Ma'am, we are live now. Good to go, ma'am.
Yeah. Good morning, everybody. Can you hear me?
Yes, ma'am, we can hear you.
Reshma, can you hear me?
Yes, ma'am. Yes, we can hear you.
Yeah, I'm starting. Good morning, everybody. It is my pleasure to welcome all the speakers and the delegates today for the Stroke Symposium 2021. I welcome all the eminent neurologists from across the country to share their vast knowledge and experience in the field of stroke. I would like to congratulate and thank all the speakers and delegates for rendering their remarkable services during this tough phase in the global pandemic. The crux of this conference is to bring about the latest updates and recommendations in the field of stroke. Also, an emphasis on the latest advances and ongoing research, enabling each one of us to expand our mental horizon and keeping abreast of the newer and modified recommendation. I welcome you all once again to this comprehensive stroke workup. Thank you. Now, Reshma, you can start.
The session is at 9 a.m. No, I think the speakers have to, the delegates have to join. So I think if we start, they might miss. So we will wait for 5 minutes to allow all the delegates to join. Mr. Sahu, if you can please tell us, or whoever is there in the technical team, how many people have joined so far in the viewers link? How many of them have joined? If you can please tell us based on that. Who's there with us in the technical team? Hello? Please unmute yourself and help me out with this. Please let me know how many delegates have joined so far so that we can consider starting the session.
Ma'am, presently it's showing 13 participants has joined till now, ma'am.
So I think because 9 a.m. was the schedule.
Yeah, ma'am. Yeah, ma'am. Yeah, ma'am. We'll just wait for some 5 minutes, ma'am. So I'll say my colleagues to again give a call to everybody, ma'am.
Yeah, Dr. Revan Jaiswal is our first speaker. He's ready. He's there with us. He's ready. I just had a conversation with him. He's there with us. So,
okay, ma'am. Okay. Just give me 5 minutes, ma'am.
Yeah, sure. Sandhya ma'am, आप ना फिर से एक बार आप बोल दीजिए ना मैम, मतलब अराउंड मतलब 1 minute to 9. 1 minute to 9.
See, 9 o'clock sharp will start. So around 8:59 I will tell. That is fine. It is only 1 minute.
हाँ वही मैम. तो अपन एक बार what happened? Sandhya
I
ma'am?
can see some. Are we sharing our slide?
No, why?
Because
Yeah, Reshma. Yeah, tell. Good morning. On behalf of organizing chairman, it is my pleasure to welcome all the speakers and the delegates today for the Stroke Symposium 2021. I welcome all the eminent neurologists from across the country to share their vast knowledge and experience in the field of stroke. I would like to congratulate and thank all the speakers and delegates for rendering their remarkable services during this tough phase in the global pandemic. The crux of this conference is to bring about the latest updates and recommendations in the field of stroke. Also, an emphasis on the latest advances and ongoing research, enabling each one of us to expand our mental horizon and keeping abreast of the newer and modified recommendations. I welcome you all once again in this comprehensive stroke workup. Thank you.
Ma'am, you're mute. Ram, ma'am, you're mute. You have to unmute.
Okay. A very good morning to the speakers and delegates. I welcome you all once again to this interesting teaching program. I welcome you to the first session. The first session will be in between 9 a.m. to 11:30 a.m. I request all our delegates to post their questions in the chat box, and the questions will be taken at the end of each session. Now, I'd like to introduce our first speaker for the first session, Dr. Revan Jaiswal. Dr. Revan Jaiswal has done his DEM, MRCEM, Fellowship in Diabetology, Cardiology, and Ultrasonography. He is the Senior Consultant and Head of the Department, Emergency Medicine at Princess Esra Hospital, Deccan College of Medical Sciences, Hyderabad. He is known to be extremely dynamic in his emergency management skills. His areas of expertise are pediatric emergencies and critical care. Dr. Revan Jaiswal, sir, I welcome you to start your session.
Thank you, Dr. Rinda, for introducing me. A very good morning to all of you. So, my topic for today is triage in emergency room of stroke. So I've been given 10 minutes to talk on what we do in ED for 60 minutes. Acute stroke. WHO defines stroke as sudden onset focal neurological signs of presumed vascular origin lasting longer than 24 hours or causing death. It accounts for 11% of all deaths and is a significant cause of morbidity. Initial patient triage in the ED can be broken down into several fundamental steps. It begins with early recognition of stroke patients and distinguishing these cases from stroke mimics. Recognition at pre-hospital happens with Cincinnati pre-hospital stroke scale and Los Angeles pre-hospital stroke screen. Distinguishing stroke patients from stroke mimics in ER and recognition of stroke in ER happens with the help of Rosier scale. Cincinnati pre-hospital stroke scale has 3 equally weighted components, which are facial drooping, arm drifting, and speech disturbance. Score of 1 is suggestive of stroke suspect. Los Angeles pre-hospital stroke screen has 5 criteria: age over 45, no prior history of seizure disorder, new onset neurological symptoms in last 24 hours, patient was ambulatory at baseline, and normal blood glucose. All to be yes, and unilateral weakness with any of the below. Drooping of face, grip weakness, and arm weakness is again a stroke suspect. Can I get some technical help? I'm unable to move the screen.
Sir, you can minimize it. You can minimize it again and start it again.
Not able to, it is stuck.
Actually, it must have hanged, sir. It must have hanged. Your laptop must have hanged there.
Okay.
All smooth here, sir.
Sir, Raven sir,
Yeah.
there's a dialog box open at the bottom of the screen on the right side.
Yeah. Unable to appreciate. Yeah.
Now you can start sharing, sir.
Yeah.
Yeah.
Yeah. So we recognize stroke suspects. And now next, effective pre-hospital management is crucial for stroke system of care. Managing chest compressions, airway breathing, management if required, giving oxygen if needed, perform pre-hospital stroke assessment as discussed previously, establish and record exact time when patient was last seen normal, rapid transport to closest facility capable of treating stroke, bring witness, family member if possible, alert receiving emergency department such that code stroke can be activated, check and record blood glucose to assess for hypoglycemia as hypoglycemia is a stroke mimic, check and record blood pressure as systolic BP of more than 185 and diastolic of more than 110 are contraindications for IV thrombolysis, establish cardiac monitoring and IV access and collect samples if possible in transit. Recognition of stroke in emergency room happens with the help of Rosier scale. It has 2 negative predictive components and 5 positive predictive components. Negative predictive components being loss of consciousness and seizure activity. Positive components being asymmetric facial weakness, asymmetric arm weakness, asymmetric leg weakness, speech disturbance, and visual field deficit. Stroke is likely if the score is more than or equal to 1 in the absence of hypoglycemia. Now, once an acute stroke is suspected, the next step is to distinguish acute ischemic stroke from hemorrhagic stroke. In ischemic stroke, the blood supply to an area of the brain is completely blocked, causing tissue death and neurological damage. In hemorrhagic stroke, bleeding causes disruption of blood flow beyond the damaged area. So the point to be noted here is 88% of the strokes presenting to emergency medicine department are ischemic strokes, 12% being hemorrhagic. Once diagnosed, are handed over to neurologist or neurosurgeon based on the severity and mass effect on the brain parenchyma. Then the patient is taken care in stroke unit or surgically, whatever. But 88% of the cases are open for reperfusion in the ED. For acute brain imaging, non-contrast cranial CT remains the imaging mode of choice due to ability to detect intracranial hemorrhage and cost effectiveness. 24/7 direct access to imaging on arrival at the hospital saves valuable time, and door to imaging should be achievable within 25 minutes. Now, once CT shows hypodensity or MR shows hyperintensity, the treatment options available for the patients are IV fibrinolytic therapy or endovascular thrombectomy. Now, few patients present to you beyond the window period. Window period shall be discussed a little later. So if they present to you beyond window period, CT or MR studies may be done with perfusion studies to identify the penumbra, which is the salvageable brain. Then we identify large vessel occlusions and thrombolysis with thrombectomy eligible patients. Large vessel occlusions can be identified by Los Angeles Motor Scale. Score of 4 or more than 4 is suggestive of large vessel occlusion, which would be benefited with endovascular thrombectomy. The components being facial drooping, arm drift, and grip strength. Cincinnati Stroke Triage Assessment Tool, again the components being gaze deviation, arm weakness, level of consciousness impaired. Stroke score of 2 or more than 2 is large vessel occlusion. Field assessment stroke triage for emergency destination. A score of 4 or more than 4 is 60% likely of being a large vessel occlusion. Rapid arterial occlusion evaluation, the components being facial palsy, arm motor function, leg motor function, head and gaze deviation, aphasia, agnosia. A score of 5 or more than 5 is a large vessel occlusion. It has been laid down by American Stroke Association that large vessel occlusions, if identified at the pre-hospital level, the patient should be taken to comprehensive stroke centers where all the treatment modalities are available, because recent studies are showing that endovascular thrombectomies are giving better outcomes to patients with large vessel occlusions. The final steps involve administration of tissue plasminogen activator in TPA eligible patients and notifications of neurointerventional team for consideration of endovascular thrombectomy for large vessel occlusions. Contraindications to thrombolysis should be identified by the emergency team within 10 to 15 minutes of patient's arrival to ED. The important contraindications being timing of presentation beyond 4.5 hours, age being less than 18 years or more than 80 years, NIH-SS score being less than 5 or more than 25, INR more than 1.4, platelet count being less than 1 lakh, previous stroke within past 3 months, previous intracranial hemorrhage, systolic BP more than 185, or diastolic being more than 110. Now, time is brain. Earlier reperfusion established the greater chance of reducing ischemic injury. Time window for IV thrombolysis is up to 4.5 hours after onset of symptoms in eligible patients. The stroke team should strive hard to maintain door to needle time less than 60 minutes. Algorithm with timelines. A patient arrives to ED with stroke symptoms at time 0. Within 10 minutes, the patient should be attended by emergency physician and emergency nurse. Emergency physician determines last time known normal, obtains a brief history and physical examination, identifies, very importantly, absolute exclusions for IV thrombolysis, orders a CT scan and orders labs required. The emergency nurse connects the patient to a cardiac monitor, administers oxygen if the patient is hypoxic, establishes IV access, collects blood sample, sends samples required, does a point of care glucose to rule out hypoglycemia, prepares for CT scan. All these things to be done within 10 minutes. By 15th minute, we need to activate the stroke team. Stroke team comprises of neurologist, neurosurgeon, anesthetist, radiologist, and of course the emergency team. By 25th minute, we see to it that the brain imaging is completed. And by 45th minute, the brain imaging result should be collected and the lab report should be collected such that by 60th minute, we are ready to initiate the treatment option which we have selected. So this is what we do in ER. Thank you so very much. Honored to be at this forum.
So thank you so much. It was a wonderful presentation to begin with. Thanks a lot once again. Sir, I request you to stop sharing your screen.
Reshma, a little bit increase your voice.
Now I would like to introduce the second speaker of the session. It is Dr. Aug-21 Reddy. He has done his MBBS from Sri Venkateswara Medical College, Tirupati, DM Neurology from NIMHANS, and postdoc fellowship in stroke from NIMHANS. He worked as an assistant professor in NIMHANS and currently is working as a consultant neurologist from Samatvam Neuro Center, Anantapur. He has 10 publications and 1 book chapter to his credit. He has treated over 2,000 patients with stroke and treated more than 2,500 patients with COVID. I take my pleasure to invite him. Dr. Aug-21 Reddy, please, I welcome you for the session, sir.
Good morning, respected teachers, colleagues, and dear friends. Am I audible, Dr. Reshma?
Yes, sir. Yes, sir. It is clear.
Yeah, I'm on. Okay. At the outset, I thank Sandhya Madam for giving me the opportunity to share my thoughts and also to participate in the CME. I'll be starting my presentation with the following outline. So initially, I will take up a brief case, followed by briefly about NIHS, and then few slides about aspects, and then the selection of patients for IVT, and then I will conclude. So this is a patient who comes to a casualty at 1:15 a.m. brought by relatives with a history of, she is a 35-year-old lady. She is brought with a history of right-sided weakness, facial deviation to left side, and difficulty to speak, but able to understand. Onset was at 11:30 p.m. and She is a known case of rheumatic heart disease, underwent mitral commissurectomy also earlier. Examination findings are like this: irregular pulse with normal BP and the pansystolic murmur. And neurologically, she had aphasia and gaze preference to left side with right hemiplegia. GRBS was 104 mg per deciliter. So this is seen initially by our first year resident, and then he has to call a senior person now. So this is what he tells on phone. He starts telling 35-year-old lady who had come to us onset of symptoms at 11:30 p.m. and presentation time 1 hour 45 minutes, motor aphasia, pupils, right human facial palsy, other cranial nerves normal. So blah blah blah. So detailed history. Gradually, by the time he becomes second year, he learns little better, and he tells this way. This time it is like he tells non-case of cardiac illness. Presentation time is 105 minutes, motor aphasia, right upper and lower limb weakness, and hemiplegia, and then NHS is 14, CT aspects 10, GRB is 104.
I'm sorry to interrupt you. Could you be a little loud, sir? Actually, we are unable to hear you.
Okay.
Little.
Now?
Yes, sir. It's better. Thank you.
I'll remove the headphone. Now, Reshma, am I audible now? Is it clear?
Yes, sir. Yes, sir. Initially, it was a little unclear. Thank you. Sorry to interrupt.
So, by the time the resident enters third year, we expect him to be really fast in deciding the patient and then be really clear. So, this time he says 35-year-old lady, known cardiac illness. Time is 105 minutes. NIHS is 14 and aspect is 10 and fits to the eligibility criteria. And we are taking up for IVT and EVT. This is what we have to learn over time in the residency period. So this patient was taken for IVT because she is within 3 hours, and we can see here dense MCA sign on the left side, hyperdense MCA left side, and because it was not recognized, we have done DSA and then we have referred to the intervention team. EVT was also done, and she did well. We'll start with the NIHS. NIHS means National Institutes of Health Stroke Scale. It is one of the most widely used deficit rating scale. It is most widely used because it is not only the doctors, it can be used the paramedical people, it can be used by the sisters. So if we train anybody who is well educated can use it and it can assess the scale. So more than 5 lakh healthcare professionals are certified with this now. It is gold standard in severity rating. First time it was used internationally at NINS RTPA study. It is one of the best scale to capture the neurological findings, although it has a few limitations that like very fine findings can't be recorded in that. The advantage is that it is replicable. It is good reproducibility is there. Both medical and paramedical staff will be able to assess this with good training. So there are certain principles we have to remember before we start using the scale. So the principle one is score what we see, not what you think. Imagine a patient comes to triage and we are sitting somewhere and we'll be looking at that. Some junior resident will be seeing, and you can't just take it that, okay, this may be this. No, you go examine and then you decide. This is what the finding is. So this is what I have scored. So it's very objective. Anybody can see, and the score should be the same. To score the first response, not the best response. So don't coach the patient. Sometimes in motor aphasia, slowly, when you keep telling again and again, they may utter few words and then dysarthria scoring may change, aphasia scoring may change. Only in the language testing, we should take the best response. In all other things, we should not coach them. LOC may be assessed casually while taking the history. And when we start assessing the patient, we can immediately tell loss of consciousness is there or not. Gaze in the NIHS, it's only horizontal. So don't expect that it should be perfect. It can be plus minus 2 score. It's not that it has to be everything perfect, because we are not spending a lot of time in neurological assessment, because it will definitely take more than 20 minutes for us to take a detailed examination finding. So the principle is be quick and make use of it best. Following the scores that we have to assess in NIHS, first is the level of consciousness. We'll score 0 if patient is alert, and the worst score is for coma. If patient is in coma, the score is 3. So the next one is LOC questions, where we ask the month and age in the language which patient speaks, preferably. So if patient answers both correctly, it is scored 0, and if both are incorrect, it is 2. Then comes loss of consciousness commands. So here one thing is, We tell her to open and close eyes. Second one is make a fist and let go. Both are incorrect. We score it 2. Both are correct. It is 0. Then we see the gaze and then visual. So in that we see the hemianopia. Then facial palsy. By the time we start speaking to the patient, we will analyze the facial palsy. It's very easy. So we need not specifically examine for this. Then motor arm. So if patient is able to lift the arm slightly, if he is able to lift the arm, then it becomes 3. Can't, sorry, 2. So 0 is normal, 1 is drift. She will be able to lift the arm and there will be mild drift, like conator drift. 2, can't resist gravity. 3, there is no effort against gravity. Only side-to-side movements are possible in 3. 4, there is no movement. So each limb we have to score separate. Then the limb ataxia. If it is present in one limb, you score it as 1. Present in 2 limbs, you score it as 2. Then comes sensory, language, and dysarthria, extinction, and inattention. Extinction is also, by the time we assess the language and weakness and hemianopia, we'll be able to conclude whether extinction and inattention is there or not. And language and dysarthria, if there is severe language impairment, then dysarthria should be scored bad. So by this we can say if the patient is completely normal, we'll score NIHS as 0. And if patient is comatose, maximum score actually according to NIHS is 42, but no patient gets 42 score, even if patient is comatose, because comatose patient ataxia will not be there, so it will come down, and we have to assess the language and dysarthria. We will not be able to assess them. So the problem in this, if the patient is comatose, we'll score around 38 because ataxia will be scored as 0, and then language, it can be scored anywhere from 0 to 2. Dysarthria can be obviously 0. It will be around, so 0 to 2. It can be anywhere from 0 to 2. So the score comes, worst possible score comes around 38, 39. So how do we use it in clinical practice? So if NIHS is less than 6, we say that, okay, patient may really improve, good recovery is possible in next 3 months. Patient is more than, NIHS is more than 16, we say mostly it will be poor recovery. So from 5 to 15, there will be a decline in favorable outcome by 5% for every point increase in NIHS. So as I said earlier, the predictor, it's a predictor of short-term mortality risk and dependability risk. Best possible score is 0 and worst possible is around 38. There is also one more thing that once we have charted down the score and somebody sees the score and individually if we see the rating, we can predict the pattern subtype of ischemic stroke. Like if only in limb patient has scored 4 and 4 and everything else is normal, then it should be a lacunar stroke in internal capsule. So like in this scan. If she has cortical loss and functional loss, memory issues, motor aphasia, if the patient has scored bad, then we expect there is some cortical impact. So NIHS patterns can predict the subtype of ischemic stroke in practice. So there are some caveats in NIHS before we use it. If one wants accuracy, this is not the tool. So this was initially used as a research item. So many trials have used this because it's reproducible and it can be done at medical and paramedical level. It has its own fallacies that it is not very accurate, yes, because neglect, extinction, then ataxia, memory, cognition, they are not assessed in detail. So if you want to see as a whole as a patient, this is not a tool. And left hemispheric stroke score more compared to right side because most of the times language areas are in the left hemisphere. So same amount of infarct situated in right side and left side in the inferior frontal area will cause more NIHS if it is left hemisphere and relatively lesser NIHS if it is the right hemisphere. And also in NIHS, so there is something like the weightage is more given for hemispheric symptoms rather than brainstem and cerebellum. We can see language, we can see dysarthria, we can see gross things like limb power. If the power is 0, the score is 4. But if ataxia, worst possible ataxia, we score only 2. So there is some discrepancy between the hemispheric functions and brainstem and cerebellar functions. As I said, it does not reflect accurately the coordination, the pattern of gait, the cortical sensory functions, distal motor function, memory, and cognition. So we at Nimans, so when I was PDF, we had tried with the staff, nursing staff, we had tried to do the NHS native version, because when we test the language and dysarthria and picture reading, it will be really difficult for our people, because it's from the English. It's not culture friendly, and it's not the language that our people speak. It's not the English which is commonly spoken. So either it is Kannada in Karnataka or Telugu in Andhra and Telangana. This is the cookie theft picture. If we tell this to even slightly just literates also, what is cookie? They will ask, what is this cookie? What is it written there? And also, this picture is more really culture friendly. That our people here, it's well practiced in villages that the cooking, many of them do it outside, even outside the home, and see the tree and the fruit, and the boy is falling down, and the girl is playing over there, and see the naming: spectacles, cycle, tap, chappal, key, and then chair. So these are all really culture friendly. We have to adopt this over time. These are the words that we use in NIH's original scale. The Kannada version, so little easier based on the language assessment. This is the Telugu version: Mama, Tappu, Oppu, Kalu, Katta, Vekkillu, Majjiga, Gali, Vana. So these are the words and sentences that we have adopted, so that it is really culture and language friendly, so that the assessment is more friendly and it will be more reliable for us. So before we start seeing, so in Nimhans, when we started the seeing, the course, my teacher used to say, before you start seeing any patient, you should have NIHS certification, and you should send it across to me before you have to get the certificate and send the certificate to me on mail. Then only I'll allow you to see the patient. So that was the principle followed. I hope all the residents do this, all the emergency physicians and medicine, physicians and the neurology residents start doing this NIHS certification. There are several versions in this. This is the best version. If you put search of NIHS in the Google, you will get the link, and it is NIHS's English program. There's a training in that as well as certification. So you'll get some credit points as well in that. And it's very good program, very easy one. So once you enter this training campus, it will take you along the line. So they will ask the mail ID and then information, and then you start doing the NIHS certification. It's free, and everyone has to do this before we start seeing the stroke patient. Briefly about the imaging in stroke. CT is a workhorse, whatever we have, however big our hospital is, however level of corporate setup we have, we always think, yes, CT is a workhorse, CT is a workhorse. CT along with CT angio will help us to really delineate, to solve many cases. MRI, little time taking, and if you ask in night, many institutes doesn't have the facility during the night. So even now, even I think for next 30-40 years, CT will be the main investigation of choice, especially in our country. Brief pathophysiology I'll tell, then we'll go to the proper imaging. So our normal cerebral blood flow is around 50 ml per 100 gram tissue per minute. Imagine a situation where there is a block in the artery and the amount of blood reaching is only 20 ml to 30 ml. And also imagine a worse situation where it's around 10 ml per 100 gram per minute. So at the level where 20 ml is reaching the blood per 100 gram, there will be loss of neurologic function. There will be cytotoxic edema. Initially, this is the one that happens, cytotoxic edema. In this situation, diffusion will be positive, but CT will be negative. And these are all potentially reversible. When it reaches 10 ml per 100 gram per minute and less than that, there will be ionic edema. So the initial one is cytotoxic edema, and here it is ionic edema, where sodium enters the cell, potassium comes out, and along with sodium, the water enters the cell. So intracellular edema happens. This is a time where diffusion is positive and CT is also positive, and this will be destined to necrosis. So both the cases, as soon as possible, intervention has to happen. And if the edema is ionic edema, this tissue is destined to necrosis. We may really not save much of this tissue, even if we do intervention. So what are the early ischemic changes? So before we come to aspects, these are the basic things. So when there is initial part of cytotoxic edema where diffusion is positive and CT is negative, and the border between the cytotoxic edema and ionic edema. During that pathway, we'll see the early ischemic changes. So these are the common things. Insular ribbon sign. So in this first scan, we can see left side. So left side, we can see the insula, and right side, we are not able to see very clearly. Insula is hyper. It should be hyper in the CT. Lentiform nucleus should be hyper. Caudate should be hyper. White matter is hypo, and gray matter is hyper. So insular ribbon sign is very early marker because when the occlusion is at the proximal M1, the vessels from MCA supply the insula. They are the most terminal part. So when the block is happening at the proximal MCA, the most affected region is insula. It is arterial watershed zone. So that is what is the first area which gets affected in large vessel occlusion. The insular ribbon sign is really early sign. We have to check for it. And there will be obscuration of the lentiform nucleus. Here we can see left side lentiform nucleus is not clear. Right side we are able to see. And then loss of gray white differentiation and hyperdense artery sign. So right MCA looks hyperdense here. So it's a topographic aspects is from Alberta stroke program early CT score. It's a topographic scoring system which has 10 regions. It doesn't give equal weightage. Even for smaller structures, it is given one score, and in larger areas also it gives one score. Like I said, internal capsule is really small, but the problem is if the infarct is sitting internal capsule, patient really has a major disability. But it doesn't happen if it is in M1 or it is in M3. Or sometimes they may have from the caudate. So, but the scoring is similar. It's all 1-1-1. Caudate. So 2 levels we have to take. First level is ganglion level. Other one is supraganglionic level. In the ganglionic level, we'll see caudate has 1 score. Lentiform has 1. Internal capsule 1. Insula 1. M1 1. M2 and M3. So 6 score comes from the ganglionic region. And supraganglionic region, we get M4, M5 and M6. So 3 regions. Let us come to window adjustment. So these are the 3 patients who come to casualty with different neurological deficits. See the first scan, it looks almost, yes, there is mild difference here from the right hemisphere, left hemisphere, we can see the sulci effaced. It's more clear in this window. And next day you see that it's infarct here. And even the second scan, you see there is mild difference from the right lentiform, left lentiform looks little hypodense. More so obvious here in the left side. And it is clearly seen in the MRI after 1 day. Even the third patient, so right caudate looks hyperdense, but left one, it doesn't look so hyperdense. And even lentiform looks clear here, it's not so clear here. The left MCA entirely gone. So here comes the window adjustment, whether it's really required or not. Alberta group has not mentioned that anywhere, but later on when people start reviewing the data and then studying more and more, it is better. They say that you sit in the console, you sit in the original console where source images are there, you change the adjustment, you adjust the window. It can be 40-40, but new machine, sometimes it is 70-20. It depends on the machine. So you have to adjust the window and then you decide where the gray white differentiation is better seen, and then you commit for the aspects. So highest score is 10, and that is normal, and 0 if the entire MCA territory infarct is there. So who are the eligible patients? Ideally, aspects is at least 7. At least 7, it is good. But guidelines till 6, yes, you can try. Till 6, you can try. Most of the 6 were failures when we had referred earlier to the intervention team. But 7, 8, 9, 10 really do good. So guidelines say, yes, you take from 6 to 10. Some of the guidelines now say even 4, 5 can be tried, but you have to really take consent from the patient party and you have to tell them, yes, we are just trying. So if aspects is 4, they say 1 in 10, 1 in 20 may improve. So as of now, it stands that you take aspect 6. MRI aspects is obviously, it's very clear. Even in our private practice now, it's friendly because patients won't believe if you say that CT is showing that, this and that. So everyone wants it to be more clear. So MR diffusion shows it's very clear, but we lose a lot of time. We almost do, once we refer for MRI, it takes 45 minutes for MRI. So the time, the chunk of window, patient enters for a window period, but it becomes out of window. We can't really do anything after this MRI. So it's tough. Yes, if institute has a protocol that you do within 10-20 minutes, it may help. So as we go on now, from CT aspects, now the current scenario is CT angio aspects is better. They say angio aspects is better because the contrastization of parenchyma is seen in the areas where there is no evolved infarct. Like in this patient, we see CT at admission, it looks grossly normal. So everybody says aspects is around 10. There is maybe there is a doubt at insula, but it looks 10. You see the CT angio, there is a stark difference here. The contrastization of parenchyma is very less in the right side. Right caudate looks, there is no vessels only in this. And you see the right lentiform nucleus. Left lentiform is clear, right lentiform, there is no contrastization. So 1, 2, and probably there is a doubtful area of insula. So I would say it may be 7 or 8. But ultimately, after 24 hours, if you see whatever we see in the CT angio, it is reflected in CT after 24 hours, where you see that caudate is gone, lentiform is gone, insula is gone, and M2 is also gone. So, CT angio aspect is more reliable than CT aspect. So for this also, we should go to the source image. We should see the console, sit in the console, see the source image, adjust the window so that gray white differentiation is better seen, and then you commit to yes, this is there. Involvement of area is there. I would not pick up this patient. So it's added information in the prediction of the final infarct size, and it has a good inter-rater reliability. So coming to the topic proper, selection of patients for IVT. So here every month is crucial in casualty when a patient enters in window period, because each minute 2 million cells die. Though we have 100 billion neurons, 2 million is a very good, very high amount. So don't wait till 4.5 hours. You have to do it as soon as possible, whatever is there. But that protocol should come in hand, and we have to be with the patient and then decide. Within, as earlier sir said, the CT time should be less than 20 to 25 minutes, and door to needle time, it is 60 minutes. Now it is reduced, at least we have to try at least to 45 minutes. Door to needle should be 45 minutes. So ASAP, you should not say that, okay, we have 4.5, we'll wait and we'll just go ahead and do it slowly. So it's not slow, it should be ASAP. There are very well-defined indications, but not well-defined contraindications, because in a NIM study, what they have done, they have taken many arbitrary numbers, like ICH never should be taken. Never in life, anytime we have ICH, it's never take. Why we should not take? If there is a small chunk of ICH due to a minor trauma, somewhere
You have and for 4 minutes, 2 minutes available for your presentation, sir.
Okay, sir, fine. So then I'll go a little quick. So we need to see that the exact time of onset is the first thing we should do, and then the SR or emergency physician should go along with the patient, ask the sister to do GRBS, and then find the exact time of onset, check NIHS on the way to CT brain, and then rule out the contraindications, and then do as I said earlier, whatever contraindications were there earlier, now it is overcome by RCTs. Now many of them are really indications. Many of them have changed now. So till 3 hours, these are the entry criteria. Patient should be at least 18 years old, and then patient should have severe stroke and mild. If it is mild stroke, it should not, but disabling stroke. So the patient comes from between 3 to 4.5 hours. Patient should not have diabetes and past stroke. NIHS should be less than 25, not on oral anticoagulants, and the imaging should show less than 1/3 MCA infarction. BP, we all know BP should be less than 185 by 110, and blood glucose should be more than 50. Patient can be on antiplatelet therapy. It's not a contraindication. He can be on mono as well as he can be on dual. And if patient has end-stage renal disease, do APTT and then go ahead with the IVT. Absolute contraindication. These are the absolute contraindications. Past ICH, current ICH. Current ICH is definitely absolute contraindication. Mild non-disabling stroke, in severe head trauma in last 3 months, extensive clear hypoattenuation in CT, GA malignancy, suspected aortic dissection, intraaxial cranial neoplasm, infective endocarditis because high chance of bleed, and INR more than 1.7, APTT more than 40 seconds, PT more than 15 seconds, treatment dose of low molecular heparin received in past 24 hours, recent GI bleed, and intracranial intraspinal surgery. Some of them are absolute contraindication, but in the literature it is coming up now. Over few years, it may be removed from the contraindications list, like ischemic stroke in past 3 months. If patient had lacunar stroke involving the internal capsule or lentiform nucleus, it is not going to bleed. So we can definitely take them up, but we have to inform the patient relatives, take the consent and do it. Fast ICH, which is really minor, it may be related to trauma, it can inform the patient and take it. Direct thrombin inhibitor, do APTT, and if it is normal, yes, we can do it. Factor 10 inhibitors, do prothrombin time. If it is normal, we can take up. Platelet count less than 1 lakh is going to change now. It's an arbitrary number earlier taken. So the bleeding component may be very less chances with this amount of platelet. There are additional recommendations where they are said to be relative contraindications. So in these patients, we have to be cautious and then we have to decide based on individual patient level. If MRS is more than equal to 2, patient relatives are agreeing, yes, we can do. Dementia we did earlier, they were doing well. Seizures at onset, we had missed 2 CVT cases. So anytime you see for venous reconstruction and then take a call if seizures are there at onset. Or if hyperglycemia also can cause seizures. So blood glucose less than 50, we have to treat the hypoglycemia and then only see if deficits are persistent, then we have to go ahead with the IVT. If it is more than 400, yes, we can still do, but then the problem is collaterals are usually poor in this high sugar patient. So they may not really do well. So it's not an absolute contraindication, it's relative contraindication. Intracranial arterial dissection, it's a relative contraindication. Unsecured aneurysms, pregnancy, again, it's between the doctor, physician, and then patient party. Illicit drug use, cardiac myxoma, left atrial ventricular thrombus, extracranial cervical arterial dissection. Microbleeds less than 10, yes, it is safe. More than 10, it is 2B indication, so it's not very well recommended. Malignancy with less than 6 months life expectancy, usually we won't do. The current, along with the stroke, if patient has acute MI, you thrombolize and then refer to the cardiologist, we can do the primary intervention. In past 3 months also, earlier it was contraindicated, but now, yes, with the consent of the patient relatives, we can take it really safe. Except there, if at all there is anterior and lateral thrombus, lateral infarct in the heart. Sickle cell disease in adults, yes. Hyperdense MCI artery sign, it's not a contraindication. Most of them will go for intervention, but IVT is indicated. Do IVT and then try to do EVT. It's not opening up. So stroke mimics, it's not harmful to give for a normal MRI also. Hyperglycemia, if seizures are there, we can really give. It's not a harmful thing. It won't bleed. Nothing to worry on that aspect. So treating stroke is a procession. So all the above process should be finished in few minutes. To prepare a patient, we should have a checklist in the emergency block and carry it all the moment when stroke call comes. So we should have a proforma in hand and then move along with the patient. Patient enters the casualty, see GRBS, take them to CT, and on the way check the NIHS and check the contraindications and finish it. So NIHS and aspects are important components of stroke care. It has to be more language and culture friendly. We have to look at aspects in the console with source images and change the window setting for better resolution. Time is brain, decide fast and go ahead. Take informed consent. Definitely in this world where we have many legal concerns, we should definitely involve the patient relatives in the consent decision making. It should be patient-centric, individualized decisions. Institution protocols with a coordinated teamwork will help. Thank you.
Thank you so much, Ashok sir. I think it was a very educative and informative session, especially for all the rest. Yeah, thank you so much, sir. Sir, I'd like to request you to stop sharing the screen.
Sure.
Questions will be taken at the end of the session, sir. We have some questions for you, which we'll take at 11:20 a.m.
Okay.
So, please stop sharing your screen, sir.
Yeah. I have stopped the sharing.
Can you please do it again? Fine, thank you. I take a pride pleasure in introducing the next speaker. She's our Sandhya ma'am, Dr. Sandhya Manoranj. She did her MBBS from Trivandrum Medical College, graduated in 1998. She did her DNB General Medicine from Chaitram Hospital and Research Institute, Indore. She did her DNB Neurology from Apollo Institute of Medical Science and Health City, Hyderabad. She is currently the head of the Department of Neurology at Deccan College of Medical Sciences, Hyderabad. She has received Dr. Sam G.P. Moses Gold Medal for DNB General Medicine in the year 2004, and she is the recipient of award for Best Paper in Stroke in INCON 2019. That is Dr. G. Arjun Das and Dr. K. Jagannath Award. She has to her credit More than 30 publications and 3 book chapters. Areas of interest are stroke, epilepsy, movement disorders, and demyelinating diseases. Dr. Sandhya ma'am, we invite you with pride, pleasure. The stage is yours.
Yeah, Reshma, thank you for the nice introduction. Am I audible?
Yes, ma'am. Clear, ma'am.
Slides. 1 second. Good morning, everybody. I've given 4 topics. That is diagnosing stroke, definitions, stroke mimics, and the TOST classification. It is a more of a theory topic, but I will try to make it as simpler as possible. Now coming to the diagnosing stroke, an accurate diagnosis of ischemic stroke or TIA and hemorrhagic stroke is essential for justifying and optimizing stroke prevention. There are 4 tools for the diagnosis of stroke. They are clinical diagnosis, radiographic diagnosis, neuropathology, and serum biomarkers. Now coming to the clinical diagnosis of the stroke. So there are 3 questions to be answered at the end of the clinical history. Is the process vascular or a stroke-like mimic? If a vascular process, then where in the CNS is the abnormality and which blood vessels supply that area? And what is the disease mechanism, whether it is ischemia or it is hemorrhage? If it is ischemia, whether it is large vessel atherosclerosis or it is cardioembolic or it is Lacuna stroke or any other etiology. The physical findings that help in identification of the stroke mechanism are elevated blood pressure, cardiac enlargement or murmurs, and vascular fluids. The retinal infarction is a clinical diagnosis. When a patient presents with acute painless vision loss, definitely we need to examine the fundus. And in the fundus, we see that typically the pallor appearance of the disc. In addition to that, we have to look for the cherry red spot in the macula region. So this is the slide showing the central retinal occlusion, and which is the clinical diagnosis we can make with this condition. To further confirm this retinal infarction, sometimes fluorescent angiogram is needed. Now coming to the radiographic diagnosis of stroke, confirmation that the patient had a stroke and not a stroke mimic required the radiology investigations. There are multiple modalities of investigation. The next speaker will deal with that. Now coming to the MRI brain. The slide shows the fast stroke MRI screening protocol. By using this screening protocol in the emergency department, that is radiology department, within 8 minutes, we are able to identify whether there is permanent tissue injury or the viable tissues are there. Now coming to the radiographic diagnosis of the stroke in the spinal cord. Imaging evidence of vertebral body infarction adjacent to a cord signal abnormality on MRI is a specific indicator of ischemia and a useful confirmatory sign. This is the MRI picture showing T2 hyperintense lesion. Such hypertension lesion can be there also in other inflammatory conditions. And here you can see the vertebral body involvement. Infarction is there. And this is the axial section showing the vertebral body infarction along with the atherosclerotic plaque in the aorta. So this confirms spinal cord infarction. This is a very important sign. Now, next is the neuropathological diagnosis of the stroke. Usually, we doesn't depend upon the neuropathology because we diagnose clinically and by radiological, but some knowledge should be there of about the cerebral infarction. And this is the eosinophilic and hematoxylin staining showing increased eosinophilia of the neurons and vacuolization of the neuropil. This is typical, that is chronic scar is there with adjacent pial and subpial surface not affected or it is spared. And this is the infarct and this is the chronic cystic lesion. But neuropathological evaluation of the brain remains the definitive means to detect ischemic necrosis or infarct. However, in modern era, its role is diminished. Now coming to the serum biomarker as a modality to diagnose stroke. The commonly measured markers are S100B, glial fibrillary acidic protein, BNP, and matrix metalloproteinases. But none of these substances are routinely measured by hospital laboratories, but they are a focus of clinical research. Now, this is the algorithm for evaluating patients with a clinical diagnosis of stroke for the purpose of optimizing prevention of recurrent ischemic stroke. So what are the class 1 recommendation investigation needed for diagnosis of ischemic stroke? Those marked with the green are class 1 recommendation, that is CT scan or MRI, ECG and other basic laboratory tests. And third is the non-invasive carotid imaging. And fourth is the prolonged ECG test. Now coming to my next topic is definitions. Introduction, TIA definitions, types and stroke definition. Now stroke, something about the history. Stroke was first introduced in medicine in 1689 by William Coley. Before that, it was termed as apoplexy by Hippocrates, that is in 400 BC. Now coming to the definition of transient ischemic attack. It is changed from time-based to tissue-based. The traditional definition of TIA was a sudden focal neurological deficit of presumed vascular origin lasting less than 24 hours. Now, the newer definition is a transient episode of neurological dysfunction caused by focal brain, spinal cord or retinal ischemia, but without acute infarction. For practical purposes, the newer plus duration lasting for 24 hours is taken. A TIA typically lasts less than an hour, often minutes. Now coming to the case, a 53-year-old man presented with an episode of tingling and clumsiness of the left hand lasting for 5 minutes. That means it is a TIA, left-sided TIA. So the MRI showed diffusion restriction in the right precentral gyrus region. So patient presented with TIA, but there is infarction in the MRI. So it is no more called as a TIA. It is an acute cerebral CNS infarction. Now coming to the second case, a 82-year-old man presented with 2 episodes of aphasia, one lasting 30 minutes and other lasting 15 minutes. And this is the MRA where diffusion weight imaging does not show any infarct, acute infarct, but TIA presentation is there. And this is a perfusion CT imaging showing hyperperfusion of the left MCA territory. So it is not infarct, but TIA-like presentation, still we call it as TIA because there is no tissue damage. Now coming to the types of TIA. 3 types are there based on the pathophysiology, that is embolic TIA, lacunar TIA and large artery TIA. Embolic TIA may be from artery to artery or due to cardiac to aortic, or it can be unknown source. Now next is the stroke definition. Stroke is classically characterized by as a neurological deficit attributed to acute focal injury of the central nervous system, but by a vascular cause, not a non-vascular cause, and that includes cerebral infarction, intracerebral hemorrhage, and subarachnoid hemorrhage. Now, coming to the definition of CNS infarction. CNS infarction is a brain, spinal cord, or retinal involvement, death either due to ischemia. It is based on 2. It can be either pathological imaging or objective evidence or clinical evidence. But if you're taking the clinical evidence, the symptoms should persist at least for more than 24 hours and other etiology should be excluded. This is the picture. So here, right MCA territory is infarct is there in the CT scan, and then pathological abnormality. Either one you can take, or this can be stroke or clinical features. That is BFAST. Everyone know that. Now coming to the silent CNS infarction. Silent means silent. There is no clinical signs and symptoms, but there is radiological evidence of tissue damage. Then we call it silent infarction. That is by the CT scan or by the pathology. Now coming to the definition of stroke caused by intracerebral hemorrhage. That is rapidly developing clinical signs secondary to intracerebral hemorrhage. This intracerebral hemorrhage can be either brain parenchyma or ventricular system. Now coming to the definition of stroke caused by subarachnoid hemorrhage. That is same, rapidly developing signs of neurological dysfunction and or headache. That is an important point, secondary to subarachnoid hemorrhage in the brain or spinal cord, not due to trauma. This is a picture showing subarachnoid hemorrhage. Now coming to the definition of silent cerebral hemorrhage. It is similar like silent CNS infarction, where patient doesn't have any clinical signs and symptoms of stroke, but there is imaging evidence of bleed. In this case, we can see left bleed is there in the deep gray matter structure, and this is the pathology. Now, definition of stroke caused by cerebral venous thrombosis. So here, infarction or hemorrhage in the brain, in the spinal cord or retina because of the thrombosis of the cerebral venous structures. That is called CSVT. Now, the last entity is definition of stroke not otherwise specified. An episode of acute neurological dysfunction presumed to be caused by ischemia or hemorrhage persisting more than 24 hours or until death, but without sufficient evidence to be classified as one of the above. So it is called as acute neurovascular syndrome. Now, this is a flow chart depicting decision tree for determination of a cerebral vascular event definition, which I have mentioned earlier. So, for defining the cerebral vascular event, there should be focal arterial ischemia. Now, two sides, that is, one is symptoms and one is pathological or imaging evidence. If the patient is having symptoms, then you have to think whether it is more than 24 hours. The more than 24 hours means it itself fits into CNS infarction, even if the imaging is negative. Now, next is if the symptom lasts less than 24 hours, then two possibilities are there. That is TIA, where CT scan or imaging, other imaging modalities are negative. That is TIA. Another is that if the patient is having symptom either more than 24 hours and less than 24 hours, and there is evidence of the imaging abnormality, then also we label at ischemic stroke or CNS infarction. The last is the silent CNS infarction, where the patient doesn't have any symptoms, but imaging show abnormalities. Now, coming to my third topic, that is stroke mimics. I will discuss about
you have another,
process.
excuse me, madam, you have another 5 minutes available for you.
Okay, mnemonic and case weakness and stroke chameleon. Now, stroke mimic resembles like a stroke, but it is not a stroke. Stroke mimic is a major diagnostic challenge and it accounts for 1/3 of the acute stroke admission. These are the common stroke mimics: seizures, syncope, migraines, space occupying lesions, metabolic condition, functional disorders, and demyelination. Now, I have made a mnemonic for stroke mimic, that is HEMI. For PGs, H for hypoglycemia, hyperglycemia, hypothyroidism, hysterical convulsion reaction, E for epilepsy, M for multiple sclerosis, migraine, other metabolic condition, and I for infections and intracranial tumors. This is a chart showing the clinical characteristic of different differentiating stroke from stroke mimic. Various features are there: age, level of consciousness. Based on this, even imaging and EG, we can differentiate between stroke and stroke mimic. Now, coming to the case vignette, a 65-year-old female presented with sudden onset expressive aphasia. And this is the CT. And the MRI also did not show any acute infarct. So we diagnosed it as a TIA and discharged her. Then she developed recurrent similar episodes. At that point, we did CT perfusion images. And this is the images showing increased blood supply at the left frontal region. That is, CBV is increased and cerebral blood flow is increased. So this is a stroke mimic. That is focal seizure presenting as stroke. And now coming to there are certain selected diagnostic scales to help differentiate stroke mimics, which has been already discussed by our first speaker. Now we have to attend the importance to be given to the Rosier scale. It is an important scale used to distinguish suspected stroke and stroke mimics. So if a score, there are 7 points are there. If the score is more than 0, that is 1, stroke is likely. If the score is less than or equal to 0, stroke is unlikely, but not completely excluded. So in patients with TIA, there won't be much clinical symptoms. So we need to do additional ABCD to scoring. Now, what is stroke chameleons? Stroke chameleons are actually stroke, but they resemble some other illness. Most common chameleons are altered mental status, systemic infection, and syncope. Now, a 72-year-old man woken up with a left foot drop. On examination, there was left dorsiflexion weakness was there with intact sensation, and he had prior history of low backache. So we made a diagnosis of left L4, L5 radiculopathy, but his MRI did not show any significant prolapse PIVD. So we proceeded with the re-examination, and we showed extensor plantar on the left and the clonus was there. So here we can see in MRI DW sequence, there is a right frontal infarct in the parasagittal region. So it is though it is a stroke, presentation is left foot drop. So it is like a chameleon. So this is a case of left cortical foot drop presenting as stroke chameleon. Now coming to my fourth topic is toast classification. It was given by Harold P. Adams et al. In 1993. It is a classification for subtype of ischemic stroke. It is the etiological classification, and it is prepared using clinical feature and ancillary diagnostic studies. Now, this is a 5 TOS subtypes: large artery atherosclerosis, cardioembolism, small vessel occlusion, stroke of other determined etiology, stroke of undetermined etiology. In undetermined etiologies, 2 or more causes identified, negative evaluation, and incomplete evaluation is the undetermined etiology. Now, they again divided whether it is probable or it is possible diagnosis. In probable, all the features are consistent with one subtype of ischemic stroke. In possible, they could not do all the studies, but there were certain features. That is, diagnosis is made when the clinical finding and neuroimaging data suggest a specific subtype, but other studies are not done. Now, this is a chart showing the important chart for the features of TOS classification, that is clinical. Should go cortical or cerebral dysfunction, can be there, clinical present in large artery, cardioembolism, even in other cause. In Lacunar syndrome, the location will be in the subcortical or brainstem. So presentation will be like that. And even in TOST 4 also can have subcortical or brainstem location and presentation. Now coming to the imaging. Imaging can be divided into whether the infarct is more than 1.5 centimeter in the subcortical region or it is less than 1.5 centimeter. If it is less than 1.5 centimeter, you make a diagnosis of lacunar stroke. If it is more than 1.5 centimeter, then other strokes to be considered. Now attention to one point. See, in the type 4, that is non-atherosclerotic vasculopathy, both lesions can be more than 1.5 centimeter or less than 1.5 centimeter. Now next test is the stenosis of extracranial internal carotid artery, that is more than 50%. That is a feature of large artery atherosclerosis. Then next, cardiac source of emboli can be there in cardioembolism, and other abnormalities such as non-atherosclerotic vasculopathy, hypercoagulopathy, or other hypercoagulable state can be seen in type 4. So this is a sources of cardioembolism, various list. Now certain clinical clues: sudden onset to maximal deficit less than 5 minutes, decreased level of consciousness, isolated cortical features, spectacular shrinking deficit, and onset of symptom after valsolar provoking activity are the features of cardioembolism. Evidence of radiological clues are evidence of at least one cardiac source on the echo, and the MRI is important because we can see the cortical involvement and wedge-shaped infarct. Multiple infarcts can be there, multiple tertiaries can be there, even hemorrhagic conversion can be there. This is the angiogram showing immediate MCA cutoff sign, which is a feature of cardioembolism. Now, a case, a 65-year-old man, diabetic and hypertensive, presented with right ataxic hemiplegia. And CT scan showed left thalamic infarct, and MRI also showed. And the size of the lesion was less than 1.5 centimeter. Rest of the investigation normal. So this indicates lacunar stroke. Another case, a 39-year-old woman, 3 years after stroke, preceded by TIA, present to OPD with left-sided TIA again. And this is the CT scan showing hypodensity in the right parietal and temporal, occipital and temporal region. The rest of the cardiac workup and ancillary test, even the carotid study was negative. Now this is the imaging angiogram. There is no signal from either of the ACA, MCA, and collateral vessels were not much visible. So it is Moyamoya disease, Suzuki grade 5 and 6. So this is TOST 4. Now what is the scope? Advantage, widely used, simple, logical, practicable. Disadvantage is that more of a type 4 type subischemic strokes are there. That is undetermined by around 40%. Now what are the other classification system available for ischemic stroke type? That is TOST, CIS, Chinese Ischemic Stroke Scale, Sparkle Scale. Among them, the TOST is seeing more of a undetermined etiology. So CIS and Sparkle has lower type 4 subtype of TOST subtype. Now take home message: diagnosing stroke depends mainly on clinical and radiological modality. Look for vertebral body infarction in spinal cord infarction. TIA definition has changed from time-based to tissue-based, but for practical purpose, duration of 1 hour or less are typical of TIA. Stroke mimic resemble like stroke, but they are not stroke, while stroke chameleons are actually stroke, but does not resemble like stroke. Rosier scale is an important scale to differentiate stroke mimic from true stroke. Then TOST classification, 5 subtypes, etiological classification, and is simple and logical. Thank you. This is my team.
Thank you so much, ma'am. I think you have comprehensively covered such a vast topic. Actually, there were 4 subtopics. It was a very, very informative and educative talk. Thank you so much. It has always been a pleasure to listen to you. I request our delegates to post their questions in the chat box. The questions will be taken at the end of the session. Now, ma'am, I request you to please stop sharing your screen.
Yeah, I stopped share.
Now I take the pleasure in inviting our next speaker, Dr. Shravan Kumar Marupaka sir. He did his MBBS from Kakatiya Medical College in 1985, and he has done his diploma in radio diagnosis from NTR University in 1991, Usmania Medical College. He did his DNB radio diagnosis from National Board of Examinations in 1992. He has a very vast experience of 36 years in this field. And he is currently working as an associate professor in the Department of Radiology in Deccan College of Medical Sciences. He has multiple research papers to his credit. Sir is academically extremely active, one of the most favorite of all the students. Sir, I welcome you to the session. Sir, please take over, sir. Sir, Shravan sir, are you there with us? Sir, please unmute yourself, sir.
Yeah. You're able to hear me?
Yes, sir, we can hear you, sir. A little louder,
Yeah.
sir.
Yeah.
If you could please be a little louder.
Okay. My topic is about imaging of stroke, and my presentation, instead of involving a lot of protocols for imaging of stroke, it's more of, I'll show you a lot of aunt minis. So this is first thing is how to differentiate bleed from infarct. Basically, on CT, bleed is hyperdense and infarct is hypodense. Then this is the hyperdense MCA sign or hyperdense vessel sign. It is the earliest sign in cases of ischemic stroke. It has got high specificity and high sensitivity. There is good correlation between the density of the vessel and the thrombus volume on CT angio. It's a reversible sign, and it is associated with poor clinical outcome, large volume strokes, and severe neurological deficits. And those with hyperdense artery sign are less likely to have rapid neurological recovery than those without the sign. Now here I show you the hyperdense basilar artery sign. This could be very important in unconscious patients. Sometimes recognition of the hyperdense basilar artery may lead to thrombolytic treatment in an unconscious patient. This is the case of top of the basilar artery syndrome. And if we see that hyperdense vessel sign on a bone window, think that it is a false positive appearance. Hyperdense vessel is not seen on bone window. Then this is next early sign of the ischemic stroke. It's already shown by other speakers also, the insular ribbon sign. Here we see slight hypodensity. The definition of the lentiform nucleus and caudate nucleus from internal capsule is not clear here. We can't even see the insula. It is better seen on, it is hyperdense on right side and it is ill-defined on left side. This is the second earliest sign in case of early ischemic stroke. So here we see atrophy of the left frontal region with enlarged CSF spaces in the surrounding region. This is a chronic infarct with atrophy. This is one of the sequelae. And here we see this is a right PCA stroke. We see hypodensity with almost CSF signal. This is a chronic infarct with encephalomalacia. Here we see gyriform calcification of the chronic infarct. This is a case with dystrophic calcification of the chronic infarct. This is the classical appearance of a fresh infarct on MRI. What we see is the classical finding is restricted diffusion. Restricted diffusion means hyperintensity on DWI and hypointensity on ADC. And this corresponding hyperintensity will be there on flare and T2. And the last change to appear is hypointensity on T1. And then there comes a question, especially when we are looking at the CT scans, whether a given hypodensity is cytotoxic edema or vasogenic edema. On a plain scan, we can usually, cytotoxic edema usually involves the cortex and vasogenic edema involves the subcortical white matter generally, but sometimes it can be really difficult to differentiate on a CT scan or conventional MRI scan. So we need to do DWI, where cytotoxic edema shows restricted diffusion and vasogenic edema shows facilitated diffusion. What we see here is in the flare image, we see hypointense signal, nearly CSF signal with surrounding hyperintensity. This is the appearance of gliosis or chronic infarct. It shows CSF signal on T2 and T1. This case has got loss of internal carotid artery flow void on left side. This is the normal flow void on right side. This is a 3D TOF angio source image where we don't see any flow in the left internal carotid artery. This is the MIP image of the MR angiogram. We don't see the left internal carotid artery. So this case is a chronic infarct with left ICA block. This is a case of recurrent stroke where we see both a fresh infarct and a chronic infarct, restricted diffusion and facilitated diffusion in the same case of recurrent stroke. We see complete block at the proximal MCA. This is a case of gyriform T1 hyperintensity associated with some changes of gliosis here. This is laminar cortical necrosis. Gyriform T1 hyperintensity is the radiological sign of laminar cortical necrosis. It indicates extremely poor prognosis. See, here we see the hyperintensity on T2 and flare with restricted diffusion. This is small, less than 1.5 centimeters. This is a case of lacunar infarct in right thalamus. What we see here is in diffusion weighted imaging, there is hyperintensity. ADC shows hypointensity, but there are no corresponding changes on flare or T2. So this is hyperacute infarct. On next day on CT, we can see clear-cut hypodensity in the involved region. What we see here is bilaterally symmetrical paramedian thalamic restricted diffusion with corresponding changes on T2 and flare and even on T1. These are acute bilateral thalamic infarcts. Then we see diffusion hyperintensity, ADC normal, but corresponding T2 and flare hyperintensities. This is a situation called pseudo normalization of ADC. This is in subacute infarcts, generally after 5 days. It also shows some blooming on SWI with hemorrhagic transformation. Here we see a ring enhancing lesion in the territory of left superior cerebellar artery with corresponding restricted diffusion on DWI. So we have to be careful about these ring enhancing lesions. Not only tumors and infections, it can also be seen in subacute infarcts and subacute hematomas also can produce this ring enhancement. The clue to the diagnosis is the restriction to a particular territory and restricted diffusion. And what are the features of contrast enhancement in infarcts? It can show intravascular enhancement, parenchymal or meningeal enhancement. Usually it is peripheral enhancement between 1 to 4 weeks, but it can start as early as 24 hours and can stay for several months. Sometimes the appearance on contrast is the only evidence of an infarct, though we don't do contrast in all cases routinely. In doubtful cases, it is indicated. Now coming to different territories of acute infarcts. Here is the middle cerebral artery territory, the caudate, lentiform, internal capsule, and the frontal temporal regions. This is the middle cerebral artery. Here we see frontal parasagittal involvement. This is ACA territory. Here we see involvement of the caudate. This is the medial lenticular striate artery and the frontal parasagittal. This is the territory of orbitofrontal and frontopolar arteries of ACA. Here we see involvement of the total internal carotid artery territory, including ACA and MCA, whereas this PCA territory is spared. This is the same case, T2 weighted image, we see loss of flow void in the left internal carotid artery, indicating thrombus. This is the right PCA territory, involving the thalamus, posteromedial temporal, occipital parasagittal, and ipsilateral half of the splenium of corpus callosum. This patient also shows blooming on SWI. So this is hemorrhagic transformation with acute PCA infarct. Here we see restricted diffusion in the posterior limb of internal capsule. This is a case of anterior choroidal artery territory infarct. Here we see left frontal restricted diffusion and also involvement of posterior and anterior junctional zones and the centrum semiovale bilaterally internal junctional zones. This is an embolic or junctional zone infarct with again hemorrhagic transformation. This is a summary: ACA, MCA, PCA, and junctional zone infarcts. Now here we see a restricted diffusion in the posterolateral quadrant of medulla. This is lateral medullary infarct with hemorrhagic transformation. Here, what we see here is T2 hyperintensity, an infarct in the pica territory with loss of flow void in the pica. This is the normal flow void. This is the loss of flow void. Even on 3D TOF, we see no flow in the pica here. Here, the same case, the thrombus can be directly visualized on SWI. This is a case of restricted diffusion in bilateral thalami. In other sections, the other thalamic involvement is seen. We also see the involvement in bilateral occipital parasagittal regions, bilateral cerebellar hemispheres, and both halves of the pons. This is a case of top of the basilar artery syndrome. We don't see basilar artery on the angiogram. This is a case where, as I have shown you before, there is an evidence of infarct with atrophy, and again area of gyriform area of restricted diffusion in the right frontal region. So acute and chronic infarcts in the same case associated with multiple collateral arteries. So this is a case of moya. This is the 3D TOF source image where we don't see flow in the major vessels in circle of Willis. This is the MIP image, shows complete cutoff of the proximal portions of major vessels associated with multiple collaterals. Then coming to aspects has already been described, but It is an important concept. So it is basically Alberta Stroke Program Early CT Score. It's a 10-point quantitative topographic CT scan score. The MCA territory is divided into 10 regions, each with 1 point. And 1 point is subtracted from 10 for any evidence of early ischemic change for each of the defined regions. The abnormality should be seen at least in 2 consecutive sections to avoid partial volume effect. A normal CT scan will have aspects of 10 and aspects of 0 indicates diffuse involvement of the MCA territory. And 2 standardized regions are taken into consideration. One is basal ganglionic region, another is supraganglionic region. This is the pictorial representation. Caudate, lentiform, internal capsule, and the insula are given 1 point each. And then the MCA cortex is divided into 6 regions, 3 at the ganglionic level and 3 in the supraganglionic level. And as it was told before, the window level has to be precisely adjusted to see the gray-white matter differentiation better. That roughly corresponds to window width of 45 to 35 with same window level. There are some of the limitations of the aspect scoring. It is limited to MCA territory, and it is difficult in M2 region due to streak artifacts from the base of the skull, and difficult to score watershed infarcts. Subcortical and age-related periventricular white matter changes lead to incorrect scoring. Motion artifacts lead to incorrect scoring, and it is least reliable in the first 90 minutes from symptom onset because parenchymal changes perceptible to human eye may not be there during that period. And aspect score of 7 or less is associated with worse functional outcome at 3 months and with symptomatic hemorrhage. And there is moderate correlation between aspects and the CT perfusion core volume. So that is why it can be used as a surrogate marker of CT perfusion core infarct in late arriving patients with acute ischemic stroke with large vessel occlusion. In this particular set of people, it can be used as a surrogate marker for CT perfusion core volume. And DWI detects ischemic lesions significantly more frequently than CT in all aspects regions except caudate head and internal capsule. So DWI aspects may be reliable and predictive of clinical outcome than NCCT aspects, but this was rarely performed in 5 of the most recent endovascular trials. Whereas DWI aspect score of less than 6 was an exclusion criteria in both Swift Prime and Rivascat. Then we can apply aspects to SWI also. SWI, an infarct on SWI shows asymmetric hypointense cortical veins that represent ischemic penumbra, and they correlate well with perfusion parameters of raised mean transit time and time to peak. So aspects SWI and aspects perfusion weighted imaging scores show good correlation. The greater mismatch between the asymmetric cortical veins on SWI and a small diffusion weighted positive area, SWI diffusion mismatch, are more likely to have favorable outcome from reperfusion strategy or recanalization. Now I'll show you a case of SWI changes in acute infarct. This is the diffusion restriction with corresponding asymmetrical hypointense cortical veins. This is the area corresponding. Here almost there is no mismatch. They are almost corresponding equal. This is the supraganglionic level. Here we can appreciate the thrombus in the M1 segment. Then they applied aspects for posterior circulation also. In the posterior circulation, again, it is divided into, it is given 10 points. And the thalamus, the occipital lobe, and the cerebellar hemisphere are given 1 point each for each side. Whereas pons and midbrain are given 2 points. Even if unilateral involvement, we have to consider 2 points. Despite the longer time to intervention with MRI as the initial imaging modality in posterior circulation strokes, it doesn't negatively affect the functional outcome. So MRI is preferred for posterior circulation strokes. CT is not good there. So the posterior circulation aspect score on MRI can accurately predict the functional outcome. The score more than 7 on MRI is a helpful cutoff for favorable functional outcome prediction in posterior circulation acute ischemic stroke. And as I said before, CT angiogrammic source images based posterior circulation aspects also can predict functional outcome. Cutoff here is 8. Then there are aspects of collateral scores. Why collaterals are important? The good flow through collateral pathways is associated with larger penumbra and small infarct core at baseline. It extends survival time of penumbra, extends time window for viable reperfusion, limits infarct core expansion, and determine final infarct volume. That is why scoring of collaterals is important. It has strong correlation between regional leptomeningeal collateral score at baseline and both radiological and clinical outcomes. High inter-rater reliability. See, the scans were considered for
Sorry to interrupt you,
for,
sir. You have 5 minutes left for the presentation, sir.
Okay. The adequate scan, adequacy is considered when arteries are seen well and when there is filling of internal cerebral veins and the dural venous sinuses. This ensures complete filling of the collaterals. So this is the details of scoring. Actually, the 6 aspects cortical regions and the parasagittal ACA territory and basal ganglia. These are 8 points. And pial arteries of Sylvian sulcus is considered, is given 4 points. The total of score is 20 points here. These are some of the suboptimal scans. Here the arterial system is not seen well. And here there is venous contamination because this is the basal vein of Rosenthal. The signal intensity is more than that of the MCA. So these are considered suboptimal scans for scoring regional leptomeningeal collaterals. There is another collaterals, that is aspects collateral score based on multi-phase CT angiogram. Multi-phase CT angiographic collateral score. This is based on delay in filling and adequacy of pial vessels in the abnormal hemisphere. It is shown to be better predictor of clinical outcomes and eligibility for endovascular therapy than a single phase CT angiogram. This is the example. This is the left-sided MCA block. The good collaterals means they are seen in the first phase itself on both sides equally well. That is good. Then this is also left-sided block. Here in the first phase, the collaterals are not as well seen as on the normal side. And there is delay here. This is intermediate collaterals. And here we don't see the collaterals at all in the first phase. They appear in the second phase. This is poor collaterals. And coming to perfusion study, it's a rapid, readily available technique to identify and quantify the presence and extent of ischemic penumbra or tissue at risk, which may be salvageable with administration of thrombolytic agents. Now the latest concept is penumbra is brain. Time is brain is also applicable, but penumbra is brain is a better concept, which allows for more personalized, appropriate selection of candidates for intervention than generalized time criteria. And though perfusion study is not required for therapeutic decision making in early presenting patients, it improves diagnostic accuracy and detection of stroke mimics. This example was shown by Dr. Sandhya. It enhances and expedites occlusion localization in patients with more distal occlusions, provides early prognostic information which may aid communication to patient and relatives and help guide early therapeutic decision making. The basic principle is mean transit time is equal to cerebral blood volume by cerebral blood flow. Cerebral blood volume is defined as the total volume of blood in a given unit volume of brain. Flow is defined as volume of blood moving through given unit volume of brain per unit time. And mean transit time is defined as the average of transit time blood flows through the given brain region. Now, how do we interpret a perfusion study? This is a case of an old man presented to the emergency room with a left hemispheric syndrome. This is the non-contrast CT, showed no hemorrhage, and this is the CT angiogram, shows cutoff in the M1 segment of right MCA. Then we should look at, first we should look at the MTT scans. This is the most sensitive to detect the early stages of minor ischemia. Here we see this is the ischemic zone. Then we have to look at CBF maps. If CBF is decreased, it is infarct. Because in transient ischemic attacks also MTT can be prolonged, but CBF will be preserved. Then finally we should look at the CBV maps. CBV is decreased in infarct core, but it is preserved or increased within the penumbra. That's how perfusion study helps us to categorize infarcts into core and penumbra. These are the prognostic maps, which give, this is software gives directly the core and the penumbra. So which are the areas where diffusion perfusion scores more than CT perfusion? That is in cases of lacunar strokes, posterior fossa strokes, and in young patients. And this is an example of different software packages calculating the core volume. Here they have done with the same source images, they have applied to different software packages. When manually scored, the core volume was 7.14 here. And with different software packages, the core volume ranged from 10 ml to 61 ml. So sometimes based on one software package, the patient becomes eligible for an endovascular trail, and based on other software package, the same patient will fulfill the exclusion criteria. So we have to be careful in choosing the software package for perfusion. Now here is a case. This is infarct with the hemorrhagic transformation. This is a hemorrhagic infarct. Hemorrhagic infarct, how to differentiate it from hemorrhage is, it usually involves the caudate and also the cortex. It follows a vascular territory and it shows restricted diffusion on DWI. This is another case of hemorrhagic infarction where there is cortical involvement, areas of hemorrhage, subfalcine herniation, and also an infarct on the other side. This is one of the complications of infarct. Because of the subfalcine herniation, there will be infarct in the other hemisphere also. This is one I wanted to mention. This is a hyperacute bleed. This is one which is closely resembles acute infarct. Here we see restricted diffusion, hyperintensity on T2, intermediate signal on T1, and DWI, the SWI shows peripheral rim of blooming. And then a peripheral rim of fluid is also important to identify, because this is after clot retraction, the serum oozes out and forms a rim around the hyperacute bleed. So this is how we should recognize hyperacute bleed. In case of doubt, we have to do CT scan to detect hemorrhage. Thank you. Thanks for your time.
Thank you so much, sir. I think it was a very informative and a practical session. And it was a wonderful learning for all the residents especially. Sir, I request you to please stop sharing the screen. We'll take the questions at the end of the session, sir. We have some questions for you, but at the end of the session, we'll take them. Just sharing screen now. Okay. Now I'd like to Now I'd like to introduce our next speaker, Dr. Sapna Ira Sridharan ma'am. She did her MBBS from Calicut University and graduated in the year 1999. She did her MD General Medicine from Calicut University and graduated in 2003. She did her DM Neurology from Sri Chitra Institute. And currently she's working as the Additional Professor of Neurology from Sri Chitra Tirunal Institute for Medical Sciences and Technology. She's been a faculty since 2009. The special interests are stroke and rehabilitation, sleep medicine, and neurology in systemic diseases. Sapna ma'am has more than 43 publications and 3 book chapters to her credit. Currently, ma'am is the principal investigator of ICMR-funded project on atrial cardiopathy and acute ischemic stroke, and she is the co-investigator of Instruct Stroke Network of ICMR. Ma'am, we are all eager to listen to you. I welcome you for the session, ma'am.
Thank you, Dr. Reshma. Am I audible?
Yes, ma'am, you're audible, ma'am. Clear, ma'am.
First of all, thank you, organizers, for giving me an opportunity to present this topic. I will start the topic going through the scheme of my presentation. The science behind thrombolysis, evidence over years, how to select patients, administration of the drug and post-thrombolysis care, and the current guidelines, especially with emphasis on ESO guidelines of 2021, what is new, and what is the future of thrombolysis in the current era of mechanical thrombectomy. So, what is the science behind thrombolysis? We know that acute ischemic stroke occurs secondary to occlusion of a vessel and resulting in ischemia and tissue death. So what thrombolytic drug does, it lyses the clot, restores the blood flow to the tissue. And is it as simple as it sounds? We will explore it in the coming slides. We have first generation thrombolytic agents, streptokinase and urokinase. Streptokinase is not approved for stroke use in acute stroke use, whereas urokinase was being used for intra-arterial injections. Second generation, recombinant, using recombinant technology, recombinant tissue plasminogen activator and pro-urokinase. And third generation drugs include tenecteplase, retiplase, desmoteplase, and uteplase. So just a recap of our physiology classes. The coagulation pathway, extrinsic and intrinsic pathway, finally converts prothrombin to thrombin. The thrombin acts on fibrinogen and converts it into a fibrin mesh, which interacts with platelets, WBCs, and RBCs and forms the final blood flow. So what our thrombolytic drug does, the tissue plasminogen activator of acts on plasminogen, converts it into plasmin. The plasmin breaks the fibrin into fibrin degradation products. So this results in the lysis of clot. So what evidence have gathered over years of research? The first drug to be tried in acute ischemic stroke is streptokinase. The studies in the 1990s, MAST-I and MAST-E European studies, where the 1.5 million units of streptokinase was given over a period of 1 hour in all acute ischemic stroke patients up to 6 hours of onset of symptoms. This was primarily similar to acute MI evidence, but both the trials had been prematurely terminated due to high rate of ICH in the treatment arm. Then came the recombinant tissue plasminogen activator. The first trial to be published, 2 trials were published in the same year, 1995, ECAS-1 study, the European study, where a dose of 1.1 milligram per kilogram body weight was administered at acute stroke within 6 hours of onset of symptoms. The outcome, primary outcome was MRS at 90 days. The first study was a negative study. There was no significant difference between the placebo arm and the treatment arm, and there was a significant increase in ICH in the TPA group. But the 1995 NIMS RTPK trial, which used a lower dose of 0.9 milligram per kilogram body weight, recruited patients up to 3 hours of symptom onset, was a positive study. They found a significant improvement by at least 30% in the neurological outcome at 3 months in the TPA group when compared to placebo group. The symptomatic ICH rates was higher in the thrombolytic group when compared to placebo, but the mortality did not differ between the two groups. So this led to the approval of TPA for use in acute ischemic stroke by FDA in 1996. Since then, the TPA use has steadily increased over the last 25 years, but the rates remain still low across the world. Indian series shows that thrombolysis rate reported ranges between 5% to even up to 14% in many multi-center studies. The reasons which are proposed are many, most important being pre-hospital delays, single most important factor in most of the studies. Then delays in activating emergency medical services, suboptimal hospital infrastructure and process, very narrow therapeutic time window of 3 hours, and medical contraindications. All these contribute to the low treatment rate. So how to overcome these barriers? We know that pre-hospital delays are one of the most important significant area of research. Increasing stroke awareness and education, activating emergency ambulance services may help to some extent to decrease this barrier. Delays within the hospital by dedicated stroke care pathways and a team which manages a stroke, activating cold stroke in emergency units, and also dedicated stroke unit where the treatment, patient recognition and early treatment can be initiated at the earliest so that the door to needle time can be minimized. Extending the next way to increase the usage of drug and get more eligible patients is extending the therapeutic window. So a lot of research has gone into this area. The 2 of the main studies, earlier studies, which was published in 1998 and 99, one was the ECAS-2 study, where the same dose of TPA was given up to 6 hours of acute ischemic stroke. However, the study was negative. The very critics of this trial point out that the median NIHs of the patients recruited were 11 compared to NIM study where the NIHs was 40. This might have been the reason why the treatment effect got attenuated. The next was the Atlantis study, again recruited up to 6 hours. The primary outcome was NIH 0 to 1, MRS 0 to 1 at 30 days and 90 days. Because of the safety concerns, midway between the trial itself, the recruitment criteria was changed to less than 5 hours. However, they found no difference between the treatment arm and placebo arm. Again, the critics of this trial also say that the similar lower NIHs when compared to NIMS RTPA trial and also delayed window recruitment. Majority of the patients got recruited between 4 to 5 hours of the study could be the proposed reason for the negative effect. However, the pooled analysis of these studies, Atlantis, ECAS, and NIMS RTPA trial, where the time to treatment was specifically looked at individual quartiles, it was found that the maximum benefit was found in the first 90 minutes. That is, you can find the odds ratio of about 2.81 benefit for the treatment arm when compared to placebo. However, when you see that the time window between 91 to 180 minutes as well as 181 to 270 minutes, still there is a benefit for treatment. However, the benefit was not significantly pronounced when the patients were recruited between 4.5 hours to 6 hours of onset. So this is a Kaplan-Meier curve which shows the declining benefit with time. As we all know, the benefit is maximum in the first 90 minutes, but still the benefit is there over placebo up to 270 minutes of this symptom onset. And the next step here is whether if you recruit the patients later, the risk of bleeding increases. We know that the bleeding risk is minimal when the patient is recruited early within 90 minutes. However, the bleed risk did not substantially increase in the patients recruited between 3 to 4.5 hours and 1.5 to 3 hours. However, above 4.5 hours, it was slightly higher. So beyond 3 hours, there was a class 1 evidence already favoring TPA use within 3 hours. Even though randomized trials recruiting patients up to 6 hours were negative, pooled analysis suggested that there is a possible benefit up to 270 minutes or 4.5 hours. But the problem is that all these trials used an exclusively CT-based selection of patients for selecting for thrombolytic therapy. So is there hope for extending the window further? So these were the studies which were published in the 2000s. The first was the epithet study, which used an MR-based selection protocol for recruiting patients beyond 3 hours of symptom onset based on a perfusion-diffusion mismatch. The next study, which was a positive study, was a ECAS-2 study. Here, the ECAS-3 study, where the patients with acute ischemic stroke between 3 to 4.5 hours with a stringent inclusion criteria were selected for thrombolytic therapy, and they found that it was beneficial over placebo. The next was IST-3 study, where again an MR-based selection protocol and patients up to 6 hours of symptom onset were recruited. In the epithet as well as IST-3, even though the absolute benefit at the end was not superior to placebo, the infarct growth was much lower in the treatment arm with an acceptable bleeding risk. So there was evidence clearly favoring thrombolysis up to 4.5 hours of symptom onset. In studies using MRI with penumbral imaging, that is a perfusion-diffusion mismatch, there was benefit for reduction in infarct growth, better reperfusion with thrombolysis even up to 6 hours. And it was found that the effect was more pronounced in those with a diffusion-perfusion mismatch than those without the mismatch. So given this data, extending time window should be biologically possible, given that the penumbra can persist even up to 48 hours of onset. Now we will look at what is the evidence beyond 4.5 hours. So this is a meta-analysis which was published 2 years back in Lancet by Campbell's group, where they pooled the data from Extend, ECAS-4 and epithet investigators, where the acute ischemic stroke patients beyond 4.5 hours and up to 9 hours were recruited, as well as wake-up strokes were recruited for thrombolytic therapy. So here also in MR-based selection protocol, looking at the perfusion and perfusion mismatch, diffusion mismatch was taken, and they found that patients treated with alteplase had a better functional outcome than patients. Even though the symptomatic hemorrhage was higher in the alteplase group, it did not negate the benefit of thrombolysis. Now, what about wake-up strokes or unknown time of onset? We know that less than a quarter of strokes can present on waking up. Such patients are usually excluded from treatment with IV TPA, and only some of them become candidate for mechanical thrombectomy also. Studies have shown that a substantial proportion of strokes that are evident after sleep probably occurred in the last few hours before awakening. So they could still be within the window of IV TPA. MRI with patients of stroke with known time of onset have identified that presence of a visible ischemic lesion on diffusion-weighted imaging with an absence of flares signal intensity may suggest that the infarct has occurred within the 4.5 hours before imaging. So this is a meta-analysis of usage of IV TPA for stroke in unknown time of onset guided by advanced imaging. This was done on the behalf of evaluation of unknown onset of stroke thrombolysis trials. The Gortz-Tamala group and who had pioneered the study on wake-up strokes. So here the pool analysis of 4 of the studies where wake-up strokes and the strokes of unknown time of onset, extend, wake-up, TOS and ICA score were taken into account. They found that 47% of the all-replace group had a favorable outcome versus 39% in the placebo group. Higher symptomatic ICH and more deaths in the treatment arm, but less disabled survivors at 3 months. Selection was based on MR diffusion flare mismatch. And an interesting observation was that a significant treatment benefit was found in the subgroup of patients with large vessel occlusion also, an adjusted odds ratio 2.35. So this reinforces the importance of identifying patients for and administering TPA even in wake-up strokes with a flare diffusion mismatch, especially if you are in a center without a facility for a large vessel occlusion.
Sorry to interrupt you, madam. You have 5 minutes left for the presentation.
Okay. So other agents and evidence, I will not be going much into the details. TNK approved for use. Based on Australian TNK study and extend 1A, better recanalization rates. So it has evidence now in minor strokes as well as for bridging therapy. Now, how to select patients for thrombolysis? I have discussed about the time window. Now we have enough evidence that patients can be taken up to 9 hours of symptom onset based on tissue-based selection and also wake-up strokes. Tissue characteristics, already the previous speakers have elaborated on that. ICH should be excluded. Aspects above 7, 8 to 10 is the best candidate. Vessel imaging not mandatory, but helps in decision making, especially in the era where mechanical thrombectomy is available. Then other things to be looked for in vessel imaging, collaterals, clot length and burden, perfusion imaging. All these improves our patient selection, helps in predicting outcome and hemorrhagic risk. And the other contraindications, this has already been dealt in detail. Previously, when we were giving TPA, we were afraid of the list of absolute contraindications and hardly very few indications. But currently, the era has changed. Now we want to include more and more patients for thrombolysis after individualized decision making. So the risk versus benefit, ideal situation, patient within 90 minutes of acute ischemic stroke, moderate deficits, persistently BP less than 185 by 110 or requiring only 1 or 2 doses of levodopa to bring down the BP, blood sugars less than 180, aspects 8 or above, meaning a small core, CTA showing no major vessel occlusion, a short thrombus less than 8 millimeter, good collaterals. In them, when we counsel the patient, we tell them that ICH risk is low, around 2 to 3%. However, if any of these factors are not very favorable, then you will have to counsel them regarding the increased bleeding risk, and decision should be taken by selecting based on the risk-benefit ratio. So thrombolysis and post-thrombolytic care, we are all aware of this pathway because we have been doing this day in and day out. So emergency evaluation of acute stroke, urgent BP monitoring, NIHs, put in a 16-gauge cannula on the right antecubital vein, send draw blood from hemogram coagulation profile. But unless a patient is on anticoagulant, no need to wait for the results. Urgent imaging, once ICH rolled out and imaging is favorable with no obvious contraindications, give the bolus of alteplase or TNK. Complete the vessel imaging. No large vessel occlusion, shift to ICU for continued monitoring. Large vessel occlusion, depending upon your center's availability, shift to cath lab or to a comprehensive stroke care center with facility for mechanical. Post-thrombolysis care, strict hemodynamic and neurological monitoring. This I need not discuss in detail to students of neurology. You are all aware of that. And whenever you suspect there is a watch for headache, vomiting, drowsiness, worsening of NIHs, any early signs of bleeding, there should be very low threshold for repeating a CT. Guidelines for thrombolysis, AHA guideline update in 2019. Already wake-up strokes and the stroke of onset more than 4.5 hours based on a diffusion flare mismatch Patients can be selected for thrombolytic therapy. TNK was approved for bridging in LVO and minor strokes. ESO guideline, obviously, low dose alteplase currently is not recommended. Extended window thrombolysis, no time of onset, patients should be selected based on advanced imaging demonstrating perfusion or mismatch. Alteplase can be administered if there is only plain CT available in your center for decision making. TPA should not be administered. Wake-up strokes, again the same imaging selection criteria for deciding on thrombolysis. TNK with large vessel occlusion, there are better recanalization rates and functional outcomes, so preferred over TPA as per the European guidelines. However, if there is no large vessel occlusion and patient presenting within 4.5 hours, still TPA is preferred over TNK. What is the future of thrombolysis in the current year of mechanical thrombectomy? Stroke secondary to LVO constitutes only 10 to 11% of all ischemic strokes in community-based series. So we know that substantial number of patients still present with medium and small vessel occlusion with moderate disability. Now we have better patient selection tools by multimodality imaging, thus the window of thrombolysis have extended. Controversies regarding use of TPA and bridging is still remains, especially direct entry trial and all. However, in centers where the facility for mechanical thrombectomy is not there, even now there is evidence favoring administering of tenecteplase or thrombolytic therapy before shifting the patient to a major center. And the TNK and other newer 5-6 long-acting drugs need to be studied further. Concluding, thrombolysis still remains first-line treatment for acute ischemic stroke presenting within 4.5 hours. In some patients, this treatment is beneficial even up to 9 hours, especially if they are selected based on penumbral imaging. With careful patient selection and implementing stroke care pathways, patients can be safely treated, minimizing the risk of complications, feared complication in ICH. In patients, the LVO presenting early, even though the role of bridging is still not proven, thrombolysis should not be denied unless there are contraindications for the same. TNT holds promise in view of comparative efficacy to alteplase, longer TFR, and the ease of single bolus administration. Thank you for patient listening.
Thank you so much, ma'am, for a very lucid and elaborate presentation. It was very informative. Thank you so much. I'm requesting you to, thank you, ma'am. We have some questions which we will take at the end of the session, ma'am. Now, I'd like to introduce the next speaker of the session. Dr. Shayan Siddiqui. He has done his MD radio diagnosis and DM in neuroimaging and intervention radiology from NIMHANS. He's currently the consultant neuro and intervention radiologist in the Department of Neuroimaging and Intervention Radiology at Star Institute of Neurosciences, Star Hospitals, Hyderabad. His areas of interest are diagnostic neuroradiology, both adult and pediatric, hybrid and molecular imaging, neuroendovascular interventions, body and peripheral vascular interventional radiology, and interventional pain management. He has multiple publications and book chapters to his credit. Dr. Shayan Siddiqui, please welcome to the session. Please start sharing your screen.
Yeah, is my screen visible?
Yes, it is visible.
Yeah. So thank you for inviting me for this talk. So over next 20 minutes or so, I will be speaking on the mechanical thrombectomy today's scenario, and I will be just covering it briefly under these 5 heads. Firstly, we'll go through why it has become a standard of care from being a doubtful therapy, and then how do we select patients for offering this treatment, and what are the various techniques, and then what are the peri-procedural issues that happen with mechanical thrombectomy. And finally, there are still a lot of controversies in patient selection in today's scenario with mechanical thrombectomy. I'll just be going through it and what trials are there that will solve it probably in the future. So mechanical thrombectomy cannot be offered for all patients of acute ischemic stroke. It can be only offered to the patients who are having emergent large vessel occlusion. That is, if they have an occlusion of ICA, MCA, or a vertebrobasilar arteries, not for your other causes of stroke. So if you see that only about 3 to 22% of subset of patients of acute ischemic stroke are actually eligible for mechanical thrombectomy. However, when you offer this treatment for these subset of patients, almost 45% of them gain functional independence. And recently, they have also proven that over 3 months, there is a net mortality benefit of 17% over patients who have not been offered thrombectomy. So briefly, right, MR Clean was the first trial that showed us 2015 the actual benefit that thrombectomy is beneficial compared to patients wherein they have not been offered thrombectomy. And as the time progressed, multiple trials started pushing off the windows right from 6 hours to 8 hours to 12. And finally, in 2019 and 20, the Dawn and Diffuse trials, which are also called as the late thrombectomy trials, really pushed the window beyond almost 12 hours to 16 and 24 hours. So now mechanical thrombectomy can be offered up to 24 hours, provided the patient has a small infarct core and a good collateral reserve in a penumbra. So right, beginning from 6 hours, it almost has been pushed up to 24 hours. Just briefly regarding the initial 5 major trials that showed the benefit of thrombectomy, when they did a meta-analysis, they found that almost when you offer this treatment, functional independence can be gained in almost 40 to 45% of the patient, and the number needed to treat was very, very low, almost 5 and 2.6. So when you compare it, number needed to treat is the way you see how an intervention, judge an intervention's response. So for example, if you see a number needed to treat for a primary angioplasty in MI, it's roughly 20 to 25. Whereas for thrombectomy, to achieve an overall disability shift is 2.6, and for functional independence is 5. So it's very, very low. So, so that's how effective this treatment is. Now, if you Hermes trials, basically they evaluate, they did a meta-analysis of the initial thrombectomy trials, that is only up to 12 hours. However, if you see even in the late window thrombectomy, that is in the Dawn and Diffuse subset of 16 and 24 hours, the benefits of functional independence remain, and almost again almost 45% of the patients were able to achieve a good functional independence. So even in late thrombectomy, if late periods if thrombectomy is offered, you can sort of offer benefit to the patient. And this was a recent publication wherein they also showed a mortality benefit. Now coming to patient selection, just a take-home point is if patient has a low infarct core and good penumbra, they can be offered thrombectomy. So strict definitive indications are anyone who is above 18 years of age and up to 80 you can offer. But now recent studies have come that even above 80 and 90 people are offering thrombectomies, but you have to individualize a decision. But for the practical purposes, anyone above 18 actually can be offered thrombectomy. And then you need to see the NHS stroke scale. So anything above 6, the patient will thrombectomy can be offered. And like I said, the aspect score is the one which defines your infarct core. So either a CT or diffusion aspect, whatever you are doing at your hospital, if it is a sort of more than 6 on CT and less than 5, that means the infarct core is low, the volume is less than 70 cc. These patients will definitively benefit from a thrombectomy. And for late thrombectomies, you have to follow the Dawn and Diffuse criteria, wherein depending on the age and NHS score, they have limited the infarct cores to 30 and 20 cc. And they have basically taken the volume of the infarct core of a thrombectomy. So all in all, if the infarct core is low, that is aspect of 6 or above on CT, and more than 5 on diffusion, and NHS score is more than 6, you can offer thrombectomy to those patients. Like I said, it is mainly offered to the patients who are having large vessel occlusion, that is a thrombus in the terminal ICA or M1 segment of MCA or vertebrobasilar arteries. And low core as in the aspect between 6 to 10 and volume less than 70. And one thing that has to be seen is, which was not sort of emphasized in most of the trials, was the collateral status, except for extend IA trials. So the patients who are having a good collateral reserve, they will definitely have a low aspect score, because the the penumbral tissue will sort of be viable for a large amount of time because of the collateral status. So it's a sort of logical. So patients who are having low core will definitely have a good collateral status. So when you're taking patients for thrombectomy and also for prognostication status, collateral status is very, very important. Now, if you go for the AHA guidelines, just one thing I want to highlight is when you are doing a thrombectomy, the diagnosis of large vessel occlusion is made by doing a vessel imaging. So you have to do either your MR angio or CT angio, whatever your protocol is. And when you're doing a CT angio, you can sort of go ahead and do a CT angio even before obtaining a serum creatinine level. So already a meta-analysis has shown that a single CT angio study, irrespective of creatinine, doesn't sort of affect the kidney function much. So that's why. So even you don't have to wait for your serum creatinine levels when you are doing a CT angio for a case of acute stroke. You can just go ahead and get it done. And finally, regarding the CT perfusion and MR perfusion, that is advanced imaging, what I like to call, you are not supposed to do any of these within 6 hours. It is logically understood that if a patient is having an aspect score of more tthan 6 and is within 6 hours, he definitely has good amount of penumbral tissue. And when you offer a thrombectomy to him, he or she will benefit. And you sort of don't have to demonstrate it again on your perfusion imaging and sort of increase the time gap between the recanalization and then the patient is presented. So this is what has been recommended even in the AHA guidelines. So they have told a strict no for doing a penumbral imaging or advanced imaging within 6 hours. Whereas when the patient is between 6 to 24 hours, you can sort of do this advanced imaging, to see which patients benefit from your procedure. So this is a very basic sort of selection algorithm within 6 hours and after 6 hours. I do basically a CT angio or MR angio to localize the level of thrombus. Then if its patient is between 6 to 16 hours, you use the Dawn or diffuse criteria. So Dawn criteria basically if you have an IC and MC occlusion, you see the NHS score if it's more than 10 in 80-year-old and infarct core is less than 21 ml. For less than 80-year-old, the infarct core volume is sort of increased, so you can go up to almost 51 ml. Similarly, for the diffuse, it sort of did not take age into consideration. It did not even take NHS score into consideration. It just took the infarct core as the criteria for patient selection in late thrombectomies. I think previous speakers must have covered it. I will just go a brief. Infarct core is the one that is sort of an irreversible tissue, and around it you have hyperperspicity, which sort of can be salvaged when you do a thrombectomy. And this is so one thing, practical point I want to highlight is when you are doing your CT angio, you sort of can also see a aspect score on your CT angio. It is called a CT angio aspect score. So CT angio aspect score almost always sort of many times is almost as good as your diffusion core. So when you have a CT and CT angio, you have CT angio aspect score. If you see that volume of that infarct almost corresponds to your diffusion image. So it sort of gives you a good estimate of what is your core infarct. Yeah. Now, like I said regarding the collateral, so previously it was believed that the progression of stroke is time bound. So there is a small rider there. It is time bound, but it also depends on the collateral status. So here you can see if a patient is having good collaterals, his infarct growth is much less when compared to patients having poor collaterals. Similarly, the salvageable penumbral tissue is more in patients having good collateral. Again, it's logical. As the collaterals are good, the more and more the tissue is salvageable, the infarct progression is so. So if you have a thrombectomy, you are likely to save more amount of penumbral tissue. And even if you see with respect to time, the patients who are having good collateral, that's in blue, the infarct progression is very, very slow. Whereas in patients who are having poor collaterals, you see how rapidly the infarct progresses. So good collaterals are also sort of one of very important prognostic markers wherein and how the patient achieves functional independence. So if a patient with poor collaterals has even if we offer thrombectomy, if there is delay, be it for any reason, being in shifting to your for imaging or shifting to cath lab or during your procedure, even if you offer complete decanalization, these patients sort of do poorly. So the time window is even much less in patients having poor collaterals. This is just an example. So this is almost similar age group, 2 patients, almost similar NHS score. So this patient, you can see on CT angio, there's almost hardly any collateral. Whereas in this patient, MR occlusion, you can see good amount of collaterals. So both of the patients underwent thrombectomy. You see the time to reperfusion was even less in this case when compared to this case. It was 3 hours, it was 12 hours. However, if you see post-treatment, this patient sort of ended up with having a huge infarct and went for decompression, whereas this patient had just a small initial infarct and most of the tissue was salvaged. So this is how collaterals affects your outcome even if you undergo a complete recanalization. So good collaterals also as called as slow progressors in simplified terms, and patients with poor collaterals also called as fast progressors. Now, how do you assess your collaterals? So there are two ways of assessing it. Either you do a multi-phase CT angio, which is an ideal way, or you single-phase CT angio. In multi-phase CT angio, after you acquire your initial run, you do one or two additional phases. Up to 3 phases can be done. So you see how the collaterals fill over time. So you can see a patient good collateral here. M1 occlusion is here. You can see collaterals coming up almost up to the level of occlusion right in the phase 1, and even they persist up in the other phases. Whereas if you see a patient with poor collaterals, see a patient here with right M1 occlusion, you see in the immediate phase there are hardly any collaterals. Even in the delayed phase, not most of the tissue sort of it's not getting any collateral. So this is how you can sort of get poor collateral. So poor collateral patients have more chances of hemorrhagic transformation. The prognosis of getting a good functional independence is sort of limited. Now, there's a simplified grading. If you have your if you're not having multi-phase CT, generally needs a higher size CT scanner, almost around a 128 size. If you're not having that, you can do even a single phase CT angio, and you can assess collaterals with a simplified score called Mitter's grading. So here, what you do is you see up to what level the retrograde collateralization is coming. So if you see in grade 1, in M1 occlusion, you see hardly any collaterals are there. It's just coming in the cortical branches. In grade 2, they come almost up to Sylvian fissure, and grade 3, all the collaterals almost come up to the level of thrombus. So grade 3 is the one which will have the best response to a thrombectomy, and that is what you call it good collaterals in a simplified score. And this was also sort of in this study they also showed it that this was there are a lot of grading in collateral. This simplified grading is sort of the most practically relevant one in today's scenario. Now, when you are doing your thrombectomy, just like how time guidelines and time limits have been given for a primary angioplasty in MI, you also need to have your time limits in your hospital when you're offering thrombectomy program. So you need to follow these time limits and sort of do regular audits and see that you sort of reach the targets or try to improve to sort of adhere to these targets. Now, one major cause of delay from picture to puncture is imaging. So yeah, so imaging is one of the major causes of delay. So what happens is this was again a meta-analysis from the Hermes collaborators. So what they found was every 30-minute delay of imaging lead to a 10 ml increase in ischemic core. So that's equivalent to increasing patient age by 5 years. So if you are wasting your time doing your advanced perfusion and whatnot and all, you are sort of delaying the time. And if you sort of delay it up to 30 minutes, you are increasing the infarct core. So all said and done, actually imaging, if you're doing more of advanced imaging, sort of it's delaying the EVT. So you need to keep your imaging protocol simplified, and you need to follow it regularly, and should not sort of keep on changing it and all those things. And like it has also been incorporated in the guideline, like if the patient is within 6 hours, you don't have to do your perfusion imaging. You just do your basic brain imaging, and you do a vessel imaging, and you can select the patient for thrombectomy. Now, after that study, there were 2 additional studies wherein they pushed the limit. So within 6 hours, it has already been even recommended that you don't do any advanced imaging. However, these 2 studies also showed that even beyond 6 hours, even if you don't do advanced imaging, you can sort of select the patient for thrombectomy. So this concept is called as clinical core mismatch. So what you do is you see your NIHS score. If NIHS score is more than 6, it definitely indicates that patient is having sort of a hemispheric ischemia. It has a very high probability, more than 80%. And if your aspect score is less than 6, more than 6 or 7, you know that the infarct core is very less. So if your NHS score is high, that means there's good amount of ischemic tissue there. But if your aspect score is low, that means that not all the tissue has gone into an infarct core. So this is a clinical core mismatch itself indicates that there's a good amount of viable perineal tissue available, and you can sort of take the patient ahead for thrombectomy. And this is what they did even in the late strokes. They just did a CT angio and aspect, CT angio aspects and a NHS score, and that's how they set with the patients. So finally, how do we incorporate it in presence imaging? So what you do is when a patient comes within whatever 4.5 hours or above 4.5 hours, you do your clinical imaging mismatch. You see if NHS score is more than 6 and aspect is more than 6, you offer them thrombectomy. Now, when do you do your advanced CT perfusion, MR perfusion? If you see the previous trial results, they use CT perfusion, MR perfusion to sort of exclude patients. So now that we know that thrombectomy is a beneficial treatment, and we should sort of aim to offering it to more patients. So advanced imaging should actually be used to rule in more patients. So when you have a patient wherein the aspect score is doubtful, see aspect 7, aspect 8 or aspect 6, doesn't affect the prognosis much. Anything above 6 will have a good prognosis. So if you're trying to differentiate between aspect of 9 and 6, it doesn't make sense. However, if you have a borderline aspect, that's if you want to differentiate between aspect of 6 to 4, that sort of makes sense. So during that time you can do sort of an advanced imaging, or if you're and you can see if the patient is having sort of a borderline aspect and if the collaterals are good, can you offer him thrombectomy. So you need to use your advanced imaging to rule in more patients and not to exclude them, like how the trials did. So in the real world, you have to use imaging to sort of take in more patients wherein this therapy can be offered. So practically, to summarize, and this is what I follow too. I initially go ahead with CT and multi-phase CT angio with NIH score mismatch. I do my MR perfusion, CT perfusion, MRI only in cases with late or wake up stroke, wherein the aspect is borderline, where it's between 5 to 6 or 4 to 5, where you have to see whether we can offer them or not. If NHS score is low, that is less than 6, and we have to see if really is having any salvageable tissue, whether these patients deteriorate, or if patients are having previous infarct. This subset of patients is very common. Practically speaking, you have a lot of patients who have recurrent infarcts, patients with atrial fibrillations and other cardiac issues. So that time sort of CT can, and already these patients have some amount of deficits. So NHS score also suffers. So that time MR really helps in to show you which of these are new infarcts and which of these are already previously present. And when it comes to posterior circulation stroke, yeah, CT sort of suffers technically. So that time you have to see the brainstem, because the brainstem is what determines the prognosis in posterior circulation stroke. And that time you have to use an MRI. And like I said, again, you should not do any penumbral imaging within 6 hours. Now, coming to the techniques, there are basically two techniques, primarily the aspiration technique, also as ADAPT, or a stent retriever technique. And finally, recently people have started combining both of them. Personally, I combine both of them. You can do them with or without GA. Both have Siesta and Goliath, both trials have shown that there's no difference in the outcome whether you do with or without GA. So depending on your choice, you can do that. So stent retriever, basically you cross the thrombus, you deploy a stent-like system, and you retrieve the thrombus with balloon guide. There is a case with stent retriever. I personally use it only for thrombectomies beyond M2. I personally don't use the simple stent retrievers. This was a post-op case who developed an M2 occlusion, and this is where I've crossed the clot and you don't deploy a stent retriever, and this is how you get a recanalization. So primarily, I don't use it in large vessel. And aspiration, where you navigate a big large bore catheter up to the face of the clot and connect to a pump and aspirate. This is an M1 occlusion wherein I had used only aspiration. You go to the face of clot and aspirate. This is how it looks. There is an aspiration catheter here. I hope it is visible. This is in the M1 up to the level of phosphor. So you take the aspiration catheter up to the level of clot and you aspirate. And now coming to combined
sorry
techniques.
to interrupt you, sir. Just 5 minutes left for the presentation.
Sure. Yeah. So coming to combined techniques, basically you can sort of combine them, and this is what was there in this case. You can see this terminal life occlusion, and this is how you combine the technique over here. You navigate the catheter beyond it over here, beyond the clot. You deploy a stent retriever, and finally you aspirate it. Now, coming to just two cases, this is a terminal IC occlusion. Here you can see this was a late stroke presenting an NHS score of almost 17, she presented at 11 hours. You can see already a certain infarct in insula and putamen region. You can see a dense vessel. So CT angio, you can see an occluded vessel. So here you can see on the CT angio, there's hypodensity within the insular region, M1, M2 segments. So aspect was around 6. And you can see a clot. So I selected this patient just based on CT and CT angio. There's a terminal IC occlusion and angiogram. And after passes, this is a complete recanalization. So if you see diffusion post procedure, it's almost similar to what was there on CT angio. So CT and CT angio is good enough for selecting patients for thrombectomy. And this was a case who had already had a left atrial appendage aneurysm, who had recurrent infarcts previously too. And because he already was having recurrent infarcts, we had done MRI because already has some amount of deficits. So MRI, here you can see diffusion, there is just a small core of infarct, but NSS score was very, very high. So on MR angioma, you can see because of the slow flow state, it is giving an appearance of a pseudo occlusion. You see MCA is not visualized, ICA is not visualized, almost it's giving appearance of pseudo occlusion. So CT angio had to be done to see where the level of occlusion was. This is one of the pitfalls of MR angio. And you can see on CT angioma, it was just an IC occlusion. And this is the left atrial appendage aneurysm which was seen. CT angioma had covered till hard to just to see the aneurysm. So this is a large left atrial appendage aneurysm with a huge thrombus load which was throwing clots. So this was a terminal ICM occlusion, and this was after one pass. This is a the recanalization. I will just go to the one more case. So coming to the posterior circulation may you select the patients just based on a diffusion brainstem score, and there's something called as the Batman score, wherein what you do is you give numbering for each of the level of vessels. So if the score is more than 7, these patients sort of benefit from basilar thrombectomy. So this is one such case wherein you can see there is a hemipontine infarct with a hyperdense basilar artery sign. Just skip to it and show you the MR diffusion also. So you see the thalamus is spared, the midbrain is spared, and in the pons you see only hemipons is involved. So his diffusion brainstem score is very good. So most likely this patient will respond very well to a thrombectomy. So so here you see beyond the vertebral artery itself, the vessel occluded, he had a very high huge thrombus load, and this is after 2 passes, complete decanalization vessel was achieved, and this was the post-procedure diffusion, where you can see the infarct size remains the same and there's hardly any progression. These were the plots. Now coming to the peri-procedural issues, you can have failed decanalization, you can have a futile decanalization, that is even after decanalization the patient doesn't benefit, and then you can have vessel perforation, dissections, and embolization to new territory. So this is a failed access. This was a case of probably having Takayasu arteritis with stroke. You can see there's hardly any CCA visualized, and the CCA is filling up through collaterals over here. So this entire segment is sort of occluded over here, and there's no access even through the radial artery. And this on MR angio initially when we thought that it was basically a tandem lesion, but on angiogram it was a very long segment occlusion. It was chronic occlusion. You couldn't decanalize it. So you can have such access issues. Then embolization distal territory. This was again one of the strokes which went very lately to our center. It was thrombolized and outside center. Her aspect was almost borderline. She presented to our center almost 9 hours. So we had to repeat it just to see any salvageable tissue was there. And you can see the good amount of mismatch is there over here. Again, she had a huge clot burden between ACA, MC, and ICA. And this is post thrombectomy. You can see after 1 pass, there's embolization. There is a clot that has gone in ACA and MCA. Finally, he had to pull it out both from AC and MCA, and he could decanalize the entire vessel. However, you can see the amount of clots she is having. There's a very huge clot burden, and her ejection fraction is almost 35. And when they did a coronary angiogram, she also had this LAD occlusion. So she had a huge clot burden, and she also had embolization to new territories because of her friable clots. So this is how even the clots affects outcome. Coming just to a last case of poor collateral, this patient presented 4.5 hours, was 32-year-old with left ventricular thrombus on anticoagulation, but he was not compliant to treatment. You see his aspect was so good, almost around 8, but you see his collaterals, there's hardly any vessels seen over here. And he was having ICA occlusion. We decanalized his ICA. Even after complete decanalization, he look at the amount of clot burden, he sort of, his infarcts progressed and he underwent a decompression. This is what happens. You see these 2 similar cases. Both of them are having ICA occlusion. She had left and she had right. She presented to us at almost beyond 12 hours. He presented us almost within 6 hours. Both of them had good recanalizations, but you see he ended up with decompression, and she sort of her infarct almost remained same. This is how the collaterals affect the outcomes in patients. And finally, intracranial thoracic disease. This is more common in posterior circulations. This was a case with a basilar thrombus and very small pontine infarct. So he's a good candidate for thrombectomy. So after first pass, you see the vessels started occluding again. All this happens because of ICAD, and finally we had to put an emergency rescue stent. And you can see the fresh clots and almost ICAD plaque. So this is how intracranial thrombosis complicates the procedures. The vessel sort of recruits every time. So this also is sort of one of the issues. Finally, we don't have right now any data to suggest that thrombectomy can be offered in patients who have large vessel occlusion with low NHS. That is, if the NHS score is less than 5, do these patients benefit from thrombectomy? So most an endoler trial will probably give us answers for that. And now the aspect limit is really being pushed. So thrombectomy is standardized for aspects of above 6, but now several trials are there wherein they're going to see if thrombectomy will benefit patients who are having aspect score of below 5. That is even that is large infarcts. And these trials are already going on whether we can take the patient directly for a thrombectomy without giving IVT. So already direct MT and skip have shown that it's non-inferior. That is, if you take a patient directly for thrombectomy without IVT, it is non-inferior to a standardized therapy, but still the confidence intervals are very, very wide. So we still have to wait for other two trials to see what they give us the answers. And finally, in basilar thrombectomy, the basic and best trials have shown that medical management sort of is almost as good as a thrombectomy, and they have given an equipoise. However, the basilar registry has shown that thrombectomy really benefits, and practically we have seen thrombectomy benefits. So we have to really see which subset of patients actually benefit when you give a basilar thrombectomy, and which patients don't benefit. So still answers for this, have to be found out. And currently there are no trials to tell us or recommend us whether thrombectomy can be offered for the medium vessel, that is beyond M2 segment or A2 segment or PCA segment or PCA. So that's what my talk was.
Thank you so much, Dr. Shayan. I think that was a very interesting presentation. You showed us some very interesting cases, a very elaborate presentation. Thank you. We have some questions which we will take at the end of this session.
Sure.
And I invite our postgraduates from the Department of General Medicine to present some interesting case vignettes. Dr. O. Tasneem Ara and Dr. Neha Tabassum will be presenting these interesting case vignettes. Tasneem, are you there with us?
Yeah.
Okay.
Good morning, everybody. Are my slides? Am I audible?
Dr. Tasneem, your volume is very low. Could you please speak a bit louder? Your slides are visible here.
Okay. Yeah. Am I audible now?
No, Dr. Tasneem. I think you should come closer to the microphone. You're not audible to us.
Am I audible now?
Yeah, clear.
Good morning, everybody. I'm Dr. Tasneem from Department of Internal Medicine. Well, before starting, I would like to thank Dr. Sandhya ma'am and Dr. Reshma for giving this opportunity. Here, I'm here to tell the case scenario of a 56-year-old man who's a known hypertensive, presented to ER with acute onset right-sided weakness and aphasia of 90 minutes duration. On arrival to ER, his blood pressure was 140/90 and sugars were 98 milligrams per deciliter, and ECG was suggestive of left ventricular hypertrophy. His NIHS score came out to be 19. What next? As we all know, mainstay of imaging in acute setting is non-contrast CT scan. Here, the patient's non-contrast CT scan on the right is showing hyperdense left MCA. And one more picture of this showing no early infarct changes like loss of gray and white matter differentiation, obscuration of lentiform nucleus, or insular ribbon sign. That makes the patient's aspect score nearly 10. Now, how do we manage this case? As this patient has all the adequate criteria fulfilling the indication for thrombolysis like age more than 18 years, clinical diagnosis of the stroke with neurological deficit, and CT scan showing no hemorrhage or more than 1/3 of the MCA territory, or patients is euglycemic and BP is in, blood pressure is in normal limits with no absolute or relative contraindications like bleeding diathesis or history of any hemorrhagic stroke in the previous or history of any surgeries. And also an ideal aspects on CT scan and NIHS score of this patient make the patient an ideal candidate for thrombolysis with tenecteplase 0.25 milligrams per kg per IV bolus. And if in patient is in higher centers with a feasibility to CT angio, and if thrombosis demonstrated in affected large vessels in CT angio, patient may be taken up for a mechanical thrombectomy after thrombolysis. The take-home message is thrombolysis in acute ischemic stroke requires optimal selection of the patients. Like I said, we should rule out, see the indications, and we should rule out the relative and absolute contraindications, which are already discussed by the experts in the previous speakers. The recommendations include aspect score, which is based on the non-contrast CT, should be more than 6, and NIHS score, which determines the severity of the stroke at the presentation, should be more than or equal to 6 for a decent prognosis and a successful thrombolysis. In the absence of the contraindications like history of hemorrhagic stroke, recent head injury, or history of any bleed, GI bleed in the last 3 weeks, or any recent MI in the last 6 weeks, or known bleeding diathesis, or in the recent usage of novel anticoagulants, or in the last 24 hours usage of low molecular weight heparin. All these things need to be ruled out before taking out the patient for the thrombolysis. And in patients need to be taken for thrombolysis who presented with a permitted time, like through 4.5, less than 4.5 hours. Studies are going to extend till 6 hours also. In early presentation of acute ischemic stroke to the ER. Bridging thrombolysis before mechanical thrombectomy achieves better outcomes in large vessel occlusions in centers where it is feasible. Well, I would like to end my note saying time is brain. As studies have demonstrated, a patient typically loses 1.9 million neurons for every minute of the stroke untreated. So the early the reperfusion, greater the reduction of the ischemic injury to the brain. So emergent evaluation and therapy is mandatory to reduce the morbidity and to achieve the better outcome. Thank you. Over to Dr. Neha.
Good morning, everyone. Are my slides visible?
Yes, Dr. Neha, they are visible. You can go ahead with your case presentation.
Good morning, everyone. This is Dr. Neha Tabassum from Department of General Medicine, postgraduate. Here we are discussing a case scenario of a 60-year-old male, diabetic and hypertensive, presented with sudden onset, slurring of speech, facial deviation, and weakness in left upper and lower limbs of 1 hour duration. Came to the ER. We have clinically assessed, and his NIHSS score came out to be 22. On checking the vitals, BP was 190 by 110 mmHg, and GRBS came out to be 438 mg per dl, temperature being normal, and pulse 92 beats per minute. ECG was showing normal sinus rhythm. CT scan, as it is, CT scan was done. The aspect score came out to be 1 and showing more than 1/3 of the MCA involvement. So what is the management for this patient? We have to first manage the BP, sugars, and is the patient eligible for thrombolysis or not. First, BP, based on the aspect score and NIHS score, expected outcomes after thrombolysis are very poor in this case scenario. In view of his poor aspect score, an early established impact added to this patient has contraindications to thrombolysis in the form of high BP and elevated sugars. So next step would be control or bring down his sugars to 140 to 180. This is the ideal target of sugar levels by giving IV insulin initially, then followed by the basal bolus regimen. So IV insulin of 10 units minimal is to be given, short acting atropine, and then control his BP by giving injection labetalol, nicardipine, enalapril, hydralazine can be used. These are the 4 ideal drugs to decrease the BP in such patients. CT angio was done, and this angiography showed right MCA occlusion. He was taken emergently to the neuroendovascular suite. Mechanical thrombectomy with stent retriever and suction aspiration was performed. There was an excellent recanalization of the MCA. Basically, in this management of stroke, we have to subject the patient to CT or MRI, and if there is an evidence of large vessel occlusion, also look at the diffusion perfusion or diffusion flare mismatch. This tells about the ischemic to the infarct progression. If any of the above favors an intervention, mechanical thrombectomy may be contemplated since the patient has presented within 6 hours with NIHSS more than 6. Angiographic recanalization may not equate to clinical improvement. Warning with respect to poor aspects is warranted in this case. Take-home message is selection of candidates for thrombolysis requires extreme vigilance. We should look for the eligibility criteria. Are they indicated? Is there any contraindications or for the thrombolysis? In this case, many reasons not to thrombolyze this patient. In view of poor aspect score involving more than 1/3 of the MCA with aspect score being 1, high sugars and BP. With these factors, a very high risk of hemorrhagic transformation was expected. So mechanical thrombectomy was the only option in highly selective groups after non-invasive imaging for large intra and extracranial vessels. So choose right since time is brain and time is tissue. Thank you for giving me the opportunity, ma'am. Thanks, sir.
Thank you, Dr. Tasneem and Dr. Neha. I think you people have well summarized our first session in the form of 2 interesting case vignettes, indicating where we need to thrombolize and where we need to avoid thrombolysis. Thank you so much. And now we'll take some interesting questions. There are many questions, but we will be taking a few questions.
Good afternoon, everyone. Now I would like to request our distinguished speakers to answer some interesting questions which are posted by delegates. So the first question is directed to Dr. Ashok Reddy, sir. The question is, how do you correlate NIHSS in posterior circulation stroke?
Okay. So there is a caveat in NIHS. NIHS, they themselves, while the rating scale is being used, the preference is given more to the cerebral hemispheres rather than brainstem and cerebellum. So it's really difficult to correlate. But high NIHS, even in posterior circulation stroke, if there is a cerebellar infarct, there will be only ataxia. There will be nothing else. Mild slurring of speech. So hardly you may get 5 NIHS. In such case, if there is basilar artery thrombus, whether to go ahead for the thrombectomy or not, it is left to the the choice of the patient party. It becomes very difficult, as our radiologist had suggested. This still posterior circulation stroke. There are still trials going on. There's no proper evidence that endovascular therapy will help. IVT, yes, can be done, but if NIHS is less than 6, it is difficult. Suppose we find a patient with low NIHS and impending that we expect that within few hours he may worsen because basilar artery thrombus is there, we can offer thrombolysis. There is no good correlation between NIHS and posterior circulation. That is, it's a caveat.
Thank you so much.
Sapna madam, anything else?
Yeah, I also agree that posterior, we know that vertebrobasilar stroke, NIHS is classically for the anterior circulation stroke and posterior circulation, despite the significant level disability like ataxia or ophthalmoparesis, it doesn't reflect much in the NIHS severity. So it underestimates the stroke severity.
Thank you, ma'am.
Yes, ma'am,
Second question is directed to Dr. Sandhya, ma'am. It is actually posted by Dr. Sapna, ma'am. What is the risk or safety of thrombolizing the stroke mimics? Sandhya, ma'am, please unmute yourself.
Actually, at the emergency level, if the emergency physician do proper screening, that is using Rosier scale and the blood sugar level, most of the time we will miss we cannot label the case to the stroke mimic. It will be mostly stroke. But still, if the patient is having trans-ischemic attack, we will miss that, and then ABCD2 score will help. There are not much studies, but there are one study in the stroke journal in 2015. There are around 561 cases. They have prospectively studied and they followed for a period of 5 years. And out of that, they found that around 75 patients were stroke mimics where they thrombolized without knowing. So what they noticed there, in patient with those who are stroke mimics, they did not have intracerebral hemorrhage, complication of thrombolysis. That is the one point they have gathered. And other thing, and this patient did better, 3-fold better than the true stroke cases. So just one sentence we have to keep that underline, that is underscore. We have to clearly differentiate between stroke and stroke mimic. That's only I know. Anything more to be added from the moderators or the group?
Same, very less. Huh? It's very less.
Yeah.
It's very less.
Yeah.
Less than 0.5%. So
yes,
I think we can go ahead. We should go ahead and do it. There's not a major restriction.
Okay, thank you. Anything, Vrinda?
Yeah, ma'am, there's one more question for you. The second question is, in case of post classification of cardioembolic, what echo modality in post classification?
Okay.
What echo modality is used?
Okay. So in 1993, when they used this TOAST classification, that is the ancillary studies, they used only the thoracic echo. They did not use the transesophageal echo. But the present 2021 guidelines say that, which I have already shown that outlined the chart, the 2D echo, that is the transesophageal echo or the transthoracic echo, only the recommendation is class 2B. They give more stress, that is class 1 recommendation for the ECG and 24-hour ECG monitoring. That is the 21 AHA guidelines. So that time they use 2D echo, only the 2D echo, that is the transthoracic 2D echo.
Okay, thank you so much, ma'am. The next question is directed for Dr. Shravan, sir. This is by Dr. Shrikant Javalkar, sir. The question is how the phases 1, 2, and 3 are determined for assessment of the collateral circulation. Dr. Shravan, sir. Please unmute yourself. Dr. Shravan, sir, we cannot hear you.
No. What is the question? I didn't get the question.
This question was posted by Dr. Shrikant Javalkar, sir. How the phases 1, 2, and 3 are determined for the assessment of the collateral circulation.
Okay. In multi-phase CT angiography, the first phase is immediately after the injection, and by the time the third phase, it will be 40 seconds. So serially, within 40 seconds, 3 phases are taken. For collateral scoring, as I have already told you, we see the opacification of the internal cerebral veins as well as the dural sinuses. That is the ideal phase exactly to assess the collateral score. But in the first phase, we should not see any venous contamination.
Okay, sir, thank you. And the second question is posted by Dr. Murli Krishna. It's for Dr. Shravan, sir. Can we do aspects on MRI is the question.
Yeah, we can do aspects in DWI, SWI. Almost aspect score is described even for CT angiographic source images. On anything we can do aspects. In fact, DWI aspects, they say superior to NCCT aspects.
Okay, sir. Thank you, sir. The next question is directed to Dr. Sapna ma'am. Sapna ma'am, we would like to know if there's any specific imaging protocol you follow at your center for acute stroke, like a fast sequence MRI or CT or a CT angio.
In our center, we basically do a CT-based selection of patients. So our protocol is CT angio, and if the patient presents after 4.5 hours, CT perfusion as well. In wake-up strokes and late window patients only, in the acute stroke, we are doing MR-based protocol. So our MR protocol includes MR, diffusion, ADC, flare imaging, susceptibility, and a TOF angio. So if the patient is cooperative, we take only 10 to 12 minutes to complete the whole MRI sequence. Because the main issue with the MRI is the delay in the time. CT hardly takes, like the full protocol, CT with angio will take only about 2 minutes to be plain CT, and injection and everything will be completed within 2 minutes. And if perfusion imaging is also required, we'll have to wait for 3 minutes more to complete that. So it may take additional 3 to 5 minutes. But MRI contrast will take double the time, and if patient is not very cooperative, then it is very difficult to interpret the image also. So ours is a CT-based protocol.
Okay, ma'am, thank you so much. And we also have one more question for you, ma'am. According to your experience, which is better agent, like a thrombolytic agent like tenecteplase and alteplase? Is there any particular scenario where one is better than the other? And also, what is the window period for thrombolizing in both of these cases?
Regarding the comparative, we know in the there is increasing evidence favoring TNK as well. But as of now, it is not superior to alteplase except a few situations. Like if you use it for a large vessel occlusion for bridging, we know that the chance of opening of the vessel is superior. M1 opening is superior if you use TNK when compared to alteplase. That is proven in extent 1A study. And the advantage of TNK is that because of the higher fibrin specificity and longer T-half, you can give a bolus dose, which is much easier to administer in emergency. Unlike alteplase, especially if a patient is for bridging, you can give the bolus and shift the patient immediately to cath lab. Whereas if it is alteplase, you will give bolus, start the infusion and shift to cath lab. Often the drug will not be finished by the time puncture is taken and the procedure is done. So you don't know whether the drug has started acting or not, unlike TNK where the action has already started. So that is the only situation. And in minor strokes, TNK is equivalent to alteplase. Other situation, still as per evidence guidelines, alteplase has to be given as a first option. But because if the cost constraints are there, you can make an informed choice regarding giving TNK as well.
Thank you so much, ma'am. The next question is directed for Dr. Shayan, sir. We would like to know what is the time or the window period for thrombectomy in posterior circulation stroke, and also a comment on mechanical thrombectomy in stroke secondary to infective endocarditis. To Dr. Shayan, sir. Dr. Shayan, sir, please unmute yourself.
Yeah. Am I audible now? Am I audible? Yeah. So for posterior circulation strokes also, you can offer it up to 24 hours. But like I said, there's a lot of caveats in posterior circulation stroke. One thing is, we still don't know exactly which patients benefit from thrombectomy vis-a-vis medical management. So one practical thing is you look at the brainstem involvement. If the brainstem involvement is less, because cerebral involvement and PC involvement doesn't sort of affect the prognosis. The mortality in basilar strokes is because of brainstem involvement. If you see, the basilar strokes almost have a mortality of 70% when compared to, it's quite low for anticirculation. So if your brainstem is spared almost up to 24 hours, like I said, the diffusion brainstem score, it's a very simple score. It sort of divides your brainstem into each halves. So if you don't have a bilateral, I guess both half of the brainstems are not involved, practically speaking, those patients will have some benefit from thrombectomy. So those patients you can select based on division and you can offer thrombectomy to them. But one additional thing is, especially in Asians and Indians, there is a lot of intracranial atherosclerotic disease, and it is predominantly seen in the basilar artery. And in these ICAT patients, they sort of, the case sort of turns very, very tricky. Many times what happens after thrombectomy, the plaque sort of gets, activated and irritated and sort of forming thrombus immediately on table itself. And you see that patient ends up being much more worse than what initially you had taken up. So that's what even the best and the basics trial have shown. When they compared with the medical management, the functional independence finally was almost equal in both of them. So we have reached an equipoise. So again, we sort of have to, the results of these are almost similar to what was there in IMS3, wherein they initially found that thrombectomy is not much beneficial than medical management. Later, they took out a subset of patients. So we still have to take out a subset of patients who are benefiting. Practically speaking, I do not take any patient for thrombectomy if, both half of the brainstems are involved. If only one half is involved, those patients, I know they will sort of benefit from thrombectomy. We take only those patients. And if the bilateral, half of brainstems are involved, that is bilateral pointer involvement or thalamic involvement is there, we sort of give them for medical management. And because the prognosis of these cases is generally very, very bad. So up to 24 hours, you can select these patients for thrombectomy. What was the next question? Sorry.
Second question was indication of mechanical thrombectomy in stroke secondary to infective endocarditis.
In infective endocarditis, generally what happens is, the vessel sort of becomes very weak. And majority of the times, what we have seen is infective endocarditis, strokes happen because of local vessel dissection or a pseudoaneurysm formation, majority of the times. And the vessel is so friable, you generally sort of do not want to, put your devices in there and injure. Because when you're doing a thrombectomy, actually you're creating a small amount of micro trauma there. And in infective endocarditis, endocarditis, already the vessel itself is, the infective foci sort of, affects the vessel, whereas the vasorum also, it sort of affects the vessel. So chances of complication are extremely, extremely high. So as such, guidelines are not there, but practically speaking, if you see the various individual series also, the prognosis has been very, very bad. So generally the strokes in infective endocarditis are because of local vessel dissections or scudonism. That's what we have seen. So isolated thrombi are very, very rare, and when it is there, generally you have to, anyhow you are giving your anticoagulation, so you sort of manage with that only. Thrombectomy sort of is, sometimes can be catastrophic in such patients because the risk of vessel injury is very, very severe, and you sort of, should not go in and, harm the patient more. So personally speaking, I do not do it, and even I think majority of the people will agree as a group it's sort of this very unfortunately is a poor subset of patient wherein thrombectomy sort of is not beneficial.
Thank you so much, sir. The last question is directed to Dr. Revan Jaiswal, sir. The question is, do we have to apply Rosier scale to all the patients presenting to the ER with stroke?
Yeah, we do apply Rosier scale to all the patients presenting to ER because, as said earlier, it is recognition of stroke in emergency room and distinguishing stroke patients from stroke mimics, and it does very effectively. We do apply Rosier to all patients presenting to ER.
Okay, thank you so much, sir.
Thank you.
We would now take a 5 minutes of tea break before we resume the second session.
Thank you.
Thank you.
Good afternoon, Dr. Subhash Kaul, sir. Hello, sir. Subhash Kaul, sir. We welcome you to the session. Very good afternoon.
Yeah, very good afternoon. Can you hear me?
Yes, sir. Yes, sir. I can hear you. How are you doing, sir?
I'm good. I'm good. What was the last
Hello,
question?
sir.
Just for
Good morning.
Hi. Good morning. What was the last question about stroke mimics and all? What was the question?
Sir, it was regarding the use of Rosier scale. I mean, when we have a patient who comes with a stroke.
How do you spell that scale?
Sir, Rosier. We
Rosier.
had the first speaker. We had the first
Rosier
speaker.
scale.
Okay. Okay, great.
So
So
we'll,
I'm audible and I'm visible?
yes, sir.
Yes,
Yes,
sir.
sir.
That is the new language now, post-COVID. Am I audible? Am I visible? And the answer is
Both.
now you are audible, now you are visible.
So Sandhya
Now
ma'am
it is
there.
little better. Can you hear me now? Yeah, little better.
Sandhya ma'am, please unmute yourself, ma'am. Subhash Kaul,
Hello,
sir.
hello, Sandhya madam. We can't hear you. We can't hear you.
Ma'am, please unmute
You are
yourself.
not audible.
Good morning, sir. Good
Yes.
morning, sir.
Now you are audible. Good morning.
Yes, sir.
And you are visible also.
Yes, sir. I think without wasting time, we should start. Sir is waiting now,
We should
Reshma.
start.
Yes, sir.
Yes, Reshma.
We'll start, Reshma.
So can I share my screen?
Yes, sir. No, 1 minute, sir. Introduce Reshma.
Reshma.
Sir, 1 minute, sir. 1 minute.
Sure, sure.
Sandhya ma'am, please share your screen to introduce sir, ma'am. I mean, you have to, or I'll just share.
Reshma, speak loudly. We cannot hear you.
Yes, ma'am. Yes, ma'am. Ma'am, please introduce sir, ma'am. I think we'll start the session. Please unmute yourself, ma'am. Ma'am, Sandhya ma'am.
Sir, can you hear?
Yes.
Yeah, I take this prestige to introduce my sir. Actually, my favorite sir, Dr. Subhash Kaul, sir. He did MBBS from Government Medical College, Srinagar, 1975 to 1980. General Medicine, MD from Government Medical College, Srinagar, DM Neurology from Postgraduate Institute of Medical Science, Chandigarh, and is a stroke fellowship from NIH, Maryland, USA. And he is the professor and HOD Department of Neurology, NIMS, Hyderabad, for the period 2004 to 2018. Served as the Dean in charge, NIMS, Hyderabad, 2015 to 2018. And presently, Sir is the Senior Consultant and the Stroke Specialist, KIMS, Secunderabad. Sir has several publications, 120 in national and international journals. He is a past president, Indian Stroke Association, and the past president, Indian Academy of Neurology. Sir, I welcome you for this wonderful talk, that is Secondary Prevention of Stroke, 2021 Guidelines.
Yeah, thank you, Sandhya. I'll just share my screen, then we are done. Yeah, I think you can see the slide, hopefully. Can you see the slide? Hello?
Yes, yes, sir. We are able to see.
Okay, okay. So, Dr. Sandhya, thank you very much for organizing this conference, and thank you very much for inviting me to this conference. I know Dr. Sandhya, I think at least 15, 20 years when she was doing her DNB in Apollo Hospital. After that, I followed her in ESI. I think wherever she went for interviews and all, by some chance, I was also there. Not competing with her, but in the board. And I can tell you, she is extremely committed and disciplined and a master in her field. I remember in ESI hospital also how much of, IVIG and thrombolysis and all. So Sandhya, congratulations and thanks for inviting me today. Now, secondary prevention is important. This is actually secondary prevention of ischemic stroke. You know that strokes can be 80% times ischemic and 20% times hemorrhagic. For hemorrhagic stroke, you have to basically just manage the blood pressure and see if there's any underlying cause like a AVM and all, and that is how you prevent them. But ischemic stroke, on the other hand, is very heterogeneous in etiology and it's a very high recurrence rate. So therefore, we are going to discuss about the secondary prevention of the ischemic stroke or the TIA. And this is latest, only for the last 1 or 2 months these guidelines have come up, and it is a 100-page document. 100 page is a simple document. Then each page has got cross references, cross websites connections, and I think you need to have at least 1 week to go through them, to assimilate them, and then to put them into your practice. They're very nicely written and they try to cover most of the situations. I'll just give you a flavor of the guidelines. Now, ischemic stroke, if you don't do any strategy, about 5 to 10% will recur per year. And second strokes are worse. It is in the second stroke that you get pseudobulbar palsy. It's in the second stroke that you get dementia. It's in the second stroke that you get gait abnormalities. So second strokes are worse. So first of all, we should not have even first stroke. But suppose first stroke has occurred, then we must do everything possible in the world to prevent the second stroke. And we'll be able to achieve our goal in most of the cases. Now, for these prevention, these guidelines. These guidelines are just giving us some kind of a roadmap. They are not absolute. They don't guarantee that the patient will not get any further event, ischemic or hemorrhagic. But they put you at some kind of a scale. So the guidelines are based on the evidence, and evidence is sometimes randomized control, randomized non-control, limited data, or even expert opinion. And based on that, the recommendation is given. So for instance, the highest recommendation is class 1. Class 1, level A. But it is also not absolute. What it says is that the benefit is more than risk, right? So for instance, you put a patient of ischemic stroke on aspirin. Benefit is more than risk, but the risk is still there. Tomorrow, that patient of aspirin whom we have put, he can come with hemorrhage, right? So we are not absolutely 100% sure, but that is how the medicine is. Any treatment is a balance between benefit and risks. So class 1 is benefit more than risk. Class 2A is benefit little less than the class 1, so on and so forth. And class 3 can be either no benefit or it can be harm, which is in red. So we have to know all this when we study these guidelines. Therefore, it's also important that when we take a decision, we inform the attendants or the relatives that it should be shared decision making, particularly when you are putting a patient on anticoagulants. You have to tell them that we are taking a little risk for the sake of huge benefit. It's called shared decision making. But for giving secondary prevention, it's essential to identify risk factors of stroke, and it's essential to identify mechanisms of stroke. Now, risk factors are hypertension, diabetes, hyperlipidemia, smoking, and mechanisms are whether it's a cardioembolic stroke or whether it's a large artery or small artery. And it's important to cover the risk factors. As you can see in one of these studies, the patients who had got an uncontrolled hypertension, they had a higher chance of recurrence compared to those who had a controlled hypertension, compared to those who never had hypertension. Same is true with uncontrolled diabetes. Same is true with uncontrolled atrial fibrillation. So it's not enough to address a mechanism, but we must go to the underlying risk factor and control it as well as we can. And after that, we should also identify, after risk factors, that what are the mechanisms which has caused this stroke. So every person should have a 2D echo to rule out any left ventricular thrombi, to rule out akinesia, hypokinesia, to rule out any valvular heart disease, mitral stenosis, right? Then every patient should have a carotid Doppler to rule out any flow reducing 70% or even 50% stenosis. Preferably, you should have an MR angio to see whether there's any intracranial stenosis, right? And of course, obviously, lacunar stroke, you will automatically identify. Now, if after doing all this, you do not find any mechanism, then that is the stage when you should do a transesophageal echocardiography, because some conditions like patent foramen ovale or aortic arch atheroma in the elderly can be detected only with transesophageal echocardiography. Even after that, if you don't find any mechanism, then you do Holter monitoring for 24 hours, for 72 hours, and even up to 3 months, what's called internal loop recording. And it's become quite relevant and quite possible these days. It's not done in every patient. It's only done in those patients where you don't find any mechanism. So you keep on searching the mechanism till you get a mechanism, or sometimes more than one mechanism. So therefore, we must subtype the ischemic stroke into whether it's a large artery, and large artery can be carotid extracranial or intracranial carotid or MCA. So that's a large artery. Then small artery, which is a lacunar stroke. Then cardioembolic of various etiologies. Then other determined etiologies, right? Other determined etiology would be like COVID stroke, post-viral stroke, vasculitis, homocysteine, so on and so forth, dissection. And even after that, about 30% of the patient, you will never find any mechanism, and that's called undetermined etiology. And many people call it cryptogenic stroke, which has subdivided into now embolic stroke of unknown etiology. So it is good to have some kind of a idea in our brain that what is the mechanism of a stroke. And let me tell you, about 15 to 20% of patients have more than one mechanism. So you can have a large artery disease, at the same time you can have atrial fibrillation. And in these patients, we have to manage them accordingly. And we have been very interested in these mechanisms and all. I think I have spent half my life trying to find out these mechanisms in Hyderabad. And what I can tell you, and this was done in 2010, the subtype paper. And what is relevant to know is that all subtypes exist in our city, in our country. We have cardioembolic also, we have aortic atheroma also, we have carotid disease also. It's important because in Western countries, intracranial atheroma is very less common. They have got carotid arteries more common. But in our country, it's a heterogeneous country. All mechanisms exist. We have to give attention to everybody. So the first thing for secondary prevention is optimum control of risk factors. Now, physical activity is very important. And in the new guidelines, it's very nicely saying that you need physical activity of at least 10 minutes, 4 times a week. It's called aerobic. Aerobic means walking or even fast walking. You have to imagine this is a stroke patient. He will not be able to jog and all or running on treadmill, most of them. But even if we give 10 minutes 4 times a week or 20 minutes twice a week, that's also good enough for cardiovascular health. It also takes into consideration some people who may not be able to walk at all. It says, okay, make them stand up at least 3 minutes every 30 minutes. So we must go through this, it is very user-friendly and it can help us to counsel the stroke patient. Standing is very important. Standing is also exercise. Sitting is new smoking. In US offices, people are working while standing these days, and it has come in our guidelines. Now, it is sad to see that smoking is still common. I think elderly people, some of the elderly people have given up smoking, but in a significant chunk, and unfortunately, even among girls, smoking is picking up. And if you don't believe me, go to the high-tech city and enter any pub or restaurant in the evening. I have gone there sometimes with my children, and you will be shocked to see this scene. In fact, this picture is from Hyderabad only. Alcohol and smoking are very common, and irrespective of the genders, in fact, more common in the ladies. So it is very important to counsel the patients, and many of them come with strokes. Many of these software people and all come with strokes. I don't know whether you have seen them or not, but they come in that area of Kukatpalli hospitals, and once in a while they land with us also. So it's important to counsel these patients against smoking. See, they don't know. They are innocent people basically, but they don't know that these are bad. They are going to destroy them. So as per our guidelines, we have to counsel them and find out methods for them to give up this highly addicting behavior with nicotine replacement and varenicline, right? And even passive smoking also should be avoided as per the latest guidelines. And then, as far as alcohol is concerned, those who don't drink should not drink ever. And those who are habituated to drinking, they are also limited drinks, not more than 2 per day and not more than 1 per day. But even it should be less than that. I would say alternate day or once in a week, if at all necessary. And I am embarrassed to say that there is a recommendation on prevention of substance abuse stroke also. I used to think this happens only in America, in Baltimore and Washington, till I saw few patients, and to my dismay, one of them was a medical student, and he came with a stroke to me, and I took a screenshot of his mobile, and this is in his mobile: cocaine, MDMA, LSDA. I never knew MDMA is a drug. I thought it was an anesthesia degree, but it is so shocking to see. So therefore, after that, I saw several students, and unfortunately, some of them from the medical field. So therefore, after a stroke, they need tremendous counseling, de-addiction programs to get rid of it. Then the diet is very important, and Mediterranean diet type, which means that refined carbs are very bad, fats are very bad, but polyunsaturated fats, which are in the olive oil, are allowed, nuts are allowed, but refined carbs, means processed food, pizzas and all, are bad for vessels, blood vessels. And of course, salt has to be reduced. It has not to be completely stopped, but at least it should be about 1 gram, which means less than 1/2 or 1/3 of what is the usual Indian salt reference. Now, hypertension is most important. It's a king of all the risk factors. And important thing, grade 1 recommendation, class 1 recommendation is that reduce the blood pressure. That's very important. Now, with what do you reduce it? Preferably with a diuretic and ACE inhibitor. If you combine, ACE inhibitors have got vasculotropic, endothelial repairing effects. So that's important. It's quite effective. You can even use, the other calcium channel blockers also. But more important is that reduce the blood pressure. And how much? Less than 130/80. If it's more than 130, or if it's more than 80, your antenna should be up and you should reduce it. Then the next question is sugar. Sugar also should be kept under control. The hemoglobin A1C should be less than 7%, and that is the bottom line. Then there is a lot of mention about lipid management in the new recommendations. And here our goal is to keep the LDL less than 100, preferably less than 70. Particularly if you have got evidence of atherosclerosis in any of his vessels. If there's a atherosclerosis in carotids, even coronary, or any of the intracranial vessels, then you must make sure that the LDL is kept less than 70. For that, we are giving high dose statin, but they are making mention of another drug, which I have not used, but they are making mention, ezetimibe. That is for those where the atorvastatin does not lower sufficiently. They have given ezetimibe, and then they have given one more agent also, which is pro-protein convertants, sublicin. Again, I have not used it, but these are the new guidelines which are saying to statins, you can add these new drugs. These are very, very bad vasculopathic patients. And they don't have to take this 80 milligram statin lifelong. Every 4 months, we can monitor it, and then we can reduce it. Our patients, anyway, finally, they are not on more than 10 or 20 milligram of statin, as you know very well. Now, for the first time, there is a lot of attention being paid to triglycerides. We never bothered about triglycerides before, and we just gave them fibrate and all, but it clearly says that take fasting triglycerides. It's better to take lipid profile fasting, although there's a trend people do it now without fasting, but it's better to take fasting. And if fasting triglycerides are more than 135 to 499, then it is better to treat them. And the drug is icosapent, but of course you can use fenfibrate also, omega-3 fatty acids also. The idea is to give attention to these. They have also to do a lot with the high carbohydrate intake, and that has to be modified. Now, obesity has to be addressed. BMI should be done. Obesity is an important independent risk factor, and it is a lot of psychological issue. A lot of people, by intermittent fasting, they can get rid of their obesity. But if they are not able to do that, then psychological counseling, even bariatric surgery can be recommended in some cases. Sleep apnea is emerging as an important vascular risk factors for hypertension and heart attack and even for stroke. So people should be screened for a history of excessive daytime somnolence, snoring, and then they should be given CPAP. It's not, there's no consensus whether we should screen all patients, even the asymptomatic ones, for obstructive, probably not, but those who have the history, they should definitely be given CPAP machine. Now, it's important that when these patients come to us for follow-up, we look at all the risk factors. It's no point to control hypertension and leave diabetes untreated, leave lipids untreated, leave obesity untreated, because there are cumulative gains in stroke prevention with the optimal control of each additional risk factors. All these risk factors are like bad guys. They get very strong when they gang up. If they are alone, then they are not that strong. So we must always make a comprehensive control of all the risk factors. This fellow is Pierre Emerico. He's the father of lipidology. He's the one because of which we are giving statins to all based on the Sparkle study which he did many years ago. Now, after the risk factors, we come to the mechanisms. Now, as I have shown you this picture again, the most common mechanism, even though we have all the mechanisms in India, but the most common mechanism which we have found is in the intracranial large artery. This one, about 30% of our strokes, if you do their MRA, you will find there is this plaque, more than 50% stenosis. It's called intracranial atherosclerosis. And we studied for 10 years and found this was the most common stroke mechanism when I was working in Nizam's Institute. And now for this, there have been studies, which was called SAMIPRI studies. And they said that if you have got a stroke because of this, you can see on the right side, this high-grade stenosis, then there was a trend to put stents in them, but this study clearly showed that if you give them aspirin plus clopidogrel plus high degree of exercise, lifestyle modification, then it is much better than stenting. Stenting in that area, that's a fragile area. Many times they can cause bleeding, they can cause complications, they can rupture. Of course, now there are better stents, but even as per the 2021 guidelines, stents have to be given only to those who fail medical treatment. As a first choice, it's not there. As a first choice, we have to give combination of aspirin plus clopidogrel for 3 months with high dose statin and exercise. After 3 months, we come back to only one antiplatelet. And stenting is not recommended in 2021, except in those who are recurrent in spite of our double antiplatelet. And definitely, sometimes what is recommended is a EC-IC bypass, where you make a bypass from an external source to the MCA. That is also not recommended. It is being done off-label. I have also done it some off-label, but it is those patients where drugs and everything else fails, and they keep on having attacks after attacks. But as a first-line treatment, EC bypass and stenting are not recommended. Then we come to the extracranial carotid artery disease. Please remember that for this, if the patient is non-disabling stroke, right, and if you have detected him within first 3 months, then we have to offer him either endarterectomy or stenting. That's very important, provided the stenosis is more than 50%. The advantage is much more if it's more than 70%, but we can offer it to more than 50% diameter stenosis, right? Now, which one is better? Is it stenting or endarterectomy? Yeah, both of them are equally good. It depends on who is doing it, right? If his complications are less than 6%, means less than 6 per 100 patients, then he's good enough. No surgeon or no interventionist will tell you that data. You would not know it, but you would know it probably by hearing others and by having his track record from others. But both of them are equally good. There are some general recommendations that if a person is more than 70 years of age, then probably endarterectomy is better for him, because after 70, these vessels get tortuous and there may be more chance of complications. But these are soft distinctions. The other thing is that it is recommended the maximum advantage of this endarterectomy or stenting is within first 2 weeks. We should not wait, because if you wait, by the time he may get another attack, and then your whole idea of intervention is lost. And similarly, if you encounter this patient after 3 months, then there is not much advantage, because by that time, if the patient has not had any attacks, he's at a less chance to get an attack, because by that time there is an endothelialization. But still you can offer him. It's not that you can't offer him. In fact, many of our patients used to be reluctant to get these interventions done. And at that time, we just followed them also. And we found that with high degree statins and exercise and antiplatelet and BP management, even they also had a good outcome. But still, as a guideline, it's our duty to offer them this intervention to prevent the stroke. Now, the other thing is that many patients will have vertebral artery stenosis. And the point which I want to say here is, and I think it was told by the interventionist previously also, that these basilar artery, vertebral artery, don't do any intervention in these patients. It's not recommended. They are best managed with antiplatelet agents. There may be situations where they are resistant and they keep on getting attacks. Those are different things. But as a primary guideline for preventing recurrence in vertebral artery stenosis, it is not intervention as it is in the carotid artery. So that is the difference. Here you have to manage medically only, even if it's extracranial vertebral artery, right? Now, we talk of large artery. When we talk of large artery, we know internal carotid artery, we know MCA. But you must realize, and it's very interesting to know, that actually large artery starts from aorta. So aorta also is a large artery. So if there is an aortic arch mobile thrombus, that has a very high risk of embolizing and causing a stroke. You can see it here. This is a mobile pedunculated hanging thrombus. And previously, people used to treat it with oral anticoagulants. But now many studies have been done, and it has been shown clearly that the grade 1 recommendation is to just reduce their cholesterol, bring the LDL cholesterol. We must always look at the LDL cholesterol. That is the target of management, not the total cholesterol. Bring the LDL cholesterol to less than 70 and double antiplatelets for 3 months, and after that you can give single antiplatelet. So that's about the aortic arch atheroма. It is one of the causes of the embolic stroke of unknown source if you have not done a TEE. So we should always remember this source as a cause of a cryptogenic stroke. Always two causes we should always remember in TEE: aortic arch in the elderly and patent foramen ovale in the young. Now, after large artery, we come to small artery or lacunar strokes. For lacunar strokes, once again, in addition to the risk factor control, if they are minor, which means their NIHS is less than 5, non-disabling minor, means just mild facial or mild pronated drift, then you should give them double antiplatelet for 21 days. Because we don't want them to have a repetition of their attack. And at the same time, we don't want them to have bleeding. So based on chance study and point study, we give them 3 weeks of double antiplatelets. But if the lacunar stroke is causing a major stroke, that can happen. You can have a very strategically placed internal capsular, posterior limb capsule, which can cause you an NIHS of 8. Then in that case, you will give it only single antiplatelet. What I'm trying to say is that chance and point studies have shown that this double antiplatelet for 3 weeks has to be given only in minor strokes or in TIAs, not in the strokes if they are major, then they have a chance of bleeding in those patients. Now, another interesting thing is, and I'm very interested in this, is that for the first time in 2021, American Stroke Association guidelines have acknowledged that silestazole also can be used in secondary stroke prevention, particularly in the small vessel disease. Now, 2B recommendation means that they are not sure, but at the same time, it's not harmful. Sometimes if a patient does not respond to the primary antiplatelets, then, or sometimes if a patient is at a very high risk of bleed, with having a lot of micro bleeds and all, we can try this. At least it has come in our guidelines. And even though the guideline is not strong, but it has come in American guidelines. Otherwise, it's a Korean drug, Japanese drug. That's where it's being used. Now, from that, we move to the cardioembolic source. And in the cardioembolic source, the most important source is atrial fibrillation. And in the atrial fibrillation, first we talk about the non-valvular, age-related, non-atherosclerotic atrial fibrillation. And this is the one on which you must have read a lot of literature and attended a lot of webinars. You can give them novel oral anticoagulants, or what are called NOACs. We can give them apixaban, dabigatran, rivaroxaban, any one of them. And important is that sometimes the AF is quite paroxysmal. The definition of paroxysmal is that it lasts only 30 seconds and after that it goes away. If you have more than 2 such episodes in 1 week of 30 seconds, then you have to give them lifelong anticoagulation, and you can use NOACs in these patients, right? Even if you have got atrial flutter, or they also are prone to this. Even sick sinus syndrome are also prone to this. And now the latest, it does not come in guidelines, but there's a concept of atrial cardiomyopathy, and that is a prelude to atrial fibrillation. If they get a stroke in spite of aspirin, you can give, but it's not in guidelines. That's being studied. What's in guidelines is that non-valvular atrial fibrillation or atrial fibrillation or flutter should be used, prevented by these NOACs. Now, after that, we come to the valvular AF. Now, if the definition of valvular AF for prevention is moderate to severe mitral stenosis or any mechanical heart valve, not a mild mitral stenosis. Mild mitral stenosis you can manage with aspirin also. But if it is a moderate to severe mitral stenosis, which a cardiologist will tell us, depends on the gradient, or if a patient has a mechanical heart valve, then he has to be treated only with warfarin, not with NOACs. They will not work in those patients. But suppose this patient is also having a stroke because of atherosclerosis in addition, some of them may be having that, then you can add aspirin to these patients, right? So please remember that. And on the other hand, if you are having a non-mitral valve, let us say aortic valve, or there is a mitral valve prolapse or a mitral valve calcification, then you don't have to anticoagulate them. Even aspirin is good enough for them. If a patient has been put a bioprosthetic aortic valve or a mitral valve, this is not considered as a mechanical valve. Then in these patients also, you can manage with aspirin, but first 3 to 6 months, you have to give them oral anticoagulants. After 6 months, recently I saw a patient who was given bioprosthetic valve, was not put on anticoagulation. He developed a stroke. So first 3 months for the bioprosthetic also, you have to give anticoagulation. See, all these things we have to study, remember, and practice. So that's what I want. You have to yourself, you will have to spend one day and look at repeatedly so that we remember and commit these guidelines. They're very helpful for us to take a decision and also save us sometimes from any unpleasant issues. Now, the other important thing is the concept of left atrial closure with a device called Watchman device. Now, Watchman device is a device by which you close the left atrium. The factory of causing of formation of these emboli is in the left atrium, particularly left atrial appendage. Now, there are some patients in whom it is dangerous to give oral anticoagulants, like patients with amyloid angiopathy, those who already have had a lobar bleed, or a patient with hundreds of microhemorrhages, cerebral microbleeds. Now, in those patients, you have to give, he's at a risk of atrial fibrillation strokes also. So you can close the left atrium with this device called Watchman device. It has been given a 2B recommendation, which is not a high recommendation, but in some cases, we may have to do it. It's not very prevalent these days, but please remember, in these also, for first 45 days, they recommend oral anticoagulation to be given. And after 45 days, you can stop it, and the patient can continue to be on Watchman device alone. Then there is another group of, atrial fibrillation. The other question is that when do you start? Once you detect a patient of stroke and he has got a cardioembolic stroke, when do you start? Well, there's a Diner's law for that, which says you can start from day 1 to day 14. Means if it's only a TIA and there's no stroke, you can start on the first day. If it's a very small stroke, less than 1/3 of MCA, then you can start on 3rd or 4th day. If it's a mild stroke, almost bordering on the 1/3, then you can give it 1 week. But if it's a big stroke, then you should wait for 2 weeks. If there's a hemorrhagic conversion, then you should wait for 3 weeks. So it's a common sense that you don't want a hemorrhagic conversion. So you can wait for some time, but not wait too much. And also when we are giving these anticoagulants, we have to be aware of the renal status of these patients. These dabigatran and rivaroxaban should not be given if the renal disease is less than 30, GFR is less than 30, but warfarin can be given, and low dose apixaban also can be given in these patients. Now, another bugbear is the infective endocarditis. Now, infective endocarditis in no case should be given anticoagulant. That's absolutely contraindication. Aspirin also you have to avoid them, but sometimes you cannot avoid if the patient is having a severe coronary artery disease, active coronary artery disease, you have to give them. But what you have to treat infective endocarditis vegetations and their emboli is with very high strength, high-end antibiotics. And sometimes they may even need surgery to remove the mobile vegetations. Okay. Now, what about LV thrombus? If you see LV thrombus in the many times you will find. So in these patients of LV thrombus, 3 months of oral anticoagulation can be given for warfarin. You see, these novel anticoagulants are only for atrial fibrillation. For most of the other cardioembolic strokes, it is the warfarin. So 3 months of warfarin can be given. I'm sure you already must have been giving to these patients, right? Similarly, if there are following massive MIs, some people are having a low ejection fraction, 40%, 45%. To them also we can give 3 months of oral anticoagulant. Still that thrombus gets resolved or it disappears, right? Then what about cardiomyopathy? In cardiomyopathy also grade 1 recommendation is to treat them with warfarin. Right, you can many times they are reversible, and if because they are viral myocarditis, you may give them only for 3 months, but you may have to extend it depending on how the patient is doing. Then what about patent foramen ovale? This is a new thing, and in all patients, at least less than the age of 55 years, if we don't find any mechanism, we must look for patent foramen ovale by transesophageal echocardiography, and we should also do TCD. There are some centers in our city where TCD is done. I think Komal Kumar from Yashoda is very good at it. I also used to do, but now I have stopped doing. But you should do every young stroke. Don't leave him till you have ruled out PFO. I have myself got many PFOs operated, but every PFO does not have to be operated. You know, PFOs are present in 1/4 of the population. If you take 100 people, out of them 25 will have PFO. You have to make sure that there is no other risk factors in these patients. You have to do their complete workup. You have to rule out any other cause in these patients. And you will grade them into high risk PFOs and low risk PFOs. And it's only high risk PFOs. There's a score called ROPE score, right? In that ROPE score, you are saying the patient should not have hypertension, he should not have diabetes, it should not be a lacunar stroke. So if you get these points and you have more than 7 points, then you are saying he has a high ROPE score, he is at a high risk. But if you have a low ROPE score, you can then observe him. But what I'm saying is that look for a PFO in all young strokes. Many of them you will be able to make a difference to their life. Now, congenital heart disease also needs to be correction, and many of them need anticoagulation with warfarin. And cardiac tumors, I'm sure once in a year you will see 1 or 2 such patients. I have myself seen, I see one cardiac tumor once in a year or once in 2 years. I remember those patients very well. You know, they look like just like any vegetation there, but there is no infective endocarditis. That's a different topic in itself, how to distinguish between a thrombus and a vegetation and a tumor. That is an eco topic. But myxoma is very important, and the secondary prevention for patients with left atrial myxoma tumors is to remove it, to remove the tumor. They don't need any lifelong anticoagulation and all. Interestingly, these patients can metastasize to the brain, and they can metastasize even after you have removed. And those metastases which are in the brain, they don't go away easily. They remain there, yet the patient remains all right. It is a very fascinating subject, the subject of cardiac tumors and their causing stroke. Now, another group is stroke of other determined etiology. Till now, we talked of large artery athero, medium artery athero, cardioembolic, lacune. But there are some strokes which don't fit into any one of them. They are called stroke of other determined etiology, and most commonly seen is strokes due to hyperhomocystinemia. Funnily, the recommendations have always been saying we give Homin to everybody, but they say that even if you give Homin, you are not going to reduce the chances of stroke, because that's what the studies have shown. But I personally feel that we must, there may be no benefit, but there's no harm, because, high homocysteine has a lot of other damages also on the other systems. So we must treat them with vitamin B12 supplements. And then these are the recommendations for ischemic stroke after an extracranial carotid or vertebral arterial dissection. Dissection is a common disease. We thought when we were not aware of it, we would never catch it. But all patients look for dissection, particularly if he does not have a atherosclerotic risk factor, particularly if he is young, particularly if he comes with a headache on one side. If you don't think of it, you will never pick it up. And it can be easily picked up by saying that rat tail appearance on the CT angio or on MRI, you can see semilunar space. And in these patients of dissection, they can be managed with antithrombotic double antiplatelets for 3 months. And after that, you can stop it. Some of the patients who get recurrent attacks of TIA, only few of them who get recurrent, stenting also has to be put. I have had to put stenting in one patient only, but otherwise they are managed well with double antiplatelets, and only for 3 to 6 months. Sometimes for our own comfort, we continue them on a small dose aspirin. Don't miss dissection, it's very common. Then we come to moya moya. Again, I have to say it's very common. Almost every 15 days, I'm seeing 1 or 2 patients. It's a very common disease, even though described in Japan, it's very common. And in this, there's a consensus that whenever if you are lucky to catch a moya moya disease at the level of TIAs or at the stage of seizures, you must offer them revascularization surgery. This is the only condition where EC-IC bypass is evidence-based, not in the atherosclerotic one. And we have got it done in many, many patients. And moya moya, particularly in young people, we must look for it, we must rule it out, and we must offer them the bypass surgery. And sometimes we have to do indirect bypass also. That's in angiomatosis, that very long terminology for that. But this is something which should be missed. Now, this is a new thing. My neuroradiologist, Dr. Anantram, always looks for this. I was not even aware of it. That, we think of normally carotid plaque, atherosclerotic, or we think of carotid dissection. But now a new entity has come, carotid artery web. It's a fibrous tissue, and it is not a cholesterol, right? So we have to be aware of carotid artery web. And the recommendation for carotid artery web is it does not need surgery, it does not need stenting, just antiplatelet agent. It is a class of recommendation 1. With more and more neuroimaging, we are noticing these carotid artery webs. So this is addition to the carotid artery extracranial disease. Fibromuscular disease is again one of the carotid artery disease only. And once again, they have to be managed only with the antiplatelet agents. I'm sure many of you have seen fibromuscular dysplasia. Then dolichoectasia just means a dilated vessel. And that dilated vessel usually does not rupture. Even though it is dilated like aneurysm, but it is horizontally disposed, longitudinally disposed, not rupture, but it becomes a sanctuary of embolization. So for that, the recommendation is to put them on aspirin. It's a reasonable modality of prevention. Now, the other good thing which has come in 2021 recommendation is, and I have particularly liked this very much, is that if you have got a ischemic stroke, particularly young patient, and you find there's a prothrombin gene mutation, you find there's the activated protein C resistance, you find there's the elevated factor 8 level, you find there's a protein C deficiency or S deficiency, antithrombin 3, it is saying it is not necessary to put them on oral anticoagulants. Antiplatelet therapy is enough. And I think it is such a big relief, because based on the survey of literature, they have found that just the demonstration of one of these is not enough unless a patient is having other evidence of DVT or pulmonary embolism, or recurrent strokes in the past, only then. But just because so many times we find a patient comes with protein C resistance and we are lost what to do. But now the guidelines fully support that you can manage only with antiplatelet agent, provided he does not have evidence of other clotting disturbances in time or space. We must keep them under our monitoring, but otherwise they can be managed with antiplatelets alone. What about antiphospholipid antibody? It's a very important risk factor. If it is just an antiphospholipid positivity, then you can manage them purely with aspirin. But if it's a full-fledged syndrome, that means recurrent abortions, and you repeat the antiphospholipid antibodies and the beta-2 glycoproteins and the lupus anticoagulant, and if on 2 different occasions you find there and a patient has a full-fledged syndrome, then they have to be managed with warfarin. The NOACs are not the thing to go. In fact, rivaroxaban can actually harm them. So we have to remember that antiphospholipid antibody, if it is limited, you can give antiplatelet therapy. If it's full-fledged, nothing short of warfarin. We have to manage them with warfarin. Now, another important thing has come that if you get a stroke in the setting of a malignancy, DOACs can be given to them. To consider DOACs, so, the best example would be a patient of TIA and he has a cancer also, and he has a AF also, then it is reasonable to give them DOAC. But if he doesn't have a AF and he has only cancer, then you may even give antiplatelet. Now, sickle cell disease is an important condition, not very common, but some belts are there. I have seen 1 or 2 patients from Visakhapatnam, but it's not very common. But we have to look for particularly children or young adults, and in them, the treatment is repeated transfusions, so that you dilute the defective sickle cell hemoglobin, repeated transfusions, and this is one condition where TCD is very important to monitor their velocities. And then the other thing is that if you have a vasculitis, giant cell arteritis induced strokes, or many times we see CNS angiitis, primary angiitis, in them the main treatment is with steroids. And we can now give monoclonal antibodies. As per them, they have recommended methotrexate or tocilizumab, which are monoclonal antibodies. You can give them, but steroids remain the mainstay. Not aspirin. We can add aspirin, but that is not even in the guidelines. What is in the guidelines is anti-inflammatory agents, if we are sure that they are because of the vasculitis. And there can be infectious vasculitis, varicella vasculitis, cerebral vasculitis, neurosyphilis, bacterial meningitis. I don't know about COVID, not much literature has come about it. Now, these patients also, we have to treat the underlying infection. So if it's a herpes zoster-induced vasculitis, we have to treat with antiviral agents. Right? So then the next is, this is probably one of the last slides. This is about these rare genetic strokes. And one of the rare genetic stroke, and I've seen one patient in my whole life, that is Fabry's disease. That is because of the deficiency of some enzymes, agalsidase beta and all, because of which there's an accumulation of that substance in the skin, in the kidneys and all. And it's very, very expensive enzyme replacement therapy, but it does not get a high recommendation. It says 2B, which means that we are not sure whether it should be given or not. But the best recommendation is that just take care of their overall blood pressure. Their homocysteine, here it says take care of their homocysteine and recurrent, but you need not worry about trying to arrange that enzyme replacement therapy. It does not get a high recommendation. And the last is embolic stroke of undetermined source or cryptogenic source, and about 1/3 of our strokes will be of this, where you don't know where from the embolism has come. And there are many studies which have been done on it. There's a RESPECT study, there's a NAVIGATE study, and the message here is that no need of giving them oral anticoagulants. As of now, as of today, the only thing which has been recommended is to give them simply antiplatelet agent, aspirin. But you must keep on searching the cause. That ES-US may, later on you may find out this was because of an underlying source. But as long as you have not found a source, there is no need of giving them any anticoagulants. Although there is one study called COMPASS study, where they have given oral anticoagulants in a small dose, rivaroxaban plus aspirin, but that was done in the setting of a carotid artery disease, not in the ES-US. So in ES-US, you are comfortable in just managing with aspirin alone. So dear friends, the crux of the secondary prevention of stroke is same what it has been, but there are some new things in 2021. Lifestyle modification with diet and physical exercise is cornerstone. We should never forget it. Even if you give aspirin and if the patient does not modify his lifestyle, that won't work, right? It is everything combined. So lifestyle modification with diet and physical exercise need not be gymnastic exercise. As I told you, even standing intermittently in his whole room also is getting a recommendation this time. Controlling risk factors with appropriate medicines for sugar, for lipids, for triglycerides, for hypertension is important. High dose statins and ecospent for triglycerides. Aspirin plus clopidogrel for 3 months in intracranial stenosis, after which you give only single antiplatelet. Aspirin plus clopidogrel for 21 days in minor strokes or TIAs. Carotid endarterectomy or stenting in carotid stenosis, provided they are disabling and preferably to be done within first 2 weeks by a person who is expert and who has a good track record. And single antiplatelet, aspirin or clopidogrel has to be given lifelong to all the strokes. And if you have got a non-valvular atrial fibrillation, NOACs can be given. Advantages, you don't need any INR monitoring in these patients. And but all other cardioembolic sources, including valvular disease or clot, it may need a warfarin anticoagulation for varying degrees of times. And it is a regular follow-up for constant counseling and checkups which is required. You know, patients are human beings. They forget to take the medicine. Many of the patients, after when they are well, particularly those who have done better, after 2-3 months, they stop taking aspirin. And then they come with a recurrence. I'm sure that must be your experience also. They have to be reminded again and again and again about all these things. That is our job. We are not only doctors, we are also teachers. The meaning of doctor is a teacher in the Latin language. That's where from the word has come. And thank you very much. And I'll be happy for any your comments or discussion at any point. Thanks a lot, Sandhya.
Thank you, sir, for the excellent talk. As usual, a scintillating talk, sir. It's a huge privilege for us to have you in this teaching program, sir. Thank you once again.
Thank you, Sandhya.
Thank you, sir.
So we have some interesting questions for you. Can we take the questions at the end of the session, sir?
Yeah, sure. I'm with you till rest of the program.
Thank you, sir. Thank you so much. It was a pleasure listening to you, sir. Thanks a lot. Now I'd like to introduce the next speaker for the session, Dr. P. Muthukumaran. He has done his MBBS from Coimbatore, and in 2011, he was the best outgoing graduate. He's done his MD Internal Medicine from CMC Vellore in 2015 and DM Neurology from NIMHANS, graduated in 2019. He's done his fellowship in Stroke Rajagiri Hospital, Aluva in 2020, and he's currently working as a consultant neurologist and interventionist at PS Neurocenter, Tirunelveli. To his credit, he has Dr. Balakumar Gold Medal in Pathology, Dr. Nandakumar Gold Medal in Medicine, a GRG Memorial Gold Medal for Best All-Rounder Graduate in MBBS. His areas of interest are intervention neurology, neuroimmunology, and neurosonology. Dr. Muthukumaran, I welcome you to the session.
Thanks, Reshma, for a kind introduction. I would like to thank the organizers for giving me the opportunity to present two very interesting topics today, which are not often we come across in our clinical practice, but nevertheless they are very important. Just give me 2 minutes. Let me share my screen. Okay. My first talk for today will be on stroke in pediatrics. We have all been dealing with adult strokes in a big way, but pediatric strokes are very challenging compared to the adult strokes, just because of the fact that they are having a very, very diverse number of causes for the strokes. So why are pediatric strokes very unique? Strokes, as we know, can occur throughout life, from intra-uterine life to the age-old person can develop a stroke. And there are clinical considerations in children which differ vastly from those in adults. So the common things in adults which we look for, the atherosclerosis, the hypertension, the dyslipidemia, are not the risk factors we would even think of in a child. And clinical considerations also vary depending on the age of the child. So a child which is in a fetal or a neonatal to the infant to a young adult, the causes of stroke vary depending on the age of the child. And they are very interesting. And strokes in fetal life, neonatal life, childhood, all have their own set of issues. So look at this chart, which is actually based on the global burden of stroke. These are the strokes in the age group between 1 to 4 years, 5 to 9 years, 10 to 14 years, and 15 to 19 years. And these first two represent the developed countries. First one is 1990, the second one is 2013. And you can see that the incidence of stroke in the developed countries is actually increasing from 1990 to 2013. And you can see these two, which represent the developing countries. And you see that these two are actually not increasing at all. It is almost remaining the same. Does that actually mean that developing countries have a lower risk of pediatric strokes compared to the developed countries? That is not exactly the reason. The problem is in the developed countries, there is an increased awareness of pediatric strokes. There is an increasing recognition and diagnosis which is happening. And there is an increasing survival of diseases which are leading to these strokes. And there is an increased survival of stroke also. And in developing countries, the biggest problem which we face is actually there is a lag in diagnosis which happens. Many a times it is just written off. Many a times people just don't even think about it as stroke till it is too late. And by that time, nothing can be done about the child. And the mortality also has come down significantly in developed countries to almost 5 to 10%. So looking at the stroke burden in pediatrics. So what would be the stroke burden in pediatrics? What is the ischemic stroke? What are the hemorrhagic strokes? What are the sinus venous thrombosis? So if you take the adult system, the most of the strokes are actually ischemic strokes. The incidence is almost 140 to 160 per 100,000. And you can see in children, it is only 1.2 to 2.7 per 100,000. And the Indian incidence is literally not known. There are no registries at all in India. So basically, it's just a calculated value. It says around 1% of all pediatric admissions and 5 to 10% of all stroke in young adults. They actually belong to the pediatric strokes. We don't have exact data, Indian data available. And the venous strokes is also around 0.6 per 1 lakh per year. And of this venous strokes also, most of them happen, 30 to 50% happens in the newborns, not in the smaller children or in the adolescent children. And perinatal strokes are actually more common than anything else, and that is around 1 in 3,500 live births. And these values of stroke are actually much lesser compared to the adults. So for the adults, this value for ischemic strokes could be somewhere between 140 to 160 strokes per 1 lakh. And the hemorrhagic strokes, which I have not, it's around 1.4 here, will be around 3 per 1 lakh. And venous strokes are much higher. So what is the problem with pediatric strokes? One, what we have been talking about is the delay in diagnosis. So if you look at this data, which is from the US, not from India, you can actually see that between 2000 to 2005, the number of children who came within 6 hours of symptom onset was near 30%. And that fell down between 2006 to 2010 to almost 25%. And in the last one where they have done the study, 2011 to 2015, it has gone up to 45%, which basically means more than 55% of children, even in developed country like US, do not arrive to the hospital at the time when we can intervene for the stroke. So there are multiple reasons for this delayed presentation. The first thing is there is no sudden onset or short duration of symptoms. Many a time the parents do not know that the child has developed some problem. They just think the child is not moving one hand, it's probably normal. He or she will move it after some time. And they don't realize that this is something which is very alarming till it is too late. And that is what makes them seek a delayed help also. And there is a missing awareness in professionals also. Many a times people who they come in contact with in hospitals, it also gets missed during that time. And there is a big difficulty in performing emergency imaging in children because they will never cooperate with you to do imaging. So you have to literally sedate them and do an imaging, or you have to even sometimes go for an anesthesia to do an imaging. On contrast, in the Western world, 28% of the adults arrive within 1 hour of symptom onset and 32% within 3 hours of symptom onset in the emergency. This value will be much lesser in India. I don't have the values for India. Have you ever done a fast for a child? Because doing a fast for an adult is very easy. You can just do it in probably 15 to 20 seconds. But doing a fast for a child is something very difficult. You probably have to coax a child. You have to tell the child to smile, you have to make it smile. You have to tell the child to move the arm. You have to tell the child to just make it squeak. And many times the children can be fussy, they will not do, and you will have no clue whether it is something wrong or the child is being fussy. And the smaller the child, more difficult it becomes. So coming to the pediatric strokes, they can be divided into 3 different groups, the broad major groups, the ischemic stroke, hemorrhagic strokes, and the cerebral venous thrombosis. And what are the etiologies of an arterial stroke in children? So this list is completely different from what we see in adults. The common causes for arterial stroke in children, the first and the second would probably be cardiac diseases and vasculopathies. This we'll be talking in detail. The third one is infections. So infections, very few of the infections will produce a stroke. So the commonest one which causes stroke is varicella, which can produce. Some upper respiratory tract infections can produce. The other things which can produce would be meningoencephalitis and tuberculosis when it produces basal ganglia infarcts because of vasculitis. So that is one area where infections can produce infarcts. And sickle cell disease, as Sir has spoken about, it's a very important cause of pediatric stroke, and it can produce a recurrent stroke in children. And as Sir has said before, you have to maintain the HbS below 30% to prevent any recurrence of stroke in children with sickle cell disease. The other group is thrombophilias. And thrombophilias, again, you have a big group. You have genetic thrombophilias and acquired thrombophilias. The genetic thrombophilias include the MTHFR mutations, the prothrombin 2020, protein C, protein S deficiency, all those things. And the acquired form of thrombophilias will include the antiphospholipid syndromes. And you have genetic causes in children. So a lot of the stomatosis, fibromuscular dysplasias, ACTA2 mutations, NOTCH3 mutations, and you have a whole list of genetic causes which are rare, but they do cause strokes. And then comes the other causes. So you can have simple things like iron deficiency anemia, trauma, radiation. All these things can produce arterial strokes in children. So I'll be talking about a few interesting cases which are rare and which happen mostly in children. I'll not be talking more of things which overlap with adults because I won't have time to do those things. So the first one I'll be talking about is vasculopathies. These also are not a single group. They are multiple different diseases which are grouped under the vasculopathies. The commonest one is probably focal cerebral arteriopathy, which happens in children because of varicella infection. The second probably is dissections, which can happen. Sometimes even infections can lead to dissections of vessels. Moyamoya disease, you have fibromuscular dysplasia, you have vasculitis of large or medium vessels, and the most other very common disease which most of us would have come across is the mineralizing angiopathy of dentifristoid arteries. So coming to focal cerebral arteriopathy, it is probably one of the commonest strokes which we find in vasculopathic strokes which we find in children. So here you have a stenosis which happens at the carotid T. So this is the T junction where you have the internal carotid artery, the antecephalous artery, and the middle cerebral artery, which is like a T. You can see this side, the ICA is normal in caliber. This side is reduced. You can also see the ACA caliber on both sides. Here it is normal, here it is reduced. So this is called as focal cerebral arteriopathy. And it has a very typical stuttering onset. So it is not like the child will come with a stroke on a moment. They can have very stuttering onset weakness, which comes and goes, and then they will just develop a major stroke. Most of these is para-infectious. Almost 1/3 of it is caused by varicella alone, and there are other viruses which also cause these infections. And 19% of them will have primary worsening after they start this problem. 18% of them will have recurrence. And of this group, 24% will have a complete recovery, 45% will have some improvement, and 32% will just stabilize on what they are having. So if you look at this image, which is down, this is called as a black blood imaging with contrast. Here you can actually see the vessel wall enhancement here. This is the normal vessel wall on the right side. Here you can see on the left side the vessel wall which is enhanced. It's very classical of focal cerebral arteriopathy. And 41% of these patients will have a good outcome. So the treatment for this diagnosis would be confirmed. These children would require a CSF, and you have to demonstrate antivaricella antibodies in them. And varicella PCR is also being done in some of these patients. And once it is confirmed that it is because of varicella, then you treat them with acyclovir and steroids. The second one, which we all probably would have seen, is mineralizing angiopathy. This happens in a very restricted group of patients. This is between 6 months to 2 years. And this happens in the basal ganglia only. It doesn't happen in any other places. It is precipitated by a minor head trauma. And it can have a transient hemidystonia, which can happen between the first to the fourth day, which resolves and most often ends up in a hemiparesis. And this is because of a persistent fetal form of mineralization of reticulostriate vessels. This is one condition in pediatrics where you would do a CT scan. Any child who comes between 6 months to 3 years of age who has a basal ganglia stroke, it is imperative that we do a CT scan to demonstrate these things. These white structures which you see are actually mineralized reticulostriate arteries which are going in. And this is seen very clearly here also. So for this, CT is the imaging modality of choice. Most of them do well, and there is a favorable prognosis, and they are started on aspirin. And we have to make sure they don't have any further head trauma also. The next one will be a moyamoya disease. A moyamoya disease is a chronic progressive cerebral arteriopathy instead of transient arteriopathy, which is a focal cerebral arteriopathy. This is a chronic progressive arteriopathy. This happens because of a slowly progressive bilateral occlusion of terminal ICA and development of collaterals in the base of the brain. This is a classical puff of smoke you get. The ICA is very much narrow, and then you have a lot of collaterals which are developing in the base of the brain and giving this appearance of the puff of smoke. It's more common in females than males, usually bilateral, but it can be unilateral at onset. And if it comes without any other disease association, it's called a primary moyamoya disease. If it comes with an association, it can be associated with Down syndrome, sickle cell disease, Alagille syndrome, Williams syndrome, NF1, postcranial irradiation. Then you call it as a secondary moyamoya syndrome. The treatment for this is basically doing what is called as EDAS or EDAMS. So this is an encephaloduro-arteriomyosynangiosis. Basically, they'll open the skull, open the dura, and then they'll take a flap either from the temporalis muscle, and then it is just put over the brain so that a lot of collateral channels will form, and the patient will not have any further stroke. There are other differentials which can happen in these vasculopathies. One is fibromuscular dysplasia. It's less than 1% of the arteriopathies which can happen in children. Only 25% of them will have string of beads appearance. You can see the narrowing and dilatation of the vessels here. The other one is an intracranial dissection. This can happen idiopathically between certain connective tissue disorders, also can happen in certain infections. These are other vasculopathic illnesses. The second one will be cardiac illnesses. I will not go in detail into it. It's like any other cardiac embolism which can happen. It happens in children also. So you have congenital acyanotic or cyanotic heart disease, cardiomyopathies, and acquired can be again cardiomyopathies, RHD, infective endocarditis, cardiac catheterization, arrhythmias. All these things can cause. So coming to imaging in children, what should we actually choose? So should we choose a CT or should we choose an MRI? So if we have to choose between CT and MRI, MRI is a better primary diagnostic modality in children. Because as we have seen, the atherosclerosis is not a cause in children. You have vasculitis, you have dissections, you have so many other causes which cause a stroke other than a thrombus which is going in, occluding a vessel. So the primary modality here would be MRI, if possible. CT can also be done. Diffusion weighted images with ADC, FLAIR, T2 axial, T1 axial, SW, and MRI would be the sequences which we would require for the beginning. If there is no abnormality, then we stop there. It is not a stroke. We have to look for stroke mimics. I'll come to stroke mimics later. So if it is a stroke, then you go to look for a penumbra. Is there a penumbra? You can do a perfusion imaging. If you think it's a dissection, go for a contrast enhanced MRI of the neck, a fat saturated axial neck imaging, and top of the MRI. And if it is vasculitis or inflammation, you go for a contrast enhanced T1 inversion recovery image or a dark red image. And coming to the management of acute ischemic stroke in children, so antiplatelet therapy is the mainstay. In children, aspirin is the most preferred drug. There is a growing evidence for clopidogrel. The other things like ticagrelor and prasugrel, they don't have much of evidence in children. And anticoagulant therapy might be needed for some of these diseases. It can be done with either unfractionated heparin or low molecular weight heparin. So where we really require an anticoagulant therapy is in dissections, cardioembolic strokes, and in hypercoagulable states. Coming to intravenous thrombolysis and mechanical thrombectomy, these are very contentious areas in children because children, they form the vulnerable group. So doing an RCT on children is extremely difficult, and getting a consent signed for them is difficult. So that is the reason why most of the studies are done in people more than 18 years, and we really have a positive studies in children. But still, there are some guidelines. So this is from the Royal College of Physicians, UK. So IV thrombolysis can be considered in any child more than 8 years of age, may be considered in 2 to 8 years of age, if acute ischemic stroke has occurred as defined by these things. So there is an acute neurological deficit consistent with arterial ischemia. There is a pediatric NIH score more than or equal to 4 or less than or equal to 24. And treatment can be administered within 4.4 hours of symptom onset. And there is no intracranial hemorrhage, which has been excluded by CT or MRI. And CT or MRI should also demonstrate either a large vessel occlusion or an infarct, which is subtle. And this pediatric NIHS is very similar to the adult NIHS. Only thing, those questions are more tuned to get responses from children who are as young as 2 to 5 years of age. So they have a different set of questions, but they are scored in a very, very similar way to the adult NIHS. Coming to the mechanical thrombectomy can be considered in acute stroke due to large vessel occlusion. In patients between age 1 to 18 years, this is the latest recommendations from the European societies. But the level of evidence is only C and class 2B recommendation. And coming to the recanalization therapies, what has been done so far? This is a French national registry. Till 2017, they have published 13 cases, 3.7 to 16.6 years. 9 out of 13 had large vessel occlusion. 11 out of 13 were given RTP, intravenous altiplase, and no bleeding complication. Only one child died because of malignant infarction, and there was a favorable outcome in almost 11 out of 12 children. And this is a Switzerland Swiss neuropediatric registry where they have had 150 children with pediatric NIHS score of more than 4, 5 IV lysis, 11 endovascular treatment, and children with recanalization. They found that older children did well. 11 years is 6.5 years. The pediatric NIH score of 13.5 is 8, and only the pediatric NIH score was predictive of outcome. The causes of recurrent acute ischemic stroke, the recurrence in adults actually is lesser compared to recurrent strokes in children. There are certain conditions where you can get recurrent strokes in children. The arteriopathy, the post-infectious or inflammatory arteriopathy, which we are talking about previously, the sickle cell associated arteriopathy, Moyameyer disease, congenital heart disease, CNS vasculitis, thrombophilic states, and underlying genetic or metabolic disorder. These are the children who can develop recurrent acute ischemic stroke. And what is the chance of recurrence in stroke? Most of the recurrences, 75% of them take place within the first 3 months of the index stroke, and it just tapers down after the 3 months. And what kind of diseases produce a high chance of recurrence? You find that if there is a definite arteriopathy, the risk is almost 5 times more than having any other cause of stroke. The 1 month stroke recurrence is almost 7%, and 12 month stroke recurrence is almost 12% in this study. And there are certain stroke mimics in children which we have to be very careful of, which can be missed and interpreted as stroke. Migraine, infections where it is not actually causing a stroke, like encephalitis or brain abscess or a neurocysticercosis, which can present with focal deficits. Demyelination can be ADAM, MOG, NMOSD. MS is rare in children. Thoughts paralysis. Inborn errors of metabolism, like mitochondrial disorders, MELAS, urocycle disorders, fatty acid oxidation defects, organic acidemias. Hypoglycemia, alternating hemiplegia of childhood, post-viral cerebellar ataxia, intracranial space accumulation. All these can mimic acute ischemic strokes in children. Coming to the outcomes, the motor outcomes in children, what is very interesting is as the age grows, like if you have a child who is very young, the motor outcomes are bad. But if you have a child who is more than 10 years, then you actually find more than 55% will not have any hemiparesis at all. They improve almost completely. This is a stark contrast to the adult population where the more older you are, the more likely your deficit will not improve. But in children, it's exactly the reverse. And the same for neurocognitive outcomes also. As the child develops a stroke older or in the adolescent period, the chance of the child having a normal cognition is much higher than when a child develops a stroke in the infancy or in the preschool age. So the most common things where they found abnormalities in the study were in visuoconstructive areas, short-term memory, and then processes. Cognitive scores will improve with age at which the stroke occurs. Coming to the venous strokes, again, these are very common in children. Almost they have a similar incidence, the arterial strokes, the venous strokes, and the hemorrhagic strokes. So the most common cause is actually systemic illness, fever, diarrhea, dehydration. This is the most common cause in children. Followed by that will be infection, meningitis, mastocytitis, and procoagulant states, hematological disorders, malignancy, drugs, cardiac diseases, and chronic diseases like nephrotic syndrome and inflammatory bowel disease can also cause venous strokes. And these are a study which was done and published in 2017, which looked at the prevalence of which risk factor caused the venous strokes in children. As we have expected, you can find that acute systemic illness, meningitis, protraumatic states carry the maximum number of children who had developed venous thrombosis, and the rest all is all very minimal. Clinical features are variable based on whether they are neonates or children. Neonates, you only can find a depressed sensorium, seizures, focal deficits, bulging fontanelle. If it is slightly older children, they can complain of a headache, irritability, depressed sensorium, sixth nerve palsy, papilledema, seizures, focal deficits. And if you have a child with seizures, focal neurological deficits, and altered sensorium, then you will have to think of raised ICP. And CVT will also come into the list. So diagnosis is usually done by an MRI, which is better compared to a CT. CT has a high sensitivity, but it cannot show the area of brain which has been damaged. And you look for always for associated things like meningitis or sinus infections, which can be seen on any imaging modality you do. Here in the CT, you can actually find deep system impact, where you find bilateral hypodensities in the thalamus. Management is systemic anticoagulation. Again, the same sort of whether you can use an unfractionated heparin or a low motivated heparin. Duration of treatment depends on the inciting cause. You have to, if it's a provoked CVP like a meningitis which causes CVP or a mastocytitis, it is enough to give anticoagulation only for 3 to 6 months. If it is unprovoked in the absence of thrombophilic risk factors, then you have to give for around 6 to 12 months. And in the presence of any thrombophilic risk factors, you have to ideally give it lifelong. Hemorrhagic strokes in children happen because of a few etiologies. Most common among them is vascular anomalies, AVMs, cavernous malformations, and aneurysms. These are the common cause of hemorrhagic strokes in children. Followed by that will be hematological abnormalities, thrombocytopenia, hemophilia, von Willebrand disease, coagulopathies, vitamin K deficiency, or iatrogenic. And small amount by brain tumors and idiopathic in around 19% of cases. And treatment for hemorrhagic stroke would be an immediate stabilization and supportive care, and vitamin K, fresh frozen plasma, or recombinant clotting factor therapy, and neuroradiological interventions or surgical repair for any malformation or aneurysms which can be present. And conclusions, pediatric strokes have very diverse causes and very varied clinical presentations. So we have to be aware of those causes and the clinical presentations. The clinical features will vary based on the age group of presentation and the type of stroke. And they require a very diligent observation and examination to pick it up, because the children, many a times, you might miss it up. A child who is drowsy might be missed up for a child who is sleeping. So it is a child who does not move a hand might be missed for, he does not like to move the hand for some time. And there is almost always a delay in presentation, which is unavoidable because it's picked up, missed many of the times. And there is a lack of information regarding the interventional management in childhood strokes, again, because of positive trials, as they are a vulnerable group, and consent issues. So thank you very much for the patient listening. I think I'll continue with my other talk also and finish it. This is another interesting topic which was given to me. It is a COVID and stroke, something which is actually happening, and we all do not know why this is happening initially. Now we have a fairly decent idea of what is happening. So COVID-19 is a respiratory illness caused by the SARS-CoV-2 virus. It's primarily a respiratory illness, but has quite a lot of systemic involvement. As the number of cases grew a lot, the CNS and PNS disorders are found to be associated with COVID-19. And the influence of cerebrovascular disorders actually came to light when young adults who had no other risk factors started developing strokes. This is when people started thinking about strokes in a very serious way with patients with COVID. Because a lot of the older people had risk factors, so many were attributed to the risk factors and not to the virus per se. So is it really a problem? Does COVID increase strokes? So respiratory infections, anything, even annual influenza, can increase the risk of stroke by almost 3.2 to 7.8 fold. And this was one study which they have done in New York in a single hospital, where they looked at the year where they had the COVID and the previous years where they had influenza. And they found the incidence of stroke was 1.8 in the year with COVID and 0.2% when they had an influenza outbreak. And incidence of stroke in hospitalized patients is 1.8% with COVID. And as with SARS-CoV-1, which happened previously, it was only 0.75%. And in patients with sepsis, it's only 0.68%, even though all these people had virus. So when we talk of ischemic strokes in COVID, what is very important is a virtuous triad. So we have to know three major factors which always are important for developing a thrombosis. One is hypercoagulability of blood. The other is a vascular endothelial damage. And the third one is flow stasis. So when we come to COVID-induced stroke, what are the pathophysiologies which happen? So these are the four major factors which are implicated. The first one will be an ACE2 dysregulation. The second one is a coagulopathy which happens. The third one is a vasculopathy. And fourth one is cardiogenic. So ACE2 dysregulation is one key component because COVID enters the cells by attaching to the ACE2 receptors. And ACE2 receptors are expressed in a lot of areas: the lungs, the kidneys, the GI tracts, the endothelium, the lymph nodes, and even in the bone marrow, spleen, everywhere it's expressed. And SARS-CoV-2 attaches to the ACE2 receptor, reduces the ACE2 levels, and increases the antithrombin 2 levels. And this hypertensive peaks happen because of the increased antithrombin 2 levels, which can probably cause the hypertensive hemorrhage. And this also activates the pro-inflammation cascade, this increased AT2 levels, which causes decreased perfusion in the ischemic zones and causes larger informed volumes. There is an impaired endothelial function, mainly the production of nitric oxide from the endothelium is impaired. And all these things lead to the dysregulation because of AC. So this picture will very clearly explain. Here is the normal renin-angiotensin pathway. Angiotensinogen gets converted into angiotensin 1 by renin, which gets converted into angiotensin 2 by angiotensin converting enzyme. And the angiotensin convert 82 or angiotensin 2 gets converted by ACE2 to angiotensin 1 to 7. It's a peptide, which is a breakdown product. So what actually happens is once ACE2 when the SARS-CoV-2 binds to the ACE2 receptor, it causes a downregulation of ACE2. So the balance gets disturbed. The ACE to ACE2 balance gets disturbed, which leads to increased levels of AT2. And this increased levels of angiotensin 2 is pro-inflammatory. It causes fibrosis, it causes apoptosis and vasoconstriction. And this is the reason why we develop all these problems in COVID. And there are certain populations which are more prone. That is also because of this DD genotype, which is found in African American, Italian, Spanish, and French. And this actually gives them an increased ACE levels. So when ACE2 comes down, they are actually at the higher risk for developing all these complications. The second factor is coagulopathy, which causes an increase in cytokines, the IL-1, IL-6, TNF alpha. There is an activation and damage to the endothelium, which causes a tissue factor expression, downregulation of the protein C, activation of the complement system. There are intravascular factors which cause initiation of coagulation. The tissue factor will combine with factor 7A and will activate the factor 7A pathway. The activation of platelets. There are white blood cells which are activated, the neutrophils. They form what is called as neutrophil extracellular traps, or also called as nets. And these are very important in thrombosis, not only in COVID, but also in other diseases. And there is a dysregulation of natural anticoagulant pathways and fibrinolysis. And there is also an incidental APLA antibody positivity, but nobody really knows whether APLA causes coagulopathy in this setting or it is just a bystander which is coming first. And what is very surprising is this increased fibrinogen levels. When we talk of coagulopathy, consumptive coagulopathy, which COVID has a feature of, the one important factor is actually low levels of fibrinogen. But on the other hand, in patients with COVID, the fibrinogen levels increase actually. And you also find an increased D-dimer. So there is an increased fibrinogen level, there is an increased fibrinolysis, which causes an increased D-dimer, increased fibrin degradation products, the thrombocytopenia which happens, and there is an increase in prothrombin time also. And this increase in fibrinogen levels also causes an increase in viscosity, which creates a situation like a hyperviscosity syndrome inside the blood system. So this is a picture which explains the same thing. And the third thing is a vasculopathy. So the COVID directly invades the vascular endothelium. So it just attaches to the receptor, the ACE2 receptor, and invades the endothelium. And once it invades the endothelium, it damages the cell. And it causes a lymphocytic infiltration into the endothelium. And this produces what is called as a lymphocytic endothelitis. And this lymphocytic endothelitis are found in multiple organs, not wherever there is a blood vessel, wherever there are ACE2 receptors. So these are found in kidneys, hearts, lungs, small bowel, and they are associated with the widespread endothelial dysfunction and apoptosis of the endothelium. And this widespread endothelial dysfunction is what causes a microcirculatory failure, and this finally leads to the multi-organ dysfunction. And COVID is known to produce large artery thrombosis. So whether these are because of this vasculitis or because they are embolic is something which is still questionable, but both the causes are being told for larger cell thrombi, which form especially the CCA or the proximal IC, where we get large thrombi with a huge load. This is another picture which explains the vasculopathy. This is a pulmonary endothelium where you can see it attaches the blood in the vessel wall.
Interrupt you, sir. You have 5 minutes left for your presentation, sir.
Okay, fine. Then I'll just skip this. I'll go to the cardioembolism. There is a direct myocardial injury related to SARS-CoV-2, which causes arrhythmias, decompensated cardiac failure, atrial fibrillation. And there is cardioembolism and stroke because of that. And paradoxical embolism is also a very important thing which happens because of DVT and PE, which are very common in COVID. And they enter the cardiac or pulmonary shunts. Many of these asymptomatic people who have shunts have developed strokes through a cardioembolic phenomenon, especially young adults with COVID. And coming to the cerebrovascular complications, there are ischemic stroke, the hemorrhagic stroke, and the venous thrombosis. And this is basically summarizing what I've told before. Coming to the COVID-induced ischemic stroke, there are few classical features. It forms 80% of the COVID-related strokes. There is an embolic pattern which is multi-territorial arterial distribution. And you also find large vessel occlusions, and there is a large thrombus burden, and there is an easy fragmentation. And you have unusual locations of stroke, like corpus callosum, where you see this is in the same patient, you have a corpus callosum stroke. And these are more prone to hemorrhagic transmission. Whether this is viral related or because of use of anticoagulants is not very clearly. Coming to the stroke subtypes, these are two studies which have been done. One by Matthew et al. From Bangalore, other was in the US. So we find that the most common strokes are undetermined, which is 48% in India and 22% in the US. And cardioembolism was 27% in the US and 5% in India. Probably the Indian studies we have missed out on cardioembolism. The large arteries was around the similar percentages, 36% here and 32% in the US. COVID-induced hemorrhagic strokes form another 15% of the strokes, usually lobar hemorrhages, multifocal hematomas. Coagulopathy is the most likely cause. Elevated D-dimer is a risk factor. And this also happens in very atypical locations like corpus callosum and dextrocortical regions. And COVID-induced CVT is very, very minimal. It's only around 5% of the strokes. Cortical and deep CVTs, cortical vein and deep CVTs are more seen frequently. And if there is a hemorrhagic deep CVT, differentiating it from acute hemorrhagic necrotizing encephalitis can be difficult in the setting of COVID. Management of COVID-related strokes, you have to go for thromboprophylaxis. D-dimer less than 500 nanograms per ml. You can either choose enoxaparin 40 mg once daily or 1 mg per kg 12th hourly. If it is more than 500, then it's only enoxaparin 1 mg per kg 12th hourly. If you are going for an IV thrombolysis in a patient with acute stroke, you have to check LFT and coagulation parameters. You have to check if there is any coagulopathy, risk and benefit should be assessed, and then go for thrombolysis. Mechanical thrombectomy is again very difficult in COVID. You have to do intubation and negative pressure room, and you have to anticipate delays. So you have to balance the risk versus benefit. So this is another chart which actually tells the same thing. So what are the outcomes related to COVID? It's a very high mortality rate, almost 30 to 45%. And you can actually find that in the age group who are older have more deaths, and who have been less than 50 have the maximum number of better outcomes. And coming to other important thing, the vaccine-induced prothrombotic immune thrombocytopenia. The two implicated vaccines are the AstraZeneca and the Johnson & Johnson vaccine. And the risk of VIPIT is around 1 in 26,000 in the study from Norway for the AstraZeneca vaccine. And for J&J from the US is 1 in 533,000. It happens 5 to 24 days after vaccination, and it is because of anti-PF4 antibodies similar to vaccination. What is more important is it causes cerebrovascular disorders. Most common is actually venous thrombosis, which is not common with actual COVID infection. Actual COVID causes arterial strokes. Vaccines cause venous strokes. So venous thrombosis, cerebral venous thrombosis, in the descending order, the first thing maximum is cerebral venous thrombosis, then it's plastic vein thrombosis, adrenal vein thrombosis, and pulmonary embolism. And arterial thrombosis is very, very less compared to venous thrombosis, usually MCA territory or an acute limb ischemia. And CVST after vaccination, it's in the European Medical Association registry, 213 cases, 187 after AstraZeneca, 26 after J&J. Thrombocytopenia happens in 57% of AstraZeneca vaccine, 0% in J&J vaccine. Mortality is very high. It's around 38% in patients with AstraZeneca. And if you take in the subset of who had thrombocytopenia, mortality climbs to 49% of the patients. And in J&J, it is around 20%. And there was a pre-COVID group, the people who had received the vaccine but had tested prior for COVID, and the mortality was only around 3%, even if they developed VIPIT. So managing VIPIT, you have to give anticoagulations. The preferred choices are Novax, apixaban, rivaroxaban, and edoxaban. Dabigatran may be used. Fondaparinux also can be used. IVIG 2 grams per kg should be given over 2 days. Plasma exchange for refractory cases. And avoid platelet transfusion unless it's absolutely necessary. Arterial strokes after vaccination are very rare. Only few cases are reported. And 3 cases are reported after AstraZeneca by Halal Mayhan. So coming to the conclusion, SARS-CoV-2 virus significantly increases the risk of stroke in patients who get infected. And ischemic stroke is commonest, followed by hemorrhagic stroke and venous thrombosis. Mortality due to strokes is much higher than those people who develop strokes without COVID. And COVID vaccines also increase the risk of developing cerebral cortical venous thrombosis. And though the risk is quite low, mortality in such cases is very high. And management of cerebrovascular disorders is also complicated by underlying coagulopathy in patients with COVID. Thank you very much for the patient listening.
Thank you so much, Dr. Muthukumaran. I think it was a very lucid and elaborate presentation. We'll take the questions at the end of the session. I request you to please stop sharing the screen.
One minute, I'll just stop.
Now I'd like to introduce the next speaker for the session, Dr. Akanksha Chaudhary. She has done her MBBS, MD and DM Neurology from Dr. SN Medical College, Jodhpur, and she's worked as a senior resident in Deccan College of Medical Sciences, Hyderabad. Currently, she is the Epilepsy Fellow at KIMS Hospital. She has to her credit 13 publications, including publications in international journals, and her areas of interest are epilepsy and stroke. Dr. Akanksha Chaudhary, I welcome you to present your session.
Hello everyone, I'll just share my screen. Is it visible?
Yes, clear, Dr. Akanksha. Go ahead with your question.
Good afternoon, everyone. And thank you, Sandhya ma'am, for giving me this opportunity. My topic is stroke in pregnancy, lactation, and kidney disease. We'll begin with stroke in pregnancy and lactation. Incidence of stroke in pregnancies is 30 in 1 lakh pregnancies, is around 30. It's 3 times more common among pregnant women than the non-pregnant individuals and non-pregnant women of the age 15 to 44 years. Most of the strokes, they occur at peripartum or in the 6 weeks following delivery. Most of the strokes in the general population, they're ischemic, as we all know, 80 to 85%. But in pregnancy, ischemia, hemorrhage, and venous thrombosis, they have a similar contribution to the etiology. This difference is attributable to the younger age profile with a greater incidence of CVT and ICH and relatively fewer ischemic strokes compared with the general population. Also, the residual disability is higher in hemorrhagic stroke compared with ischemic stroke events in pregnancies. Fatality in hemorrhagic stroke of pregnancy is 13.9% compared with 3.4% in the ischemic stroke in pregnancies. Risk factors of stroke in pregnancy. Most of the risk factors are the same as without pregnancy. Some additional risk factors are there. Hypertension, which could be pre-existing, gestational, preeclampsia, eclampsia, diabetes, valvular heart disease, hypercoagulable disorders, inherited one or secondary, sickle cell disease, lupus, tobacco and other substance abuse, migraine. Conditions associated with pregnancy which increases or complication of pregnancy which increases the risk of stroke are hyperemesis gravidarum, anemia, thrombocytopenia, PPH, transfusions, fluid and electrolyte disorders, infections, and non-modifiable risk factors like age more than 35 years, African American ethnicity. The pathophysiology behind the increased risk of stroke in pregnant women are hemodynamic factors, physiological changes during pregnancy, which predispose to a state of hypervolemia. There's increased circulatory demands, decreased blood pressure because of decreased systemic vascular resistance, increased venous stasis is there, thereby changing the hemodynamic landscape. Changes in coagulability. Physiological changes during pregnancy, they are believed to shift the balance towards a more hypercoagulable state. These changes in prothrombotic factors are greatest in the 3rd trimester and they return to baseline at 3 weeks postpartum. Around the delivery time, it is said that these coagulation factors are secreted more because the placenta is going to disrupt, and to prevent excessive bleeding, more prothrombotic factors are secreted. Connective tissue changes. Several studies in animal models, they have suggested that cerebral arterial architecture changes during pregnancy leads to decreased collagen, decreased elasticity, and distensibility. It is unclear how these changes they translate to humans, but in the setting of hypervolemia and increased cardiac demands, the cerebral arteries may not be able to compensate, leading to theoretical increased risk of hemorrhagic infarction. Investigations. A stroke workup as without pregnancy, it includes initial CT head with standard shielding to eliminate the possibility. No, it's written with standard shielding. Its initial CT is done to eliminate the possibility of hemorrhagic infarction, and it should be performed in pregnant women in most cases. In cases pregnant women, if we follow the procedure of standard shielding, the risk of radiation to the unborn child is very less. And initial evaluation is actually preferred CT because in many centers, although the MRI is not available, it may take time. And since hemorrhagic infarction contributes to a majority of in strokes in children, so it said that initial CT head should be performed. MRI of the brain without contrast was obviously be a better investigation to determine the location, extent of the stroke, and provide the evidence as to the acuity and at times the etiology of the infarction. Other investigations which should be performed are 12-lead ECG for finding out the etiology in almost all the cases, many cases, 12-lead ECG for atrial fibrillation, cardiac ischemia, 24-hour cardiac or Holter monitor for atrial fibrillation, prolonged cardiac monitor, implantable loop recorder in paroxysmal atrial fibrillation, transesophageal echo in patent foramen ovale, transesophageal echo with bubble test and PFO with DVT when it can actually go to the brain, full blood count, urea and electrolytes, liver function test, uric acid, coagulation profile, preeclampsia cases, they help in that, lipid profile in hypercholesterolemia, thrombophilia screening in inherited and acquired antiphospholipid syndromes and inherited thrombophilia. Carotid and lower limb Doppler, they benefit in venous thromboembolism. Although thrombophilia screening, inherited thrombophilia, only the genetic mutation they help. Otherwise, so they are normally they should be done after the delivery, because in any case, pregnancy itself is a prothrombotic condition. Management. IV thrombolysis. As per current American Heart Association or American Stroke Association guidelines, IV administration of RTPA may be considered in pregnancy when the benefits of treating the moderate to severe stroke they outweigh the increased risk of uterine bleeding. Pregnant women, they have generally been excluded from all the RCTs which have been done for RTPA. Antenatal patients should be observed for vaginal, and if in those patients whom the RTPA is given, they should be observed for vaginal or intra-abdominal bleeding, pain, and further neurological signs in case if there is a hemorrhagic transformation. The safety and efficacy of thrombolysis in the early postpartum period, less than 14 days after delivery, are not well established. A history of major surgery within the preceding 2 weeks is a relative contraindication for systemic thrombolytic therapy. Level of thrombolytic agents in milk, they are highest in colostrum and they decrease rapidly during the first week. No information is available, however, on its safety during breastfeeding. Mechanical thrombectomy. There are no RCTs done in pregnant women of mechanical thrombectomy. There are only case reports or publication. 2 publications, they have reported 4 antenatal cases of severe stroke which were treated with thrombectomy and they had good outcome, both the short term and long term. Only one of the patients received thrombolysis prior to thrombectomy. All the 4 women continued their pregnancy to term with no fetal complication. Mechanical thrombectomy, in cases like mechanical thrombectomy, doesn't expose you to the increased risk of hemorrhage. So it said it may be a better option for both the women and her children, her child. Secondary prevention. According to the American Heart Association, American Stroke Association guidelines, women at increased risk of stroke in whom antiplatelet therapy would like to be considered outside of pregnancy, they may be considered for unfractionated heparin or low molecular weight heparin during the first trimester, followed by low-dose aspirin in the second and third trimester. The current consensus is to temporarily interrupt statin therapy preconceptually and throughout the pregnancy. The timing of starting or restarting the statin therapy postnatally should be based on individual circumstances with regard to specific risk factors. Postpartum management. The postpartum period is the highest, The postpartum period is the highest risk period for venous thromboembolism and stroke. Anticoagulation should be continued for at least 6 weeks postpartum, depending on the timing and etiology of the stroke. Although the role of routine post-stroke thrombophilia screening in general population is unclear, factor V laden heterozygosity and persistent lupus anticoagulant is associated with increased risk of transient ischemic attacks, amaurosis fugax, and ischemic stroke. The presence of thrombophilia also has significant implications for future pregnancies. A complete thrombophilia screen should be arranged 6 weeks postnatally to ensure optimal anticoagulation in future pregnancies. Warfarin, LMWH, aspirin, they are safe to take while breastfeeding. Clopidogrel is classified as category B based on limited animal data. Therefore, breastfeeding should be encouraged. My second topic is stroke and kidney disease. Renal failure itself is a potent risk factor for stroke. The risk of stroke is 5 to 30 times higher in patients with chronic kidney disease, and especially those patients who are on dialysis. Case fatality rates are also higher, reaching almost 90% in patients who are on dialysis. There are notable differences in the type of CVA in dialysis patient versus the general population with higher prevalence of hemorrhagic CVA. Comorbidities, hypertension, diabetes, dyslipidemia, atrial fibrillation, they are all highly prevalent in CKD population. In fact, atrial fibrillation has twice or thrice more prevalence in CKD patient compared to the general population. Factors which are specific to CKD: accelerated atherosclerosis, vascular calcification, effect of uremic toxins, post-thrombotic, prothrombotic tendency, impaired cerebral autoregulation. Outcome of stroke in chronic kidney disease and dialysis. Renal impairment is associated with a greater neurological deficit following ischemic stroke with a higher risk of hemorrhagic transformation, a poor functional outcome, and greater mortality. In patients with hemorrhagic stroke, moderate to severe CKD has been associated with 2.3 times greater hematoma volume. Stroke management in chronic kidney disease patients. Clinical trials testing TPA for acute ischemic stroke, they did not specifically include patients with CKD and end-stage renal disease. The US National GET with the Guideline Stroke Registry, they analyzed the association of CKD with key hemorrhagic outcomes after IV TPA for acute ischemic stroke. The study found that compared to those patients with normal kidney function, those with CKD, they were more likely to die in hospital or have an unfavorable discharge functional status. The risk of symptomatic hemorrhage did not actually lead to the increased mortality. It was because of the CKD related factors that were responsible after IV TPA. These findings imply that the presence of CKD alone should not be a contradiction for administration of IV TPA for eligible patients. Stroke prevention
Sorry
in
to
chronic
interrupt you,
kidney
ma'am.
disease.
You have 5 minutes left, ma'am.
Yeah. Stroke prevention in chronic kidney disease and dialysis. Control of hypertension remains the cornerstone of primary as well as secondary stroke prevention in the general population as well as in patients with non-dialysis CKD. No optimum targets for BP control have been defined for hypertension control in dialysis patients. Clinical guidelines, they advocate the use of antiplatelet therapy for the presence of ischemic stroke, and there is evidence supporting its efficacy in patients with non-dialysis CKD. The risk of bleeding with prophylactic antiplatelet agent is augmented in end-stage renal disease, and they have to be used with caution. Stroke thromboprophylaxis with oral anticoagulants like warfarin or newer agents with dabigatran and rivaroxaban, they are recommended for patients with atrial fibrillation with CHATS2 score 2 or more than 2. use of statins as a prophylactic agent remains a matter of debate. Thank you.
Thank you, Dr. Akanksha. It was a very lucid and elaborate presentation. Thank you. I request you to stop sharing your screen.
Yeah. One second.
Now I'd like to introduce our next speaker, Dr. Niranjan Mahajan. He has done his MBBS at GMC Miraj, MD from Dr. VMGMC Solapur, and DM Neurology from NIMHANS. He has done fellowship in two subspecialties. One is neuromuscular diseases from NIMHANS, and currently is a fellow in neurointervention and stroke from Narayana Hridayalaya, Bangalore. His areas of interest are stroke, neuromuscular diseases, and epilepsy. To his credit, he has multiple research papers and book chapters. I'd like to invite Dr. Niranjan Mahajan for his presentation.
Thank you, Dr. Reshma. Am I audible?
Yes, sir. Yes, you're audible.
Okay.
I request you to please
Can I share the screen now? Is my screen visible?
Yes, sir. It's visible.
Okay. Okay. So my topic is venous strokes, and I'll be presenting this on behalf of my team. So a 21 years old alcoholic presented with a history of 7 days headache with focal seizures and drowsiness of 1 day duration. This was a CT scan. So in this, we can see there is some focal hyperdensity suggestive of a bleed. And in the contrast study, we can see there's a thrombus in the superior sagittal sinus. Here, this is an empty delta sign. On the background of contrast, there is a clot here. Okay. So this was a MRI done later on when the patient was worsening. So we can see there is an area of diffusion restriction in the frontal region. So patient was started on low molecular weight heparin twice a day. Though on anticoagulant, he worsened progressively over the next 3 days, and he had status epilepticus despite multiple anti-epileptics. He was started on midazolam infusion. A repeat imaging showed increase in size of the diffusion restriction, a bleed, and again venogram showed persistent thrombus in the SSS, the superior sagittal sinus. So he was taken up for intervention from our side. So here we can see there's a microcatheter placed in the anterior part of the superior sagittal sinus. We can see there's no contrast opacification from almost the anterior 2/3 of the superior sagittal sinus. This was a microshoot. Microshoot shows that there is some partial opacification with filling defect in the anterior part and in the posterior part as well from the microcatheter. So he was taken up for in situ thrombolysis and urokinase with heparin infusion intrasinus in the anterior SSS was initiated. It was given for 24 hours. He had no further seizures. His sensorium improved and he was discharged without any deficits. This was another 73 years old alcoholic with history of new onset seizures, headache, and he had sustained a trivial fall in the bath without obvious head injury. He had progressive drop in sensorium for the next 2 days. He was a known diabetic and no other comorbidities. He was brought in a stupor state and with paucity of movements of all limbs to deep pain. So this was his MRI, which showed involvement of bilateral thalami and the left midbrain as well as the medial temporal lobe. So he was diagnosed with CVT. The MR images are not shown here. So the angiogram here shows that the straight sinus, the vein of Galen, and the internal cerebral veins. Normally, the internal cerebral veins will be visible here. The vein of Galen will be visible here, and the straight sinus is faintly opacified here. So he was taken up for in situ thrombolysis again, and if possible, thromboaspiration. So a guiding catheter was advanced from the internal jugular vein into the superior sagittal into the sigmoid sinus and the transverse sinus, and through it into the straight sinus. This was the micro catheter which was placed in the straight sinus, and a micro shoot revealed that there is just faint contrast opacification owing to a thrombus in the straight sinus and the deep system. So in situ thrombolysis was given for this individual as well, and here we can see the vein of Galen is being opacified, inferior sagittal sinus, and this is a straight sinus that is being opacified. So there's partial resolution of clot after in situ thrombolysis with urokinase and heparin. This was the CT brain during his follow-up after a period of around 7 days, when he had some mild worsening, but he had improved, transient worsening, and he had improved out of that. And he had wide fluctuations in the INR on acetylene. So he was started on apixaban because he was put on RT. So dabigatran cannot be given as we cannot open the capsule. And once the capsule is opened and given, the absorption is bioavailability of the drug is unreliable. That's why apixaban was given for this patient. On apixaban, he had PR bleeding, and he was detected to have rectal ulcer with hemorrhoids, which was packed by the gastrosurgery team. And the NOAC was withheld for 2 days. It was covered with intravenous heparin for 1 day and restarted on apixaban with no new bleed. He was planned for hemorrhoidectomy at follow-up. And at discharge, he was ambulant and verbalizing. So this is his pic when he was about to be discharged. He was fully conscious, and he was ambulant with the tracheostomy as well as RT in situ. This is another patient, 38 years old male, who presented with history of acute onset of headache, vomiting of 3 days duration, polycythemic, alcoholic. He had multiple seizures after admission, and he landed up into stupor and right-sided paucity on second day of anticoagulation. That is almost 48 hours after anticoagulation, it worsened. So this was the imaging. Here we can see there is a subtle subarachnoid hemorrhage. Here we can see there's a bleed, intraparenchymal bleed, and the superior sagittal sinus, the anterior portion, is not visible, which should be visible in the MR venogram. So as the patient had worsened after 48 hours, his CT was repeated. CT was done that time, and there was a increase in size of the bleed with, we can see, layering as well. This was his angiogram. Here we can see the anterior part of the SSS is not being opacified. The vein of Tollard can be seen, but anterior SSS is not being opacified. So he was taken up for intervention in view of further worsening on anticoagulation. And a guiding catheter was advanced through the SSS into the from IJV into the just at the proximal end of the sigmoid sinus, and through the transverse sinus there was a guide wire was taken and advanced into the superior sagittal sinus. Clot maceration was done with the guide wire. A microcatheter was left in situ in the SSS, anterior portion of the SSS, and urokinase and heparin was given for 24 hours. So this was the end result, and here we can see there's partial opacification in the arterial run, and on the microcatheter run we can see there's opacification of the SSS. So the clot has partially dissolved. There were no further seizures, and he was discharged on warfarin without any deficits. So now we will come to the topic of venous sinus thrombosis, including the anatomy of the venous system. Venous anatomy is more variable than the arterial anatomy. The superficial system consists of the superior sagittal sinus, the sphenoparietal sinus, which drains into the cavernous sinus, and the tentorial groove that we know of, the transverse sinuses and the sigmoid sinus on either side. The cavernous sinus, it mainly drains the face and eye, and it is actually pathology of cavernous sinus is a distinct entity in itself, and I have not covered cavernous sinus thrombosis in this presentation. It connects to the sigmoid sinus and IJV through the petrosal sinuses and receives the sphenoparietal sinus. Some part of the brain also is drained by cavernous sinus, but mainly the face and eye. The deep system consists of the internal cerebral veins, the basal veins of Rosenthal. These are paired structures, and ultimately they join to form the vein of Galen. They drain into the vein of Galen and the straight sinus. The veins, venous sinuses and veins are that are inconsistently found and are of less clinical importance are inferior sagittal sinus, occipital sinus, forearm, and circumvein. So to the diagrammatic representation of these sinuses, you can see this is the cavernous sinus, the sphenoparietal sinus. These are the petrosal sinuses, the superior petrosal and inferior petrosal sinuses connecting the cavernous sinus to the transverse sigmoid junction and the IJV sigmoid junction. This is the sigmoid sinus. This is the straight sinus. This is the transverse sinus. This is the sigmoid sinus. This is the straight sinus. And in this view, we can see the deep system better. This is the vein of Galen, which is formed after the internal cerebral veins from either side join to the basal veins of Rosenthal from either side. And this vein of Galen is formed. This is the internal, and this is the straight sinus. This is the torcula, or the point of confluence of the superficial and deep systems. So this is an angiogram, MR angiogram, which shows MR venogram that shows what we saw in the diagram. This is the vein of Labbé that connects to the tentorial sinuses, and so SSS drains the vein of Tollard. This is usually cerebral vein, which is more prominent, and ultimately they lead to the internal jugular vein. The posterior fossa venous anatomy is more difficult to understand and more variable, but we can remember them as superior, that is the Galenic veins, and the posterior, the torcular, and the anterior petrosal. Don't go into the details of the names because they are named as per the structure, the adjoining structures. They mainly drain this Galenic, that is a vein of Galen drains the superior brainstem. We can remember by the location. The vein of Galen is located in the superior part above the brainstem and the superior part of cerebellum. So it drains these structures. The posterior or the torcular system drains the posterior inferior cerebellum, and the anterior or the petrosal sinuses, the superior and inferior, mainly the superior petrosal sinus, they drain the lower brainstem, the anterior cerebellum, and the cranial nerves. Coming to the epidemiology of the venous thrombosis, the incidence in adults is from 1.32 to 1.57 per lakh person years, 0.67 per lakh children per year in the pediatric population. And as far as women are concerned, especially pregnant women, it is 11.6 per lakh deliveries in pregnant women. And this incidence is highly variable according to the region. So the incidence of CVT is higher in India, Middle East, and Latin America. It is 3.7 to 5.3 times more frequent in women owing to hormonal effects. The usual age of presentation is 3rd and 4th decades. It accounts for almost 0.5 to 1% of all strokes, but maybe the percentages are higher in different regions according to of the world. So in clinical presentation, the important features, patients may present with raised ICP syndrome or new onset seizures, encephalopathy, or focal neurologic deficit. So features of raised ICP, like patients may have headache, vomiting, sometimes they may have blurring of vision, lowered level of consciousness, imbalance, papilledema, and cranial nerve palsies, impaired upgaze. New onset seizures, especially focal onset with loss of consciousness. However, the focality may not be evident in the history many times. So encephalopathy and focal neurologic deficits depends on the brain area involved. For example, if superior sagittal sinus is involved, patient may develop paraparesis, aphasia if left transverse sinus is involved, etc. So when to suspect CVT in brain imaging, when we see hemorrhage, ischemia, or edema adjacent to a sinus, then we should always think of CVT. So these are the risk factors associated conditions. So women-specific risk factors, mainly oral contraceptives, pregnancy, puerperium, and hormone replacement therapy. HRT is not used now. So when we are coming across infections causing CVT, then usually these are more common of a cause in children. The other causes are various thrombophilias, prothrombotic states like neoplastic disorders, especially the leukemias and myeloproliferative disorders, inflammatory diseases, the acquired ones like APLA syndrome, SLE, IBD nephrotic syndrome. And they may be iatrogenic at times from induced by chemotherapy, central venous catheters, lumbar puncture, neurosurgery, though these are exceedingly rare. And emerging risk factors as anemia and obesity. To complete the list, severe dehydration, hyperhomocystinemia, PNH, then other disorders like sarcoidosis, Behçet's disease. So diagnosis is usually made based on. Pardon?
You have 5 minutes left, sir.
Okay, fine. So diagnosis is based on CT or MRI. CT, non-contrast CT, Veno will show the empty delta sign. God sign is hypertense cortical vein. MRI with MRV, non-arterial infarcts, hemorrhage, and interluminal thrombus may be identified on GRE or T2, and black blood imaging also. SH usually is not the sole finding. It is associated with brain parenchymal changes. DSA is reserved to identify dural AV fistula and prior to endovascular therapy. When to suspect? Subacute stroke with progressive symptoms over hours to days, new onset seizures, altered sensorium, focal deficit with headache, raised ICP alone or with focal abnormality, hemorrhagic infarct, focal brain edema or infarct adjacent to venous sinus, and stroke not conforming to arterial territory. The treatment usually is subcutaneous low molecular weight heparin or IV unfractionated heparin. Unfractionated is preferred when surgery or lumbar puncture is being planned. Patients with HIT may be given fondaparinux. And decompression for impending herniation or drop in GCS with midline shift. Endovascular therapy, though it doesn't form part of guidelines, it may be offered to patients who are comatose, who deteriorate on anticoagulation and significant mass effect without parenchymal lesions. So oral anticoagulants avoided in pregnancy, and heparin should be used in them. DOACs also may be substituted, and emerging evidence to favor DOACs is evident. So provoked CVT we will treat for 3 to 6 months, unprovoked for 6 to 12 months, and prolonged or lifelong may be required for severe thrombophlebitis or recurrent CVT. Other treatment modalities are anti-epileptics and anti-edema measures. Predictors of poor outcome will be midline shift, older age, larger CVT, and multiple sinus occlusion, deep system involvement, and clinical worsening. The guidelines state strongly favor heparin use and decompressive surgery, while to favor other modalities of treatment are not really, the evidence is not very clear. The complications of CVT, the two important complications, intracranial hypertension, which I won't be discussing here, and dural AV fistula. So I'll discuss dural AV fistula briefly. It is an abnormal shunt between arterial and venous system in the dura, accounts for 10% of intracranial vascular malformations, and leads to symptoms if it causes hemorrhage or venous hypertension. The presenting symptoms, most common is the pulsatile tinnitus, because the transverse sinus and the sigmoid sinus are the commonly involved sinuses. And one should always look for bruit on the mastoid region and one may suspect this if bruit is present. Headache, sensory motor deficits, visual changes, altered mentation, myelopathy, cranial nerve deficit. Myelopathy can occur if cord is involved. The etiology is usually idiopathic, and predispositions are CVT, trauma, neurosurgery, sinus stenosis. Corneal classification based on whether retrograde or antegrade drainage is present in the sinus, and whether cortical venous drainage is there, cortical venous ectasia is there. Cortical venous drainage and with ectasia causes a poorer prognosis, and these are to be treated. This is diagrammatically represented, the corneal classification. One may go through it online, and the treatment is conservative when it is a low grade behavior, that is type 1 corneal, with antegrade drainage into the sinus. Carotid compression 3 times a day for a few months have resulted in occlusion of the dural AV fistula in some of the cases and may be tried. Endovascular embolization is the mainstay of the treatment. Rarely SRS or surgery may be offered. Now, this is a 32-year-old lady who presented with headache, vomiting imbalance, and hearing impairment on the right side. For 20 days, she was disoriented, impaired complex comprehension, impaired hearing on right side, bilateral optic disc pallor, and visual acuity of 6/60 on the right side, and left side it was 1/60. Gait was broad-based with tendency to sway to right, but no other localizing or focal deficits. This was an MRI done elsewhere. Here we can see prominent flow voids in multiple regions, and most of them are superficial. Same thing in the coronals. And this was the angiogram obtained elsewhere. So here we can see there are a lot of dilated artery, venous channels. And angiogram, here we can see this is the middle meningeal artery arising from the ophthalmic artery. Normally it comes from the ECA, but in this patient it was arising from the ophthalmic artery. And here we can see it is directly draining through a fistulous point into the superior sagittal sinus. And this is the cortical vein that is being retrocranially opacified. So this was a higher Conyard grade 2A plus B, and with feeders from bilateral middle meningeal arteries and the occipital artery. So here we can see the vein of there's reflux into the vein of Tollard and the superior sagittal sinus in the arterial phase. This is important. In the arterial phase, we can see the venous sinus. So the patient was embolized through the middle meningeal artery approach from the ophthalmic artery, and the occipital artery as well as the MMA approach was taken, and this was the final embolic material cast. This was a final shoot where we can see the MMA is occluded, obliterated, and we cannot see the sinus filling in the arterial phase and the capillary phase. So the patient was cured of the fistula, and patient improved in orientation, comprehension, and hearing. There was no change in vision. So to summarize, venous strokes are important treatable conditions, gratifying results with early treatment, devastating results with misdiagnosis and late treatment, new headache, tinnitus, neurodeficit in a patient who has recovered from CVT. Always watch for DAVF before initiating anticoagulation. And take home message, follow the guidelines in the majority, but do not hesitate to tailor them to suit your patient. Thank you.
Thank you so much, sir. It was a very illustrative presentation. We will take the questions at the end of the session, sir. And now we have a postgraduate resident from our DM Neurology program, Dr. Chandra Reddy. He'll be presenting an interesting case vignette. Dr. Chandra, I invite you to present your case vignette.
Good afternoon, everyone. I hope you can see my screen. Yeah, so I'll be presenting an interesting clinical case vignette. So this is a 65-year-old man who presented to our ER with history of neck pain for the past 6 days. After taking NSAIDs, he complained of weakness and generalized fatigue, and he had no other significant gastrointestinal, neurological, or cardiorespiratory symptoms. However, his past medical history was significant for diabetes, hypertension, CRF, obesity, metabolic syndrome, G6PD deficiency, and it was a case of OSA requiring CPAP. So on examination, he appeared dehydrated and he had jaundice and he was febrile as well. And his heart sounds were normal with no added murmurs. And his blood workup showed elevated CK levels, elevated TROP-T. His liver parameters were deranged in the form of elevated AST, ALT, and serum bilirubin levels. His chest X-ray was normal. ECG showed a normal sinus heart rate with no ischemic changes. He was admitted as a case of fever with jaundice and the possibility of hepatic dysfunction, which was infection related, or a hemolytic episode after NSAID treatment in view of pre-existing G6PD deficiency was considered. The virology screen was negative alongside other autoimmune screens for the liver disease. He was empirically started on injection ceftriaxone at 2 gram OD dose after taking a blood culture. And following the initiation of antibiotic therapy, he had no further fever spikes after admission. However, 2 days later into the admission, while returning from the washroom with the aid of a nursing staff, he suddenly became unconscious. He was unresponsive with no seizure activity. His vital signs during that time were normal. He had a normal blood glucose level when it was checked. And he had a left hemispheric syndrome with severe hemiplegia on the right side and a gaze deviation to the left with global aphasia, hemianopia, and hypoesthesia. The patient's NIHS score was 18, and an urgent CT brain showed no acute CT changes. So just summarizing the history, he was admitted as a case of fever with jaundice, and during or after admission, he developed an acute left hemispheric syndrome. So what will you do next? Will we thrombolyze him or not? So this particular patient was thrombolized, and 2 days after thrombolysis with venetoclax, the CT is showing a small infarct in the medial thalamus on the left side. Later on, his blood culture came positive for group B streptococcus. Following this, a 2D echo was done, which showed a vegetation on the posterior mitral valve leaflet. So following this, a diagnosis of acute infarct secondary to infective endocarditis, possibly resulting from a septic embolus, was considered. So coming to the conclusions, so the safety and efficacy of thrombolysis in infective embolic stroke remain a matter of debate. However, according to the current guidelines, thrombolysis in infective endocarditis is contraindicated. And infective endocarditis should always be suspected in the background of fever, and screening transthoracic 2D echo must be always be considered wherever there's a suspicion of infective endocarditis in order to avoid inadvertent thrombolysis. Thank you.
Thank you so much, sir. Now I would like to request our speakers to take a few questions from the delegates. The first question is directed for Dr. Subhash Kaul, sir. It's by Dr. Vinay Kumar Agarwal. And the question is, what should be the best time to start anticoagulation in cardioembolic hemorrhagic infarct? Should any neuroimaging be done before giving the anticoagulation? And also kindly provide the reference for the same.
Yeah, I think the question is that when should you start the anticoagulation? It depends on how big is the infarct. So I would say you can start from day 1 to day 14, or sometimes even 3rd week. So if it's a TIA stage, means cardioembolic stroke can be TIA also, then you can start right from day 1. Maybe it's a better idea to do a check CT scan to make sure that there is no bleeding or there is no infarct developed. After 24 hours of the onset, you can do a check CT scan. If your CT is completely normal, there is no bleed and you don't see any, you can start on day 1. On the other hand, if it's a very mild stroke, which means 1/7 of the MCA distribution, or 1/6 or 1/5 by the eyeballing effect, then you can start on 3rd day. If it is 1/3 of the MCA, I would say that is a mild to moderate size, you can start at 1 week. But if it is involving entire MCA, then you can start at 2 weeks. And if there is a hemorrhage also in it, then you should start at 3 weeks. In fact, there's a law called Diner's law. Diner is a very important German stroke specialist who has come to Hyderabad also, and he has done extensive clinical trials on antiplatelet agents and even anticoagulants also. So that goes by, roughly speaking, it's like 2-7-14 law. So, but the broad principle is that it depends upon how big is the infarct and whether there is any hemorrhagic conversion. So by and large, you should remember, if it's a TIA, you can start on day 1. If it's a mild infarct, you can start at 1 week. But if it's a big infarct, you can start at 2 weeks. But if there's a hemorrhagic conversion also, then you have to wait. It's better to wait for 3 weeks. And reference is, there is a reference in these 2021 guidelines also. They are saying you can start any day from day 2 to day 14. I have also shown that slide. But in addition to that, you should, that will depend on the, as I said, size of the infarct. Because the why size of the infarct, the bigger the infarct, there's so much of ischemic injury to the cells, and they are prone to damage, hemorrhage. And you should also look at the Diner's law from Google. You will get extensive literature on this.
Thank you so much, sir. And the second question is, so normally the recommendations are to start the high dose statins, but how well do the Indian patients tolerate such high dose of statins, sir?
By and large, my experience is that they tolerate it very well. Everybody's experience is they tolerate it very well. We ourselves stop it after some time. Most of the Indian neurologists, after 3 months, we started to half it to 40, and after 6 months we make it 20 or 10. Most of us do that. All of us do that. Nobody continues. But if you actually look at the guidelines, you have to give 80 mg throughout. You have to give 80 mg at least for 4 or 5 years. But I think we don't give it that high, because as you rightly said, we feel, patients have not complained, but we feel that they may not need. After all, this trial was not done in India. It was done in US. So we feel that they may not need that high dose. But it's to be individualized. Suppose if there's a patient with very high load of coronary artery disease, myocardial infarction, I think cardiologists don't hesitate to give them 80 mg. But as neurologists, I would say we give 80 mg for about 3 months. After that, we reduce it to 40 mg, and by 6 months, we are comfortable at 20 mg or 10 mg.
Okay, thank you so much, sir. And the third question would be, in case of posterior circulation stroke, do we have a preference to use dual antiplatelets, and how long do we use them?
No, I think it has nothing to do with posterior circulation. There is no difference between, as far as the management is concerned, there is no difference between anterior circulation and posterior circulation. These are just topics for discussions, talks and discussions and your personal preferences. There may be some difference in their vasculature, but when it comes to guidelines, they are uniformly same. Most of the research has not been done on posterior circulation. Most of the research has been done on anterior circulation. Most of the endovascular work has been done on anterior circulation. Most of the antiplatelet work has been done on anterior circulation, but that has been extrapolated to the posterior circulation also. So therefore, whether it's an anterior circulation or posterior circulation, it does not matter when it's a question of antiplatelets. What matters is that whether the stroke is minor or whether it's major. And I'm talking about guidelines. What the guidelines say that if you are having a stroke which is minor, now minor definition is less than 5 NIHS, which means just mild hemiparesis, which means it's not disabling, he's okay. Or it was a TIA. Then you go by the premise that most of his brain is at this time at risk, but not yet damaged. And the infarct size is not big. So you don't want a recurrence in this patient. So you give him a double antiplatelet. But we know that giving a prolonged double antiplatelet may finally cause hemorrhage, which it has caused in MATCH trial. So you give it only up to 3 weeks, because up to 3 weeks that early recurrence is very common. But if it's a big stroke, on the other hand, whether it's anterior circulation or posterior circulation, if it's a big stroke, disabling stroke, already the half of brain is gone, then you have to give only single antiplatelet. So these are the latest recommendations.
Thank you so much, sir. Sir, we have one more question. Do you recommend cardiac MRI and bubble contrast TEE in case of patients with embolic stroke of unknown source?
No, we definitely do TEE. That is very much in recommendations, because when we say unknown source, there are two important causes which are prevalent and which contribute to so-called unknown source. You know, these definitions are also important. When they talk of unknown source, they have not included TE in that. By unknown source, they mean that his 2D echo has been done and his 24 hours Holter has been done. So that becomes the unknown source. But to unravel that unknown source, we definitely do a TEE to search for two things which are common. One is patent foramen ovale and one is aortic arch atheroma. So it is definitely done. And when you do for patent foramen ovale, we also do a bubble contrast study. Because just the patent foramen ovale is not important. We also want to see that there is a right to left shunt. We want to see the size of the shunt. We want to see the number of bubbles which are passing through that shunt, per minute. So bubble contrast is part of our routine. I am not doing cardiac MRI. I have not seen anybody doing cardiac MRI, but it's in the guidelines. I have seen that. But we are not doing it routinely.
Thank you so much, sir. The next question is for Dr. Niranjan, sir. Sir, normally in case of cases with CSVT, the recommendations are to discharge the patient on warfarin. But what is your institutional experience for starting newer anticoagulants? Dr. Niranjan, sir, can you please unmute yourself? Dr. Subhash Kaul, sir, can you please answer the question?
Yeah, I think your question is whether you can give novel anticoagulants in CVT. The answer is yes. In fact, we are giving also. And the reference is up to date. So now this is no longer a controversial question. It is an accepted thing that you can give NOACs, because it's very well known that there is enough data to show that they work very well in the deep venous thrombosis of the legs, deep venous thrombosis of the pulmonary arteries. So therefore they will act in the brain also, and it is in guidelines also. You can give it. So no discussion on that. You can, the trial has been done on dabigatran. And I think that was called Respect CVT trial, in which they gave dabigatran and they found that it is as good as warfarin. So you can give it.
Thank you so much, sir. We're going to end this session now, and we're going to take a 20 minutes lunch break before we resume the third and the final session. Thank you, everyone.
Thank you.
At 2:30 p.m.
साउंड करके Can we start the post-lunch session?
Ma'am, yeah, it is 2:31. I think we can start the session, I think.
Fine, fine. Dr. Reshma Sultana Sheikh. It is my pleasure to introduce my own colleague and faculty, Dr. Reshma Sultana Sheikh. She is energetic, brilliant, and hardworking. I am lucky to have her in my department. She has played a very crucial role as the organizing secretary of this stroke CME. She did her MBBS from Deccan College of Medical Science, and she is the best outgoing student. She did her MD General Medicine from Osmania Medical College. She completed her DM Neurology from Nimhans Institute, Bangalore, and her present designation is as an assistant professor in the Department of Neurology, Deccan College of Medical Sciences, Hyderabad. Her area of interest are neuroimmunology, neuroinfections, and stroke. As for her credit, she has presently 6 publications as she has written around 4 chapters. Over to you, Reshma, for your talk on role of anticoagulants in stroke.
Thank you so much, ma'am, for such an overwhelming introduction. I feel really so happy about it. Okay, now, visible on my screen? A very good afternoon to all the distinguished speakers and delegates. Today, the topic which I'll be talking about is anticoagulants in stroke. Well, it's a gray area in stroke, so I will be running through some case vignettes and we'll discuss the role of anticoagulants in each of such case scenario we come across in our day-to-day life. So the overview of my presentation will be under the following subheadings. I'll give a brief introduction, then we'll run through some case vignettes and the role of anticoagulants, and then I'll talk about NOACs and special scenarios, and we'll have a take-home message. We are all aware of this, that ischemic stroke is more common than hemorrhagic stroke, and it's because of a blood clot which is blocking the flow in an artery. So anticoagulant agents will act on the coagulation cascade. They'll reduce the fibrin polymerization and thrombus formation. Recapitulating what has been already discussed and what we know for a very long time, we have our coagulation pathway with intrinsic pathway having factors 12, 11, 9, and extrinsic pathway, we have the factor number 7. And the final common pathway has factor 10, 2, and fibrinogen. Like you can see, vitamin K antagonists, they act on the vitamin K dependent factors like 2, 7, 9, 10. And we have dabigatran, which is a direct thrombin inhibitor. And then we have factor 10 inhibitors like apixaban, edoxaban, and rivaroxaban. From this slide, I would just like to emphasize the important point that whenever you're prescribing rivaroxaban for a patient, always give an advice to have it with food. Why? Because the bioavailability and absorption with food is very high. So we need to prescribe rivaroxaban and instruct the patient to take it with food. So how does the intervention of anticoagulation work? Our ultimate aim is to prevent early recurrent thromboembolic stroke, to prevent DVT, and to prevent pulmonary embolism. So coming across the first case vignette, we had a 56-year-old man, hypertensive, who presented with left hemiplegia, UMN facial weakness, and left visual field defect of 9 hours duration. His vital signs and lab parameters were normal, and ECG showed atrial fibrillation, like you can see in this, and 2D echo showed dilated LA and concentric LVH. Like you can see, the imaging showed an infarct with right MCA territory involvement and a right M1 cutoff in the MRA. So now, we quickly made a diagnosis of acute ischemic stroke in the right MCA, M1 division with left complete hemiplegia, comes under post-2 category, cardioembolic stroke, secondary to non-valvular AF, and risk factors being hypertension and non-valvular AF. So now we need to identify the source, and then we have to discuss the recommendations on the role of anticoagulants and the timing of anticoagulants. First, identifying the source. Like we all know that cardioembolic stroke, it is one of the most common causes of stroke, with 20% of ischemic stroke having heart as their source. And as we are discussing, each time we come across this prevention of early recurrent ischemic stroke, which is of our highest interest. So the definition is new stroke of presumed embolic origin, which is occurring within the first 2 weeks. So in non-valvular AF, the rate varies between 0.1% and 1.3% per day. Very quickly, cardioembolic stroke sources are again subdivided into 3 groups. The first one is cardiac wall and chamber abnormalities. As the name indicates, anything which has a wall as a cause, like a hypokinetic, akinetic ventricular region, and then having aneurysms or the septal defects. Then wall disorders, like Dr. Subhash Kaul sir has already mentioned, valvular AF includes only those where we have moderate to severe MS and prosthetic valves. Rest of them come under non-valvular AF. Just because we have a mild MS or even a severe MR, we cannot call it a valvular AF. So I'll reiterate the same thing. Valvular AF includes only the ones where we have moderate to severe MS and prosthetic valves. And the third source is arrhythmias like AFN, sixth sinus syndrome. Stroke Data Bank has divided the potential cardiac causes of stroke into 2 sources, strong source and weak source. Why is this important? This is important because when we decide on starting the anticoagulants, to decide how judicious we are in giving the anticoagulants for some subset of patients. Like you can see, the definite strong sources which we all know are prosthetic valves, atrial fibrillation, and akinetic segments. Hypokinetic segments come under the weak sources. So mitral annular calcification, hypokinetic segments, and congestive heart failure are all the weak sources. This is the very famous Chad-Basque score, which we have known since a really long time. What I want to emphasize is the presence of stroke or TIA will confer a stroke of 2, and that's enough for us to start a patient on anticoagulants. Now, what are the recommendations on role of anticoagulants in a cardioembolic source of stroke? So we have this famous stroke prevention in atrial fibrillation study, which has described 3 risk factors for thromboembolism. The first one being recent congestive heart failure, recent, mark my words, and then hypertension and previous thromboembolism. So whenever a patient has one of these risk factors, they automatically qualify to being treated with anticoagulants. What about those cases where we do not have any of these risk factors? This study has shown that aspirin 325 mg would suffice in other cases. So now very quickly, revising what Subhash Kaul sir has already mentioned in the previous slides, in non-valvular AF with stroke or TIA, we have a class 1A recommendation to start the patients on anticoagulants. Whenever there is a high risk of hemorrhagic conversion, we can wait for 14 days. And in valvular AF, only warfarin is the recommended anticoagulant of choice. We cannot give the NOACs in case of valvular AF. This is a very important point. Now, anticoagulants in other sources of cardioembolic stroke. Till now, I was talking about the non-valvular AF. Now, in LV thrombus, we are justified in giving warfarin for 3 months, and in acute anterior MI with reduced ejection fraction, despite the absence of LV thrombus, we are justified in giving anticoagulants for 3 months. Similarly, in PFO, if it is an isolated PFO, aspirin would suffice. But if the PFO is associated with a concomitant hypercoagulable state, venous thrombosis, or atrial septal aneurysm, we are justified in giving anticoagulants. Like already mentioned, on patients who are on dialysis with AF, we can give warfarin, and apixaban is the NOAC of choice. And in TIAs, immediate initiation of oral anticoagulant agents has a class 2A recommendation. Aspirin plus warfarin has very few indications. One being presence of LV thrombus, the other is an LVAD. And one more thing is, suppose a patient has an ischemic stroke prior to having a valvular AF, we have to give a combination of aspirin plus warfarin. This is the entire cardioembolic stroke and the recommended treatment option in a nutshell. Like you can see, in atrial fibrillation, if you have a valvular AF, warfarin and only warfarin. If you have AF with non-valvular AF, you can go for a NOAC. In a sinus rhythm, we give anticoagulants only if we have mechanical valves. In the rest of the conditions, antiplatelets would suffice. In infective endocarditis, there is no role for anticoagulants. Similarly, in cardiomyopathy, whenever you have a left ventricular or left atrial thrombus, you're justified in giving warfarin. And LV non-compaction also has class 2A indication to give warfarin. So now, when do we avoid warfarin? Well, anticoagulant is not a treatment option in valvular pathology. Don't give it in calcific emboli, myxomatous emboli, bacterial emboli, fibrin platelet emboli, and crystal embolization. Now, the biggest question is, when do we start the anticoagulants? Many trials have been done, like Subhash sir already mentioned about the famous Diner's law. Well, here it is in a pictorial representation. So we have a 1, 3, 6, and 12-day rule. So what is this? In a TIA, you can give it on day 1 of TIA. You can safely resume the anticoagulant. And when we have a mild stroke, so what is mild stroke? Mild stroke is when you have an NIHSS score of less than 8, then you can start the anticoagulant on day 3. And when there's a moderate stroke is when you have an NIHSS score of 8 to 16, you can safely start it on day 6. And then in severe stroke, where NIHSS score is more than 16, you can start it on day 12. So that was about cardioembolic stroke in brief. Now the second case, vignette. 56-year-old lady with nil comorbidities presented with right hemiplegia, global aphasia of 10 hours duration. Vitals and labs were all normal. No etiology for the stroke was traced. Imaging showed a left MCA territory infarct. So a probable diagnosis of embolic stroke of undetermined source was made. As we know that 20 to 30% of strokes have a cryptogenic source. So what is this embolic stroke of undetermined source? It is a non-lacunar stroke on imaging, and when we do not identify a cause or when the evaluation is incomplete. So what are the recommendations? Do we give or we do not? The recommendation is not to give the anticoagulants in ESUS. Aspirin would suffice, but there are some special subgroups, which are the high-risk ESUS patients, where you may give anticoagulants. So they being multiple infarcts at different arterial territories without aortic atheroma, and elderly, high CHA2DS2-VASc score, atrial cardiopathy, and PFO. And we have this RESPECT ESUS trial where low-dose dabigatran was compared to aspirin. And two observations were drawn. One is that rates of stroke were reduced with low-dose aspirin older patients. It was not replicated in the younger ones. And also, it was more beneficial in the low baseline creatinine clearance subgroup. So now we'll go to the third case, vignette. 35-year-old alcoholic with history of headache and seizures of 2 days duration. Vitals and labs were normal. Like you can see, we have a right transverse sinus hyperdensity and contrast CT showing an empty delta sign. CSPT has been discussed extensively by previous speakers. I just want to reiterate that we have class 2A recommendation for the use of anticoagulants in full dose split into twice a day. And remember that presence of a venous hemorrhage in the infarct is not a contraindication to start the patient on anticoagulant. So venous infarct with hemorrhage is not a contraindication. We can straight away start the patients on anticoagulants. So like it was discussed earlier, warfarin is recommended by the AHA-ASA, but the RESPECT trial has shown non-inferiority of dabigatran to warfarin, and the SECRET trial shows the non-inferiority of rivaroxaban to warfarin. And now we are very commonly using in our clinical practice NOACs to treat the CSPT. The fourth case, vignette, we had a 45-year-old lady presented with a history of right brow pain, and 1 day later developed a transient visual loss on the right eye. Brow pain is an indication of a ICA dissection, and transient visual eye could be a retinal ischemia. So imaging, like you can see, is showing an extracranial right ICA dissection. So a diagnosis of right retinal ischemia secondary to right ICA dissection was considered. Like you can see, we have this dissecting aneurysm. And here on the top imaging, you can see that it is a double lumen on the right ICL. So what are the recommendations? We have 1C recommendation to initiate antithrombotic treatment in an extracranial dissection. And CADIS trial, the very famous trial, it has shown an equipoise between antiplatelets and anticoagulants as treatment options in dissection. So when should we avoid anticoagulants in dissection? One, when we have intracranial dissections. Why? Because there's a risk of hemorrhage causing subarachnoid hemorrhage. And also in individuals with large infarcts having an NIHS score of more than 15 or severe neurological deficits or a risk of hemorrhagic conversion, we avoid giving anticoagulants in these scenarios. So just remember that it's extracranial dissection where we can give anticoagulants in the subset of patients. Now coming to our fifth case, vignette, a 60-year-old hypertensive lady, non-diabetic with COVID positive status. She presented with new onset weakness of right upper limb and deviation of angle of mouth with aphasia, and her vitals and lab parameters, vitals were normal and lab parameters showed increased inflammatory markers like ESR, CRP, IL-6, D-dimer, ferritin. Her 2D-co was normal. So a probable diagnosis of COVID with stroke was made. Well, because it's a new illness, we do not have AHASA guidelines and recommendations, but from whatever authors have recommended, routine therapeutic anticoagulation is not indicated. Then what is the indication for therapeutic anticoagulation in COVID patients? The first one being, if we have an ischemic stroke in a COVID positive patient, which involves multiple vascular territories, in the absence of a large territory infarct or hemorrhagic transformation, you are justified in giving therapeutic anticoagulation. The second indication being, I told initially that multiple vascular territories is an indication, but single large vessel ischemic stroke while on venous thromboembolism prophylaxis also becomes an indication for therapeutic anticoagulation. If the patient develops a stroke on VT prophylaxis, it only means that that is not enough. So give therapeutic doses. This is just to show some regimes of thromboprophylaxis in patients with COVID. Like you can see, an individual weighing more than 100 kg or a 6 score of more than 4 and a D-dimer of more than 6 folds normal is a consideration for a high intensity dose. We give, like we can see, the full therapeutic doses in these individuals. So talking about a very important topic, that is DVT and anticoagulants. As we all very well know that in ischemic stroke, we very comfortably give anticoagulants, and we have a grade 1A recommendation to start the patients on prophylactic low-dose subcutaneous heparin or low molecular weight heparin. What about intracranial hemorrhages? Even in intracranial hemorrhages, we have a 1B indication to initiate the patients on anticoagulants. So what do we do in case of ischemic stroke? We give 5,000 units subcutaneously every 8 hourly. And in subarachnoid hemorrhage and intracerebral hemorrhages, on the day of admission, place a pneumatic compression device and assist the patient on day 2. If the patient is stable and the size of hemorrhagic infarct hemorrhage is not increasing, you can safely start unfractionated heparin 5,000 units subcutaneously 8 hourly as a primary thromboprophylaxis. And if the patient is stable between days 10 and 14, we can safely switch it to oral anticoagulants. And special scenarios, periprocedural risk while on anticoagulants, a commonly encountered question. I just want to mention some important points. Whenever there is a patient who comes as a referral to us, we have to look at the periprocedural bleeding risk. Very quickly, minor procedures like dental, dermatological, ophthalmological, a low risk is there, and all the major surgeries come under high risk. Cardiac procedures are all moderate risk of bleeding, like SVT ablation, ICD implant, and cardiac catheterization via the radial artery. Sometimes we want to switch the anticoagulants for various reasons. So very quickly, the important points, if you are contemplating to switch a vitamin K antagonist to a NOAC, you can do it when the INR is as low as 2. And if you are contemplating to switch the unfractionated heparin to a NOAC, you can do it after 2 hours of stopping the unfractionated heparin. And NOAC to a vitamin K antagonist, you can do it when the INR is between 2 to 3. So reversal of effect of NOACs, quickly to mention some important points. As we know, andexanet alpha is used for the reversal of factor 10 inhibitor activity, and idarucizumab is used for dabigatran reversal, but the prices are prohibitively high, and I don't think Indian patients can afford them. So very quickly, dosing, we know that dabigatran and apixaban are used twice daily. When we are using in non-valvular AFS stroke prophylaxis, dabigatran dose is 150 BD and apixaban is 5 mg BD. If we are using it as a VT primary prophylaxis, then 110 mg on the first day and 220 mg from after that, from day 2. And for apixaban, it is 2.5 mg twice daily. These are the costs of dabigatran per month. It will cost around 4,000. Rivaroxaban will be 3,000. Warfarin is the cheapest. It will cost us 60 rupees. So finally, coming to the take-home message, I tried to put it in a nutshell. The medical condition, class of recommendation, and choice of anticoagulant. In non-valvular AF, it's a class 1A recommendation for NOACs more than warfarin. In valvular AF, only warfarin. We do not have other option. And in LV thrombus, we can give warfarin, class 1B indication. In dialysis patients, warfarin and apixaban. And in DVT prophylaxis, we can give NOACs and warfarin. In extracranial cervical and vertebral artery dissection, we can give warfarin or NOACs. And in CSVT, current data shows the warfarin and NOACs both are equally effective. And in patients with AF in a malignancy case, we can give NOACs and warfarin. In acute phase, we need to remember that unfractionated heparin or low molecular weight heparin is used. Later on, we can give these oral anticoagulants. No warfarin in calcific, myxomatous, bacterial and fibrin platelet emboli and cholesterol crystal embolization. Rivaroxaban is contraindicated in APLA. Aspirin plus warfarin, very few indications we have. MI with LV thrombus and patients on LVAD. Also in those patients who had ischemic stroke prior to being diagnosed with a non-valvular AF. These are my references. I recommend the residents to read these. Thank you so much for this opportunity. Thank you.
Thank you, Reshma, for the mind-blowing talk as always.
Thank you.
Over to you, Dr. Chandra.
Good afternoon, everyone. So I would like to introduce our next speaker for today. I'll just be sharing the slide. Yeah. So our next speaker for today will be Dr. Zohaib Mohammed, sir. Sir has done his MBBS from MRMC, Gulbarga, and MD General Medicine from Al-Amin Medical College, Bijapur, and DM Neurology from DCMS, and passed out as a best outgoing student. And currently, sir is working as an associate professor at the Department of Neurology, Deccan College of Medical Sciences, Hyderabad. And his special areas of interest are stroke, epilepsy, and electrophysiology. He has multiple publications to his credit. I would like Zohaib sir to take over.
Good afternoon, everyone. Just a minute, I'll be sharing my slide. Yeah, so good afternoon, everyone. My topic for today's CME would be motor complications of stroke. So just going ahead with the motor complications, basically per se, just a minute. Yeah. So as we all are well aware and we have gone through the various clinical aspects as well as the management aspects of stroke, we'd be entering now the field of complications, which basically decides the overall outcome of the patient in the future once they are recovering from stroke. So broadly, we'll be classifying the stroke complications based on duration as immediate complications and delayed complications. Immediate complications would be the one occurring within 2 weeks from the onset of the incidental event, that is the onset of stroke. Delayed complications are beyond 2 weeks from the primary event. Immediate complications are the one which would be having an important impact on the mortality related to stroke. Delayed complications playing an important role in the morbidity and overall outcome of a patient suffering from stroke. to broadly classify immediate and delayed complications, these are the various ways which we classify. The most important in immediate complications would be the raised ICP, hemorrhagic transformation, as well as the aspiration. We all experience these three as the dreadful complications initially, maybe within first 5 to 7 days from the onset of the stroke. And that has got an extensive impact on the outcome of a patient. These usually clinically, when we consider raised ICP, hemorrhagic transformation, as well as aspiration, we encounter maybe about within day 1 to about day 7 from the primary onset of the illness. A urinary tract infection, venous thromboembolism would be in the later part of the second week or early part of the second week. However, cardiac arrhythmias and myocardial infarction depends upon the previous cardiac status. Usually, if the patient has got any previous coronary events, we have to be very careful, as previously said by all the respectable speakers, to concentrate on the cardiac evaluation as well as examination. Delayed complication, the most important would be the motor complications, which we'll be discussing in detail. Apart from that, the most disabling part would be the post-stroke pain, depressions, contractures, falls, and dementia. So these are certain basic definitions which have been used since age long according as per the various stroke associations and committees, ranging from progressive stroke up till the pulmonary embolism. Progressive stroke as well as the progressing stroke as well as recurrent stroke would be initially difficult if the patient's sensorium is on the lower side. Hence, a careful watch would be required to assess them based on their definition. The most important among all these definitions would be complications would be the fever. If any fever occurring within first 5 days has to be extensively evaluated. Usually what we observe is having to wait for a day or two and decide about the antibiotics. However, recent studies have said that any onset of fever within first 5 days has to be extensively evaluated and managed aggressively, because it has got significant impact on the outcome of the patient. So as per the studies are concerned, if we take overall immediate complications in a patient with stroke, the standout complication would be aspiration pneumonia, accounting for roughly ranging between 25 to 35% as per various diseases. And raised intracranial pressure does depend upon the size of the infarct and its further complications. Pressure source urinary tract infection, as we discussed, will belong to the later part. However, post-stroke seizure, the involvement of the number of patient depends upon the various types of the infarct, which we'll be discussing later. These complications have got various levels of effect on the mortality. Raised ICP, aspiration pneumonia, and any other infections in the initial part have got a mortality rate effect on the mortality extending between 18 to 35%. So if we consider this chart, which we have got from as a natural history of the stroke and various effects on the complication, usually the first 24 hours, we concentrate based on the intracranial pressure and its associated complications. But what is most important is beyond that, that is beyond 24 hours up to the early mobilization of the patient, there are so many complications which have got its own part and role to play. If we consider the readmissions after discharge, the readmission rate varies between 25 to 30% within first 2 weeks. And that has got a significant effect on the morbidity. So here, when we are considering between post-reperfusion therapy up till discharge, we can see apart from edema, these are the 4 important, that is infections, cardiac complications, recurrence, seizures, and DVT. This particular phase is of utmost importance if we are going to concentrate on recovery of the patient and further rehab of that patient. So based on the NIHSS score and depending upon the severity and the percentage of complications which we can have, very severe, it is definitely expected that the complication rate would be high. But if we concentrate on the next 3 aspects, that is from severe up till mild, the percentage of complication, 1 or more complication, varies between 40 to 70%. Even when we are considering mild stroke, we are having a complication rate of as high as 40%. So these patients also do require a proper care in the form of a dedicated stroke team, not just a neurophysician or a critical care physician, a dedicated stroke team taking care of these particular set of the patients. So coming to motor complications, we will be dividing the motor complications basically as a hyperkinetic, hypokinetic, and others. The others belonging to the long-term complications in the form of spasticity, falls, and dysphagia. So movement disorders form an important part of the post-stroke related complications apart from the other complications which we have discussed. Incidence varies between 1 to 3%, going as high as 20% depending upon the area of cerebral hemisphere or the brain which is being involved. And we all are well aware that hemorrhagic stroke is more likelier to cause movement disorder and associated complications. So coming to the various, we'll be going in a short session over these various movement disorders. Hemibalism as well as chorea, that is hemichorea, are the most commonest form of movement disorders which we experience post-stroke. And hemichorea per se accounting for about a larger number of as high as 40% of involvement in the stroke. So balism can involve either one limb or all limb depending upon the area which is being involved. So in case if we go for the pathophysiology or the areas which are being where the strategic infarct can be placed, good old, as we say, that the contralateral subthalamic nucleus in hemibalism and caudate in chorea. But even we have come across many case studies, as well as we all might have experienced cases that other parts of the basal ganglia or the subthalamic nucleus, when they are involved, a mixed movement disorder pattern we do come across in such patients. So about 80% of the patients with hemibalism are noted immediately after the onset of the stroke. However, important point over here is there are certain subset of patients where there might be a delayed presentation as long as 5 months. So if a stroke patient is noted and there is a delayed onset of hemibalism or any movement disorder, or an elderly patient presenting with a new onset of movement disorder, a thorough workup for any past stroke in the form of lacunar stroke also has to be considered. Spontaneous recovery is definitely noticed in about 24% to 25% of the cases over a period of about 2 to 6 weeks. If a patient is presenting with acute onset of chorea and is out of the is belonging to an adolescent or an elderly age, other differentials also we should be considering if we are not able to pinpoint a strategic infarct in the form of vasculitis, other vasculopathies, and autoimmune conditions. Treatment, as we all are well aware, dopamine receptor blockers, typically haloperidol, is used since long and has got a resolution rate of as high as 50%. But there are patients who land up in refractory movement disorders in the form of hemibalism and chorea as high as 25%, which might end up requiring either use of local botulinum as well as ventrolateral thalamotomy. So the second most commonest movement complication which we come across is dystonia. The definition is known to all of us, that is involuntary sustained muscle contraction, and it represents up till as high as about 35%, but roughly about 20 to 20% or 25% of the overall post-stroke movement disorders. And in elderlies beyond 50 years of age, stroke is the most commonest cause of dystonia. Presentation of new onset dystonia in elderlies. The site which we are supposed to look for in the imaging is putamen, and pathophysiology, there is interruption of the corticostriatopallido-thalamic cortical loop, and sometimes an acute infarct or a small infarct involving this loop and not strategically placed in putamen can also lead to dystonia. So the treatment option, that most disabling part of dystonia is it is not as good responsive as hemichorea as well as hemibalism is. So the medical response to medical therapy is poorly noticed in these patients. Anticholinergics, benzodiazepines, and baclofen are the commonly used agents, but the treatment failure rates for medical therapy ranges as high as 50 to 75%, which might ultimately require the use of botulinum toxin. Myoclonus and asterixis noted, but not as commonly as the initial three, that is chorea, balism, as well as the dystonia. Myoclonus can affect either arm, face, leg, or voice, depending upon the strategic location of the infarct. The commonest sites being involved are frontoparietal lobe as well as basal ganglia and pons. Asterixis, again, the site commonly being involved is thalamus, frontal lobe, or lenticulocapsular area. Asterixis is basically thought to be due to dysregulation of the various tracts which connect from the cerebellum up till the frontal lobe, that is cerebral lobe brainstem, whereas thalamo-frontal lobe circuits. And any small infarct not initially visualized in the strategic area can also lead to asterixis. Holmes tremors, which is characterized by resting tremor of a limb, commonly noted due to an infarct involving the midbrain or any part of the brainstem as well as cerebellum. The only thing about it is it can be delayed. It is very rarely noticed in initial part or immediately following a stroke. Usually noticed beyond 2 weeks, can present even as high as up till 3 months after the stroke. The treatment options for it would be from propranolol up till sodium valproate. However, levodopa response is noticed in about 35% of the patients. Hence, initial trial of levodopa is taken up in patients presenting with Holmes tremor. Non-responsive to that, then the use of other drugs can be considered. Palatal tremor consists of a brief rhythmic involuntary movement of the soft palate, where a lesion is noticed in the Guillain-Mollaret triangle, which is formed by the red nucleus, inferior olive, as well as this particular part, the red nucleus, inferior olive, as well as the dentate nucleus. Coming to vascular Parkinsonism, also considered as one of the form of secondary or atypical type of the Parkinsonism, accounts for about 15% of the cases initially diagnosed as idiopathic Parkinson's disease. However, we all are well aware that we call it as lower half Parkinsonism or symmetrical involvement of the bilateral lower limb. Since the gait involvement is noticed and initially can be mild, is missed in majority of the cases. The rate ranges as high as 30% for missing up of the vascular Parkinsonism. Certain individuals we do notice once they start any decline in the cognitive function, then our attention is drawn towards the analysis or diagnosis of vascular Parkinsonism. Acute cerebrovascular events can also lead to acute Parkinsonism when the strategic involvement of midbrain or basal ganglial structure is noticed. There are various diagnostic criteria which are used for vascular Parkinsonism, such as Littleman's diagnostic criteria as well as Winnicott's diagnostic criteria. Basically, all of these criteria depends upon the clinical presentation and the duration of the symptoms. However, any patients presenting with involvement of a symmetrical involvement of the lower limb, we should consider the diagnosis of vascular Parkinsonism, which might be associated with other cognitive features. So these two criteria are considered as for the evaluation of vascular Parkinsonism. Coming to the next complication, that is post-stroke seizure, the commonest according to our setup, apart from the infections and initial part of the aspiration and raised ICT, we do come across post-stroke seizures. So post-stroke seizures, the incidence varies between 7 to 10%, but certain studies have noted as high as 25% following ischemic stroke. However, hemorrhagic stroke are more likelier to cause post-stroke seizures. The risk predictors for post-stroke seizures would depend initially upon the areas involved and the type of the stroke. Cortical strokes predicting a higher risk, whereas involvement of caudate going to the lower down. However, involvement of either one or more than two of these risk factors predicts a more than 40% chance of a person developing seizures. So we divide these post-stroke seizures as early and late, depending upon the duration. That is, between less than 2 weeks, would be considering it as early post-stroke seizures, and beyond 2 weeks, we will be considering it as late post-stroke seizure. So the pathophysiology again is same, because of the inciting event, various excitatory changes taking place in the surrounding areas of the stroke as well as in the primary area, leading to a process of epileptogenesis, which gives rise to higher chances of developing a stroke. Treatment for post-stroke seizure, the one and the commonest thing which is considered is there any role of prophylactic anti-epileptic therapy in individuals developing for stroke, which is discouraged as far as various guidelines are considered as well as studies until the onset of the seizure. If there is an early onset of post-stroke seizure, even certain studies have recommended to use benzodiazepines SOS during the initial stage and to wait for as they do resolve on their own. However, late onset of post-stroke seizure do require long-term anti-epileptic therapies. And the choice of the drug depends not just on the semiology and on various factors which come along with the patient.
Sorry to interrupt, sir. You have just 5 minutes left for the presentation.
Sure. Yeah. So the next would be alien hand syndrome, which is characterized by involuntary and uncontrollable motor behavior, and the sites which are being where the in fact we consider apart from the other causes for this alien hand syndrome would be left mediofrontal cortex and corpus callosum. Again, it has been classified into various types depending upon the involvement of either medial frontocortex or corpus callosum. The treatment would depend upon the etiology. Definitely when it is a stroke, we'll be considering antiplatelets. Amantadine and methylphenidate have got certain amount of role in the management of alien hand syndrome. So coming to the last few slides, spasticity, as we all are well aware, is one of the most disabling complications which a person with stroke does experience. Here, if we consider the percentage wise, between 3 to 6 months is the duration where the highest percentage of spasticity would be noticed. Again, it goes on the severity of the stroke, the site of the involvement. Because of the loss of the this is the pathophysiological slide leading to spasticity, loss of supraspinal inhibition, ultimately leading to an higher lower reflex level, leading to spasticity. These were certain guidelines which are still being considered in the European level, not yet generalized. When would we need an urgent referral to periodic monitoring? So in case if two of these features, that is increased muscle stiffness across 2 or more joints and severe loss of the sensory motor function is considered, an urgent multi-team involvement and management of this patient is considered. Whereas when we are talking only about an individual suffering from dexterity problems, only periodic evaluation and re-examination should be considered for a duration of about 3 to 6 months. However, in between these two, a multidisciplinary team, not just evaluating the patient, but also going ahead with physiotherapy and medications has to be considered in this patient. So management of spasticity, we all are well aware, varies from physical management up till the surgical options. However, most of the time we are struggling between physical management as well as the oral medications. If the severity of spasticity is to an extent it's impairing the daily activity of the individual, we should go and consider regarding the botulinum therapy as well as surgical options. Cortical hand syndrome, it is the strategic involvement of the hand area. In fact, in that area, also known as the hand knob area, leads to a typical weakness which can involve either only a hand associated only to the extent of involvement only of the thumb. Sometimes even finger involvement may be noticed, whereas the remaining part of the proximal arm remains normal. Cortical sensations is the clue in such individuals where cortical sensations are affected. Post-stroke falls. Post-stroke fall, again, it goes as high as up to 37% in all the stroke survivors. It depends upon the various factors. We have to look for between the initial first week up till the 12th week for the highest incident of falls. The risk factors which are considered for falls in the post-stroke individuals would be motor deficit up till autonomic dysfunction. However, motor deficit and autonomic dysfunction together constitute about 50% of the risk factor which is responsible for fall in these individuals. So this is a chart where it forms a vicious cycle following stroke, where an individual can land up with the fracture and other complications in the form of DVT. Hence, once we discharge a person post-stroke, It is of utmost importance to for a regular follow-up and assessing the risk of fall, for which various scales have been taken up in the recent past. Concluding my last two slides, post-stroke dysphagia, a most difficult part for us to consider once the individual develops this, and its percentage of post-stroke dysphagia varies between 28 to 65%. However, most of the individuals usually improve beyond 2 weeks by their own self. It is thought that certain reorganization of the subcortical structure leads to the broadening of the area and involve improvement in the dysphagia. So bedside, there are various screening tests which can be considered for dysphagia, and the most commonest which we can follow is the bedside swallow test, and it is the easiest way to assess for dysphagia bedside. Various behavioral treatment approaches are considered for management of patients with dysphagia in the form of postural adjustments, altering the bolus characters, and increasing the volitional control phase. However, there are certain other maneuvers which are considered might be difficult to carry out these maneuvers on the bedside, but at least compensatory mechanisms might help in the early initiation. So these are the various dysphagia techniques which can be considered bedside. Thank you.
Thank you, Dr. Zohaib, for your wonderful and excellent talk. See, when we think about motor complication, we think of mainly weakness, muscle weakness, rigidity, or spasticity. Since there is no much literature available on motor complication of stroke, your talk was an eye-opener. You covered all aspects of motor complication. One should be aware of this motor complication of stroke as the treatment varies. With your talk, we would emphasize more on these motor complication of stroke in our daily practice, because these are the gray areas of neurology. Thank you, Dr. Zohaib, once again. Now, our next speaker is Dr. Shrikant Javalkar, sir. Sir, are you there, sir?
Ma'am, first I would like
Yes, I am ready. Can you hear me?
Yes, sir.
Right.
Zohaib, sir,
Dr. Shrikant, sir, you want anything?
Ma'am, first Zohaib,
hello?
sir.
Ma'am, just
Dr. Zohaib?
Yes, I've stopped the slide share, ma'am.
Right. I'm sharing my screen.
Yes.
One second, sir. One
second, sir.
Sir, can you stop sharing your slides, sir? 1 second.
Just a minute. Just a minute.
I'm sorry to interrupt you, sir.
Let me introduce our favorite sir, Dr. Shrikant Javalkar, sir. Sir has been my teacher since my residency days. I feel so privileged and happy that you have graced this CME as a speaker. Sir did his MBBS from Osmania Medical College, Hyderabad. Sir did MD from General Medicine from PGI Chandigarh, and he did DM Neurology from PGI Chandigarh. Sir is the professor and ex-HOD Department of Neurology, Deccan College of Medical Science, Hyderabad. He is the pioneer in introducing the postgraduate program at Deccan College of Medical Sciences in the year 2012. His areas of interest are stroke, epilepsy, and movement disorder. Sir has multiple publication and book chapters.
Nothing to do.
I welcome you, sir, for your talk on non-motor manifestations of stroke.
Yes.
Sir?
Am I audible clearly?
Yes, sir.
Dr. Sandhya, yes. Firstly, I thank you for the very nice introduction. Of course, I was incidentally instrumental in starting the Department of Neurology, and all of you are doing very well after my retirement. Congratulations to you. Now, after the initial session in the morning where about treatment of acute stroke, myself and Zohaib are dealing with post-stroke complications, those who have survived after the stroke. When you told me first about talking about the non-motor complications of stroke, I was a little perplexed, because complications means the things which come after a certain period of acute stroke. So I have slightly modified the title. I will be dealing with non-motor manifestations of stroke instead of just restricted to the complications of stroke. So let's start with the first slide. The non-motor manifestations of strokes, generally these are not, easily recognized, and most of us don't pay much attention to these things. But when I started reading about these strokes, I realized they are very important and very common, as well as disabling not only to the patients, but the patient's caregivers also. And they have cause a greater loss of productivity and reduction of quality of life in patients. And this burden of the patient is also shared by the caregivers, because suddenly there is a loss of finance earnings to the family, and then most of the family members have to take care of the person who is incapacitated. But luckily, many of these non-motor complications are treatable, and intervention improves the quality of life of the survivor. I'll take one by one these disorders. The first and most common is mood disorders. Under this, we'll be dealing with depression, mania and bipolar disorders, anxiety, and apathy. Out of all these, depression is the most common, and it's obvious. A person who has been mobile, independent, and earning bread earner for the family suddenly becomes dependent on others. So it's very common and very logical to have a patient or stroke going into depression. But it also very effectively treated. A clinically significant depression occurs in about 20%, 23% of the stroke survivors. And the depression generally sets in later, when the patient recognizes that he's not going to recover very soon, and maybe sometimes he's not going to recover at all. And that is the time, generally about 3 months after the stroke, that they realize their situation and go into depression. And I'll take up the treatment at the end of the talk one by one, but it has also been shown that treatment with antidepressants also has a positive effect on motor recovery of the patient. The next mood disorder is bipolar disorders or mania. This is relatively uncommon. It's commonly seen in right cerebral infarcts. And in this study, the patients who had a family or personal history of psychiatric disorders were eliminated, thereby indicating that the bipolar disorder was a direct result of right hemispherical stroke. The next mood disorder is anxiety, again very common and very understandable also, and it is often associated with depression. The incidence is 26% in men and 39% in women. And again, like depression, it's easily treatable with drugs. The last disorder is apathy. It is reported again, particularly in right hemispherical strokes. In general, all these non-motor complications, except aphasia, are more common in right hemispherical strokes. The apathy is sometimes difficult to identify because it may be associated with depression and anosognosia. And the treatment is difficult. It's not easy to treat apathy like anxiety or depression. The next non-motor complication of stroke is fatigue, and it is common and also a long-lasting symptom of stroke. Various studies show that the incidence is between 29 to 77% of stroke survivors. And the cause of post-stroke fatigue is not really understood. It's independent of the motor deficit. Those who recover from the motor deficit also complain of post-stroke fatigue. The reason given is that in functional MRI imaging, it is shown that when a person moves a certain limb, a very large number of neurons and circuits are activated as compared to those who are normal. So it may be that the result for maybe the fatigue may be the result of more neurons and circuits coming into play for doing the work which is normally done by lesser number of neurons, and it's postulated this may be the cause of fatigue. Next common disorder is attention disorders. Most of the right hemispherical strokes suffer from hemispatial neglect. That is, they neglect the paralyzed side of their body and also the space on the contralateral side of the stroke. That is, suppose the patient has a right hemispherical stroke, the patient does not recognize or admit that he has got left side weakness, as well as he will tend to ignore persons or any objects in the left side, on his left side and left visual field. And this can sometimes be a very significant handicap. Language disorder. I think this is the second most common disorder, second most common non-motor disorder after the mood disorders. This happens in right hemisphere strokes. There may be impairment of production as well as comprehension of the spoken and written speech. And it also is a disabling and frustrating because the patient cannot express himself and the patient's relatives and caregivers many times cannot understand what he is telling. And the language disorders may be in the form of aphasia, alexia, agraphia, or acalculia. This was one patient who came to recently, a 40-year-old man. His son was telling that my father suddenly started talking irrelevantly. Whatever we ask, he says that I don't know, I don't understand, and he goes on repeating the same thing. So they thought probably he has lost his memory or something. But when we got the MRI, as you can see in the screen, he had a left posterior parietal and temporal infarct, and this was the cause of his speech disorder. I think we can skip this slide. Next, we come to disorders of emotional communication and empathy. There is impairment in expression as well as recognition of emotion. Many times, the patient has recovered from his motor deficit, but his spouse or relatives tell that he seems to be unconcerned. And he is unconcerned about his own handicap as well as the emotions and of the caregivers. He seems to be in a completely different world. This happens because of the emotional communication is affected, one by the speech problem. There is dysprosody. Most of the times, we express our emotions by inflections in our speech, by change in volume, change in tone, etc. People know that whether we are sad or angry or happy, but this is lost in patients with stroke. They speak in a monotonous tone, so it is difficult to understand their emotional relations. And most of the times, all the emotions are affected, but sometimes specific emotions like fear and disgust may be affected in right temporal, insular, and amygdala strokes. And again, these disorders happen in right cerebral stroke. Next, we come to a very important complication, memory and other cognitive functions. This is again very common after stroke. Cognitive function declines after stroke due to following mechanism. One, it may be a direct result of the lesion, like lesions in hippocampus or temporal lobes may directly cause cognitive impairment. Second, it may be a result of hypoperfusion. If there is a stroke is due to a hypotension or a cardiac arrest, there is a global hypoperfusion, and this may subsequently cause memory disturbances and cognitive function impairment. Thirdly, it may be due to small vessel disease disrupting white matter connections between different cortical regions. And in most of these cases, there is a gradual improvement over months or years, but some cases continue to deteriorate and go into what is called as post-stroke dementia. The incidence of post-stroke dementia ranges from 6 to 32%, ranging from mild cognitive impairment to severe dementia. MCI may progress to dementia in some cases only. And there are various mechanisms of vascular dementia. It may be just MCI, multi-infarct dementia, or a single strategic infarct like infarcts in frontal, parietal lobes, or in thalamus, or in singular gyrus. Or there may be multiple lacular lesions, as in a small vessel disease. Hemorrhagic lesion, multiple hemorrhagic lesions like in amyloid angiopathy also can lead to vascular dementia. Then subcortical leukoencephalopathy can cause subcortical vascular dementia, and then rarely CADASIL. But in many cases, the cause of this dementia, post-stroke dementia, may be mixed cause. Elderly persons may have Alzheimer's, superimposed on then vascular dementia also may complicate the picture. Here is an example of a strategic infarct in thalamus causing vascular dementia. vascular dementia caused by multiple lacular infarcts in the white matter. And here is an example of amyloid angiopathy. The multiple black holes you see in the posterior parts of the brain are responsible for the dementia in this patient. Now, next we come to another complication, much less than other things. Other complications is the delirium and impaired consciousness. The incidence ranges between 24 to 48% in acute stroke. It's more common in hemorrhagic than in ischemic stroke, and it's more common in large hemorrhages and large infarcts. Seizures, Dr. Zohaib has already dealt just before me. The incidence is about 10%. And as he has mentioned, the seizures can be classified into two types. Those seizures occurring at the onset. Here, the risk of recurrence is much less. So these patients can be treated with anti-epileptic drugs for 3 to 6 weeks, and then we can discontinue the anti-epileptic treatment. But the late onset seizures, which generally develop 1 year after the stroke, have a high risk of recurrence, and these patients need to be treated like any epilepsy case. Sleep disorders. This is another area which is often ignored. At least I ignore this many times and fail to inquire about the sleep disorders in stroke cases. And the incidence is supposed to be around 50% of stroke survivors. And the sleep disorders may be in the form of obstructive sleep apnea, central sleep apnea, restless leg syndrome, hypersomnia, and insomnia. Now, the other symptoms are visual symptoms. And the visual symptoms can be due to the infarct in any part of the visual pathway, leading to either a monocular blindness, hemianopia, quadrantinopia, various scotomas, and visual neglect. Here was a case, a 50-year-old lady who had suffered from COVID about 3 months back, and she came to me with sudden loss of vision in one eye. She didn't have any other symptoms, surprisingly. The only symptom was loss of vision in one eye. And the MRA shows that there is a complete occlusion of the internal carotid on one side, leading to optic atrophy. This is a diagram showing the visual pathway, and the lesions in different places can cause different sorts of visual defects, leading from complete loss of vision, hemianopia, quadrantinopia, and in the posterior pathway, there will be sparing of the macula. There are some miscellaneous disorders which occur in post-stroke non-motor complications like urologic disorders in about 33 to 60% of cases in the acute setting. And these symptoms may persist in about 15% at 6 to 12 months. And vertigo occurs in posterior circulation strokes. Now we'll come to the treatment of non-motor manifestations of stroke. The three main stages of treatment are physical, behavioral, and occupational rehabilitation, medications, and non-invasive brain stimulation. The third, that is non-invasive brain stimulation, is still not a very well established and not easily available mode. It may be either a direct current stimulation of the brain or transmagnetic stimulation. These modalities are still in an experimental stage, but the first two will deal in more detail. Now, taking the disorders one by one, first taking up the mood disorders, the counseling and behavior therapy are the mainstays, as well, and then the counseling of the patient caregivers also is very, very important. The drugs like SSRIs and anxiolytics are very effective in treating depression as well as anxiety. Lithium valproic acid and lamotrigine help in treating mood disorders. Fatigue. The next problem is fatigue, which is very difficult to treat actually, but sometimes modafinil and amantadine may help. But exercise seems to be the best option. The patient has to be motivated to do exercise, and this really helps in overcoming the fatigue. Language disorders, behavioral and speech therapy will be the mainstay of treatment. Direct current stimulation and transmagnetic stimulation are being tried. Sometimes donepezil 10 milligrams per day helps in treating language disorders also. Hemispatial neglect, no definitive treatment. Experimental therapies like prism adaptation and brain stimulation are being tried. The next problem is dementia, and here again the cognitive rehabilitation helps in a big way, and drugs which are used for dementia like cholinesterase inhibitors, donepezil, rivastigmine, and galantamine and memantine may help to a certain extent. Seizures already has been dealt, and the seizures have to be treated like any other case of seizure disorder, and the drug treatment is very effective in treating seizures in post-stroke cases. Sleep disorders, obstructive sleep apnea, CPAP, and weight reduction definitely will help. Restless leg syndrome, propinerol and pramipexole, the patients respond very well to these two drugs. Hypersomnia, modafinil, methylphenidate, and levodopa also has been tried. And insomnia, zolpidem and sedative antidepressants like trazodone will help. Pain, again, Zoeb has partly dealt with this topic also. The treatment depends on the cause of pain. Spasticity, baclofen, tizanidine, and sometimes botulinum injection and physiotherapy. Thalamic syndrome, which occurs in infarcts of the thalamus, tricyclic antidepressants, gabapentin, pregabalin, duloxetine, and in rare cases, deep brain stimulation and stereotactic thalamotomy will help to relieve the pain. With that, I come to the conclusion. My sincere thanks to the audience, to organizers, Dr. Sandhya and her team, and special thanks to Dr. Chandra, who helped me to decorate my slides. Thank you very much.
Thank you, sir, for such an interesting talk. It's a pleasure, sir, listening to you. You were like the invisible guiding force throughout, sir. Your enthusiasm is contagious. Thank you, sir.
Thank you. Thank you, Sandhya.
Thank you, sir.
Congrats, till now it has been going on very well, and I think you will end in a very happy note. Thank you very much.
Okay, sir. Thank you, sir.
Sandhya ma'am, please unmute yourself and introduce the next speaker, Dr. Sinchu sir, ma'am.
Okay, 1 minute.
Sandhya ma'am, please unmute yourself, ma'am. Sandhya ma'am, are you with us? Sandhya ma'am, are you with us, ma'am? Okay, I'd like to introduce the next speaker of the session, Dr. Sinchu C. Manyangat sir. He has done his MBBS from Trivandrum Medical College in the year 1998, DNB General Medicine from Trivandrum Medical College, graduated in 2004. Sir has done his DNB Neurology from Trivandrum Medical College, and sir has done his postdoc fellowship in stroke from Sri Chitra Institute. Sir is currently working as a senior consultant and stroke specialist in PRS Hospital, Trivandrum. Sir has more than 20 publications to his credit, and areas of interest being stroke and intervention and autoimmune neurology. Sir, I welcome you to the next talk. So please share your screen. And thank you for being a part of our CME. Sir.
Reshma?
Yes, ma'am, please talk. Yes,
yeah, just I'll tell few words about him. It is my pleasure. Actually, internet some connection was there, so I could not introduce him. He is my own MBBS batchmate and my friend, Dr. Sinchu C. He is calm and quiet with always a pleasant smile on his face and always explains in detail my doubts on stroke. And he has a strong subject knowledge. Welcome you, Dr. Sinchu, for the most important and the difficult topic, that is the landmark trials in stroke. Over to you, Dr. Sanju.
Thank you, Sandhya. Good evening, respected senior colleagues and my dear friends. Today I'm going to present the landmark trials in stroke. Is my slide visible?
Yes, sir. Yes, sir. Clear, sir.
Okay, we'll start. So first of all, I would like to congratulate Sandhya and her team for doing a wonderful job conducting such a marvelous stroke symposium. Now, this landmark trials in stroke is a boring topic, but I will try to make it as interesting as possible. Now, I'll say that even after this brainstorming session, I'm not going to trouble you with any statistics. Just sit back and relax and enjoy the history which is being unfolded as a thriller through the following landmark trials. Now, before going to landmark trials, we should know about the outcome in any disease. So in stroke, we take modified Random scale, that is MRS, at 3 months post-stroke as the benchmark for recovery. So if a patient develops a stroke, you treat him, and at 3 months, if his MRS is 0 to 2, we say that he had a good outcome. If it's 3 to 6, we say that the treatment has not worked, it is a bad outcome. So 0 means after 3 months after the stroke, patient has no symptoms. Or 1 means there is no significant disability, able to carry out all pre-stroke activities. 2 means patient has slight disability, but he can look after self without daily help. So that means the patient after 3 months can do all his activities without help. We say that the patient has improved. But on the other hand, if the patient requires some external help for activities of daily living, he is considered not improved. That is, even he may be walking without support, but even then we will say that the patient has not recovered. So anything below 3, that is 4 is moderately severe disability, 5 is severe disability, bedridden patient. 3, 4, 5, we take it as unfavorable recovery. So the scenario changed in 1995. Before 1995, patient with presumed stroke arrives in casualty, gets admitted in the ward. If fortunately gets a CT brain, we will start aspirin and then pray to Almighty. We will say that this is a nihilistic approach, but that was the truth. Till the first landmark trial in stroke arrives on scene, and that was none other than our NINS RTPA study. The NINS RTPA study was published in the NEJM in December 1995, which was conducted by the National Institute of Neurological Disorders and Stroke, RTPA Stroke Study Group. That is why it's known as NINS RTPA study. Actually, it was a randomized double-blind controlled trial, and they used recombinant tissue plasma activator, we call it as RTPA. The trial had 2 parts. Part 1 tested whether TP had a clinical activity and assessed improvement at 24 hours. And part 2, they assessed the clinical outcome at 3 months after RTPA infusion in stroke patients. So coming to the part 1, it was a smaller trial. There was 291 patients who were enrolled. They tested whether TPA had clinical activity at 24 hours. And the improvement they wanted was patient should improve by 4 points of the baseline NIHS or should have a complete resolution of neurological deficit within 24 hours of the onset of stroke. And the results was as expected. There was no significant difference between the group given TPA and that given placebo in the percentage of patients with neurological improvement at 24 hours. So plainly speaking, we should not expect any significant difference in patients, in our patients whom we give TPA at 24 hours. So our junior colleagues, do not look at the 24-hour NIHS and become desperate saying that the patient has not improved. Just look at the 3-month MRS. And in this part 1 study itself, the benefit was observed for the TPA group at 3 months for all the 4 outcome measures. In the part 2, there was 333 patients, 168 in the TPA arm and 165 in the placebo arm. They assessed 3-month post-stroke, what is a Barthel index, what is MRS, what is a Glasgow outcome scale, and what is NIHS. And the results was patients treated with TPA were at least 30% more likely to have minimal or no disability, that is MRS 0, at 3 months as compared with patients given placebo. And this was the first trial which could prove that stroke is a treatable disease. With a drug, we can have at least 30% more likely patients having the minimal disability. And the downside was the symptomatic intracranial hemorrhage at 36 hours was 6.4% in the TPA group and only 0.6%. That was also statistically significant, but that didn't increase the mortality. The mortality at 3 months was 17% in TPA group, 21%, and it was not statistically significant. So the final verdict was that this is the conclusion they have given. Despite an increased incidence of symptomatic intracranial hemorrhage, treatment with IV TPA within 3 hours of onset of ischemic stroke improved clinical outcome at 3 months. This was the landmark trial which led to the approval of intravenous RTPA by US FDA the next year itself, part on basis of the second part of NINS trial. Why I call this as a landmark trial? Because before NINS RTPA study, it was a nihilistic approach, and that perception about stroke changed with this trial from being a treatable disease to the stroke being an untreatable disease, changed to a treatable disease. It made stroke a medical emergency, and more than that, from our armchair neurologists, we became dashing neurologists. Basically, literally meaning that we dashes from ER to the CT or MRI console, and then from there we dashes to ICU, and then again dashes back to our OP, again dashes to ER. This dashing neurologists became the fashion after this trial. And one more important thing was that this gave the concept of time is brain, because in stroke, every minute counts. With each minute, 1.9 million brain cells are lost. So it became a landmark trial showing that treatment should be quick and time is brain. Now, after this trial, the other trials were started to increase the window period because not much patients came within 3 hours. So the 3 other trials which were later published were the CAS2, Atlantis A, and Atlantis B. But unfortunately, all the 3 were negative. There was no significant benefit for IVTP in the 3 to 6 hours. And then in 2008, the next landmark trial comes, the CAS3 trial. And this was a trial. This is known as European Cooperative Acute Stroke Study, or CAS3, published in 2008 in NEJM. They tried thrombolysis multiplex, the IVTP, 3 to 4.5 hours after ischemic stroke. And the dose was also 0.9 milligram. 821 patients, 418 in the multiplex group. And you can see the median time for administration was around 4 hours after the onset. And the primary endpoint was much more stricter. From MRS 0 to 2, their favorable outcome should be 0 or 1. 2 will be coming into the unfavorable outcome. And even with this strict criteria, they had a favorable outcome in 52.4% in multiplex group compared to 45% in placebo with a significant p-value. But the intracranial hemorrhage and also the symptomatic intracranial hemorrhage was also more in the multiplex group, which are also statistically significant. And with this trial, the window period for IV thrombolysis was extended from 3 hours to 4.5 hours. So that is why we call this as a landmark trial. There were exceptions, people more than 80 years with severe stroke, with online equivalence, stroke plus diabetes mellitus. These people were not included in this trial. And so these remained as exceptions in the guideline also. And then with this trial, the guidelines changed to the window period to 4.5 hours. Then the people wanted to include these people, these subset of people also into this 4.5 hour window. So they went ahead with other trials, and this was the next trial, which is the IST3 or the third international stroke trial. Actually, this is a negative trial. They wanted to study RTPA within 6 hours, but thing was that they included more subsets of patients. One was the patients more than 80 years, 53% were older than 80 years in this group. It was a truly international study with 156 hospitals, 12 countries, 3,000 patients. But unfortunately, here also there was no statistically significant difference between the RTPA group and the control group in the 3 to 6 hour window. But this made us bold to include more patients in our IV thrombolysis because we can thrombolyze more 80 years and more people with INR less than 1.7. Such a concept was brought after this IST3 was published. Now again, people tried to improve on this one by increasing the window period going through the mechanical thrombectomy route. So the mechanical thrombectomy trials were gaining in popularity, but unfortunately, all the three trials which were published in 2003, that is synthesis expansion, MR rescue, and IMS3, which were mechanical thrombectomy trials, were negative. So this is known as the year of three negative EVT trials. And just all these three were published in NEJ. We'll just briefly see, even if it's a negative trial. The first one was sorry for the interruption. The first one was IMS3. It was stopped early because of futility after 656 position. And there was no difference between the endovascular group, that's mechanical thrombectomy group, as against the IVTPA group. There was large number of patients in the EVT group. And the next one was MR rescue. They tried 8-hour window. There was no difference between that 3-month MRS in the embolectomy and standard care. It was 3.9 and 3.9 in the standard group. And the third one was our synthesis expansion. In this one, they tried only 4.5 hours. In addition to the retrieval, stent retrieval, mechanical plot disruption or intra-arterial thrombolysis was also allowed. But unfortunately, the patients on IVTPA group had a more good outcome rather than the endovascular therapy group. So they concluded that patients with acute ischemic stroke, endovascular therapy is not superior to standard treatment. With these trials, everything came to halt. There was an intermission. Nothing is working. Even after 15 years after our RTPA trial, it's only RTPA. And then in 2050, the next hero comes. He had come with newer gadgets like solitaire device, TUO device, ADAPT device. And in 2015, 5 landmark mechanical thrombectomy trials were published from different parts of the world. This is called a landmark. Why? Because these 5 randomized trials show positive results for endovascular treatment in patients with large vessel occlusion. And the 5 trials were MR Clean from Netherlands, SQ from Canada, USA, Extend IA from Australia, New Zealand, SIF Prime from US and Europe, Revasket from Spain. Just briefly through each of these trials, MR Clean was the first one to be published, and that had 500 patients from Netherlands. And they had a pragmatic trial with minimal criteria. NI should be more than 2. Patient should come in 6 hours onset. There should be an occlusion. That's all. And you can see that among the 500 patients, 445 had received IV altiplase also. And this group, our intervention group, had favorable outcome in 33% compared to 19%, which was statistically significant. And they concluded that statistically significantly more patients achieve function independence at 90 days in the intervention group. And with the presentation of this trial, the 4 trials which was coming behind, they all underwent interim analysis of the data and found that everything was positive, and all the other 4 trials stopped prematurely. So till date, this is the only fully powered study among these mechanical thrombectomy trials in this group. And then the escape was the other trial which showed positivity, and that had a window of 12 hours. They had a stricter criteria. They should have a CT aspects more than 5. They should have a more than good collaterals with more than 50% collaterals. And the imaging to groin puncture time should be less than 60 minutes. Target groin puncture to reperfusion time less than 30 minutes. This was a very strict criteria. And obviously the improvement was seen in the function independence from 33% in MRP, it increased to 53%. So function independence was seen in 53% versus 29%. And also this is only tried to demonstrate statistically significant reduction in mortality also. And the next one was our Extend IA from Australia. They had a 6-hour window. This one was showing a perfusion imaging. This one wanted perfusion imaging as a criteria. And this was the first trial to use a rapid software. And they had a very good reperfusion rate of 86%, and the function independence increased to 71%. And there was a large time to mortality benefit. And the last one was the SIF Prime. SIF Prime, it was from US, it has 6 hours onset window. They had the highest reperfusion rate, 88%, but the function independence was only 60%. Even now we know that even if the reperfusion is 100% fully present, the recovery may not be that much full. And there are no significant difference in the 90-day mortality or symptomatic intracranial hemorrhage. So they concluded that patients receiving IV TPA for acute ischemic stroke with occlusions in anterior intracranial circulation, thrombectomy within 6 hours improved functional outcomes. And the last trial was the from Spain, the Rivasca trial. They had 8 hours windows. They had a longest door to groin puncture time of 269 minutes. That was a very long time. And so their functional independence rate was only 44%. So from 71%, it dropped down to 44%. That also is a true principle which holds even now. Even if you go for a thrombectomy, do it as fast as you can. And that was also halted early because of the other trials coming before it. And with these 5 trials, the 2015 focused update was published by AHASC, and they worded it as patients should receive endovascular therapy with a stent retriever if they meet all these criteria. That is, a patient more than 18 years coming with a IC or proximal M1 occlusion within 6 hours with a NIHS more than 6 or aspects more than 6 should receive endovascular therapy with a stent retriever. And this was followed by other trials also. So we have got a new treatment modality in the form of mechanical thrombectomy. Now, but the subset of patients who were excluded were more. So they wanted other trials also to include these patients. So they didn't look at the aspects of the perfusion to exclude the patient. In all the trials, good aspects were required. So in Triage, from France, they included 57 patients who had aspects of 0 to 4. Even now, that guidelines do not permit these patients to be included in trial, included in our clinical practice for mechanical thrombectomy. And you can see that 30% of them had good outcome. So this again showed us that we can include more patients in our IV thrombectomy group, mechanical thrombectomy group. And they conclude that bridging therapy should be considered for all patients with large vessel occlusions of anterior circulation. But again, we are stuck with 6-hour window. So we wanted to increase the window to the next level. And now the new hero dashes in. And that was the Dawn trial, which increased. They tried thrombectomy at 6 to 24 hours after stroke, and they wanted a mismatch between deficit and infarct. Just briefly, you can see that their inclusion criteria was very clear. Patient should be last seen 6 to 24 hours earlier. There should be occlusion of the IC or NCA and M1 segment, and the mismatch should be between the severity of clinical deficit as measured by NIHS and the infarct volume as measured by the rapid software. And it was a large trial from 26 centers, 107 in thrombectomy and 99 in control group. They used measured volume using rapid software. There are 3 groups. If the patient was more than 80 years, then the NIH should be more than 10 and the infarct volume should be less than 21, meaning that NIH is more than 10 means it's a severe stroke, but the infarct volume less than 21 means it is a small core. So the core is small, the severity is small, that means there is a mismatch. That is known as the clinical infarct volume mismatch. But in the second group, if the patient is less than 80 years, if the NIHS is more, they can have an infarct volume of 31. That is a small, little larger core also they will take up for this trial. And the group C, if a patient has very severe stroke, that is a NIHS more than 20, then the infarct volume could go up till 51 ml. And they have concluded that the results showed that function independence at 90 days was 49% in the 6 to 24-hour group with thrombectomy as compared with 13% in the control group. In the control group, there was no thrombolysis because they are already for 6 hours. And the interesting thing was that even at this point of time, this 24 hours, the rate of symptomatic ICH and mortality did not differ significantly. And so they concluded that among patients with acute stroke who had last been known to be well 6 to 24 hours earlier, and who had mismatch between clinical deficit and infarct, outcomes for disability at 90 days were better with thrombectomy plus standard care than with standard care alone. And this led to the change in the guideline to include more patients till 6 to 24 hours after the onset. Now, this was followed by another trial, Diffuse 3. Here, there was a change in the inclusion criteria. Instead of clinical volume mismatch, they tried diffusion perfusion mismatch. Actually, what they did was they took up patients for thrombectomy in the 6 to 16 hours window. They should have some remaining ischemic brain tissue that was not yet infarcted, which was as evidenced by our perfusion imaging. The diffusion shows the volume of the infarct. That is, the volume of infarct should be less than 70 ml. That means it's a small core. And the perfusion shows the ischemic penumbra, and the ratio between this volume of ischemic tissue to infarct volume should be more than 1.8. So that means there is a penumbra which we can salvage. And we can see in this example, which they have given in the article, the core is only 23 ml, but the perfusion lesion is 128 ml. The mismatch ratio is 5.6, that is more than 1.8. And they have two groups, endovascular and medical therapy group, and they have a very good response in the endovascular group, that is 45% had a functional independence at 90 days, versus 17%, which was statistically significant. They also did a shift analysis. What they mean by shift analysis, they plot the MRS in the y-axis and see how many patients had shifted to MRS2. Here we can see that from MRS 0, 1, 2 includes 45% of patients. Here it's only 16%. So this showed a favorable shift in the distribution of functional outcomes of 90-day MRS. So with these two trials, the guideline again came up. The 2019 update of the 2018 guideline. They said that in selected patients with ischemic stroke within 6 to 16 hours with LVO who meets dawn or diffuse criteria, mechanical thrombectomy is recommended with level 1A evidence. And in 16 to 24 hours, they requested dawn eligibility criteria. Then after this trial, the IV thrombolysis also people wanted to improve the window period. So the next trial, this was in 2018, the Wake Up trial. This was a positive trial. This was a landmark trial because from ages on, we were excluding patients who woke up with stroke because there was the time of onset was unknown. Now this trial wanted to determine whether patients with stroke with an unknown time of onset and features suggesting recent cerebral infarction MRI would benefit from thrombolysis with IV TPA. And they used the diffusion flare mismatch as a marker for viable tissue. That is ischemic lesion that was visible on MRI in diffusion, but no parenchymal hyperintensity on flare. That is diffusion positive, flare negative means there is a patient was within 4.5 hours. And they had to stop owing to cessation of funding, but it was a positive trial. The favorable outcome at 90 days was in 53% compared to 41.8%. And so they concluded that in patients with acute stroke with an unknown time of onset, basically patients who woke up with stroke, intravenous alteplase aided by a mismatch between diffusion and flare in the region of ischemia resulted in a significantly better functional outcome. But there was numerically more intracranial hemorrhages than placebo at 90 days. So the trial, with this trial, the HASA guideline worded like this: in patient acute ischemic stroke who awake with stroke symptoms or are unclear time onset more than 4.5 hours from last known MRI to identify diffusion positive, flare negative lesions can be useful selecting those who can benefit from IV alteplase administration within 4.5 hours. Level 2A BR. So with the advent of mechanical thrombectomy and the rapid software, people began to think, why don't we use rapid software to improve the window period for IV thrombolysis? So the next landmark trial was the Extend trial, which was published in May 2019 in NEJM. That was actually thrombolysis guided by perfusion imaging up to 9 hours after onset of stroke. So from 4.5 hours, they jumped to 9 hours. And this was the Extend trial. It was randomly assigned to, means patients were randomly assigned to receive IV TP between 4.5 and 9 hours. And also they included patients who woke up with stroke if the patient was within 9 hours from the midpoint of sleep. And the only criteria was that they should have a perfusion lesion ischemic core mismatch ratio greater than 1.2. And ischemic core volume of less than 70 ml. That means a small core with a good penumbra, like a mechanical thrombectomy trials. And they showed that there was a good outcome in 35.4% patients compared to in the IV TPA group compared to 29.5% in the medical group. It was statistically significant, although the symptomatic intracerebral hemorrhage was also statistically significant at 6.2% versus 0.9%. So in the time window period within 4.5 to 9 hours, again 35.4% improved with IV RTPA. And so they concluded that patients with ischemic stroke and salivary brain tissue, the use of IVTP between 4.5 to 9 hours onset or at the time the patient above with stroke symptoms resulted in a higher percentage of patients with no or minor neurological deficit than the use of placebo. And this was followed by a meta-analysis by Bruce Campbell group, and they showed that the conclusion was the patients who had stroke with unknown time of onset with diffusion flare or perfusion mismatch, intravenous alteplase resulted in better functional outcome at 90 days than placebo. And a net benefit was observed for all functional outcomes despite an increased risk of symptomatic hemorrhage. And although there were more deaths with alteplase than placebo, there were fewer cases of severe disability or death. And with this meta-analysis and the extent trial, European Stroke Organization gave the 2021 recommendation for patients with ischemic stroke of 4.5 hours to 9 hour duration. That is a non-onset time. It's not a wake-up stroke, it's a non-onset time. And with CT or MRI co-perfusion mismatch, and for whom mechanical thrombectomy is either not indicated or not planned, we recommend intravenous thrombolysis with alteplase. So it should be a non-onset. We are not planning for a mechanical thrombectomy, then we can use IVTP. And the mismatch was the same in the extent trial, infarct core volume less than 70 ml, and the ratio between critically hypoperfused volume by the infarct core volume should be more than 1.2, and mismatch volume was more than 110 ml. So these were the trials which increased the window period for our IVTP. Now coming to the anticlimax, we started with the INS RTPA, which shattered our concept of nihilistic approach to a treatable disease. Now we are trying to avoid RTPA now. This was the 2021 article, the SKIP randomized trial in the patients undergoing mechanical thrombectomy without or with intravenous thrombolysis. What is the functional outcome? We wanted to show mechanical thrombectomy as a standalone is superior to IV RTPA plus mechanical thrombectomy. But unfortunately, the results, it was a last study. The functional outcome was 59.4 in the mechanical thrombectomy alone group compared to 57.3% in the combined IV TPA plus mechanical thrombectomy. But the odds ratio was not significant. And they concluded that the findings failed to demonstrate non-inferiority of mechanical thrombectomy alone compared with IV TPA plus mechanical thrombectomy. And the wide confidence intervals around the effect estimate also did not allow a conclusion of inferiority. So it's not superior, not inferior. So till now, we should use IV TPA even if you are considering mechanical thrombectomy. Thank you for the patient listening.
Thank you, Dr. Sinchu, for the excellent, comprehensive, and crisp talk. It was a journal blast on the landmark trials of stroke. So I thank you once again for the effort you have made to prepare these slides and make it simple and interesting for the delegates.
Thank you, Sandhya.
Thank you. Thank you.
Okay, bye.
Bye.
Thank you, sir, for such a comprehensive talk. Now, I'd like to introduce our next speaker, Dr. Syed Amir Pasha, sir. He has done his MBBS from Kurnool Medical College, his MCH Neurosurgery from Nizam Institute of Medical Sciences, and he's currently the senior consultant neurosurgeon with 24 years of experience in this field. Sir is the head of the department for neurosurgery at Deccan College of Medical Sciences, and he has multiple research papers and book chapters to his credit. Sir, I welcome you to the session.
Thank you, Reshma, for the nice introduction. Good afternoon, all the delegates. I would like to thank Sandhya, Reshma, and the other organizing committee members for inviting me to give this lecture. I feel I am the odd man out. Among the neurologists, I am the neurosurgeon here in this session. I would like to share my screen. Am I audible?
Yes, sir.
Yeah. Yeah, can you see my slides?
Yes, sir.
Hello? Yeah.
Yes, sir.
My talk is on hemorrhagic stroke. I would like to give a surgeon's perspective. Actually, Dr. Sandhya asked me to talk only on the decompressive craniotomy, but I thought because that will be too small a topic, I thought I will give a comprehensive outlook of the like all the surgical options in this catastrophic stroke. Hemorrhagic stroke is very lethal stroke, almost amounting to more than 50% mortality over an year. It is it accounts to almost 18 to 20% of all the strokes in the Asian population. And in the Western population, it is around 10 to 15% of all the strokes. See, look at the spectrum of the presentation. See, it can be a simple basal ganglionic hemorrhagic stroke here, or it can be a basal ganglionic predominantly involving the caudate nucleus with intraventricular extension, or it can be predominantly intraventricular or purely intraventricular hemorrhagic stroke. It can be a basal ganglionic stroke with intraventricular extension and predominantly involving the thalamus and the globus pallidus. It can be just a lobar bleed, or it can be just a lobar bleed with intraventricular extension. And then in the posterior fossa, which is more catastrophic than the supratentorial hemorrhagic strokes, it can be only in the cerebellum, or it can be just occupying the brainstem, which is more catastrophic than any other kind of hemorrhagic stroke. If you look at the main cause of this hemorrhagic stroke, 80% of the times it is small vessel disease, mostly the deep perforator arteriopathy secondary to hypertension or atherosclerosis, or it can be because of the cerebral amyloid angiopathy. And 20% of the times, these hemorrhagic strokes can be because of the macrovascular bleeding, because of various reasons like aneurysms, arteriovenous malformations, AV fistulas, or cavernomas also. And I just want to give a brief outlook. Like, it is very important for a surgeon when a surgeon looks at a hemorrhagic stroke, his intention will be how early the intervention should be. And he should be able to assess whether this hemorrhagic stroke is going to be stable or the clot is going to expand further, and what is the possible reason for this stroke. And this is a nice modified Boston criteria, which indicates cerebral amyloid angiopathy when there are there is a probable criteria and the possible criteria with like multiple lobar hemorrhages and the cortical and the subcortical or cortical subcortical combination small hemorrhages, and cortical superficial focal or diffuse siderosis. And then on the non-contrast CT scan, if there are finger-like projections of the hematoma, or if there is associated subarachnoid hemorrhage, they're usually indicative of cerebral amyloid angiopathy as the cause of the hemorrhagic stroke. And then if the initial acute CT angiogram at the time of presentation after stabilization of the patient yields a macrovascular cause, the diffuse DSA will have a high yield in picking up the source of the macrovascular bleeding. And like the standard medical care, even the surgical management has a great role in the initial part of the management of the hemorrhagic stroke. That is like in the first 48 to 72 hours. When we are dealing with hemorrhagic strokes, there are certain factors which are modifiable and there are certain factors which are not unmodifiable. The lot of importance should be given to the modifiable factors because the management of these factors will have an impact on the outcome of the treatment. The main modifiable factors are like elevated blood pressure, the associated anticoagulants or the antiplatelets. When there is associated hydrocephalus secondary to the massive parenchymal bleed or intravascular bleed, and when there is a high risk of hematoma expansion, and the evidence of macrovascular bleeding. Because managing these modifiable factors is very important, because more than 47% of these patients with hemorrhagic stroke are mostly going to deteriorate in the first 24 hours. And clinical deterioration in these cases is equivalent to very, very poor functional outcomes. So as I said, the non-modifiable factors are not, there's nothing much we can do about it. This is the age and the volume of the clot and then the location of the intracerebral hematoma. Volume of the hematoma is very important because along with the location of the clot, the volume of the clot forms two main predictors of the outcome. And hematoma, which is more than 30 ml in volume, is associated with unfavorable outcomes. And a combination of volume more than 60 ml with GCS of less than 8 has a more than 90% predicted 30-day mortality. And hematoma, which is more than 150 ml, usually is associated with high mortality, like it is equivalent to the death of the patient. And see, why hematoma expansion is very important in hemorrhagic strokes? Because the primary brain injury occurs at the time of the bleeding, when the hemorrhagic stroke happens. That happens in 2/3 of the patient. But in the remaining 1/3 of the patients, it is the hematoma expansion which further decreases the functional outcomes. And this expansion usually happens in the first 24 hours of the hemorrhagic stroke. And when do you call that hematoma has expanded? If there is a more than 33% increase in the volume of the hematoma, or a more than 6 ml increase in the volume of the hematoma compared to the baseline hematoma size. And in intraventricular hematoma, it should be more than 1 ml increase. And if there was no intraventricular hematoma at the time of presentation, but the delayed imagiology is showing intraventricular bleed, that is considered as hematoma expansion. And like in ischemic strokes, even in hemorrhagic strokes, time is brain, because the first 24 hours, 48 hours, a lot of things are happening even in hemorrhagic strokes. Even though we are not losing millions of neurons like in ischemic stroke, but we are losing the scope of improving the functional outcomes in the first 24, 48 hours. And what are the factors which mainly affect the hematoma expansion is time from the onset of the symptoms, like from the ictus to the baseline imaging, and the volume of the clot at the time of the baseline imaging, and associated antiplatelets and the anticoagulant usage, and high blood pressure. These are all the factors which are indicative of hematoma expansion. And though there is no much statistical significance to these signs, there are some signs on non-contrast CT and on CT angiogram, which can give us an idea about the hematoma expansion possibility. Like blend sign here, you can see that there is the hypodense clot here, hypodensity, which is like blending with the hyperdensity here. Or there is a black hole. There is a hypodense area which is surrounded totally by the hyperdense clot. Or the island sign. There is a primary clot, and then there are 3 islands which are not connected with the primary clot. If there are more than 3, that is around 4 islands, but connected with the main clot, central main clot. This is the island sign. And if a patient, if CT scan is showing more than one of these features, that is considered as expansion prone hematoma. And on the CT angiogram, if there is a focal hyperdensity within the hematoma, it is more indicative that these hematomas are going to expand. So at least this gives an idea about hematoma expansion and then the possible early intervention by the surgeon, though it doesn't have much statistical significance. As we discussed already, the surgical intervention along with the standard medical care has a definite role in the initial part of the management, that is in the first 1 or 2 days of the hemorrhagic stroke. And though medical treatment is considered as the standard treatment for most of the hemorrhagic strokes, the surgical intervention has a role, but its indications and the clinical benefits are controversial. Let us go into the statistical evidence, like how bad it is or how good it is, and how early these interventions should be taken up in the hemorrhagic stroke management. And when you hypothetically think, when there is a hemorrhagic stroke, when you do surgery, you end up removing a clot. Thereby, you will be reducing the volume of the clot. You will be reducing the intracranial pressure, and that gives a chance to restore the cerebral architecture, and then improving the cerebral perfusion pressure also. And this also gives a scope to avoid the secondary cascade of secondary brain injury because of the degradation products of blood products. And mostly, as we already discussed, the treatment modalities are non-surgical in hemorrhagic strokes. And particularly in this set of scenario, like a patient presenting with hemorrhagic stroke where the patient is minimally symptomatic and the GCS is more than 10, and if there is a brainstem hemorrhage which is not very suitable for surgery, and there is a high ICS score, and the dominant hemisphere is involved with a GCS less than 5, and the patient age group is more than 75 years, and the site of the hematoma is in the basal ganglia, including the caudate nucleus, globus pallidus, or thalamus. And the other scenario is like surgery will not be advised when there is very rapid clinical deterioration and the situation is hopeless, and when there is irreversible neurological damage and the hematoma size is very massive, like critical size is more than 85 ml, and 150 ml volume of the hematoma is generally sentenced as a inevitable death. And surgical intervention is well advised in the scenarios like there is hemorrhagic stroke with midline shift and herniation, and the volume is moderate, like 10 to 30 cc, and the site of the hematoma is in the lobar location, and cerebellar bleeds, and patient is relatively younger. These scenarios will have a better outcomes if there is surgical intervention as early as possible. And when you compare the volume of the hematoma with the intracranial volume, surgery is usually advised when the hematoma is 8 to 12% of the intracranial volume. And when the volume is around 4 to 8% of the intracranial volume, based on the clinical status and the at the time of the presentation, will be a deciding factor whether to advise surgery or no surgery. And if the volume is more than 12%, surgery will not be helpful. And if the volume is less than 4% of the intracranial volume, no surgery will be required. The aim of the surgery is basically to improve the functional outcome and to decrease the mortality. I would like the delegates to remember these two things, because in most of the trials, these two things are assessed in comparing the conservative line of management and the surgical intervention. And the aim also includes the avoidance of the secondary brain injury cascade by decreasing the blood degradation products. And when you think about surgical intervention, there are several options. Like the standard approach is craniotomy with hematoma evacuation, or a decompressive craniectomy with or without hematoma evacuation, or external ventricular drainage, and then minimally invasive approaches. Like in any other surgical approaches, the minimal invasive concept is picking up even in the management of the hemorrhagic stroke, and there are a lot of trials going on with minimal invasive approaches. The minimal invasive approach can be an endoscopic just aspiration of the clot, or a stereotactic guided aspiration, or combination of endoscopy and stereotactic aspirations with the thrombolytics, or an ultrasonic morcellation. These are all the evolving techniques in the minimal invasive approaches. I would like to just show some of my cases where we did craniotomy. We intended to remove the clot and replace the bone flap, but because the brain was very tense, we decided not to replace the bone flap here. And similar was the situation with the other case also, where we removed the clot and the bone flap could not be replaced because there was a lot of pressure in the brain. Yeah. My slides are stuck. I'll just follow this one. Yeah, this is another case where the clot was evacuated and the bone flap was replaced as the brain relaxed once we removed the clot here. And I think I will skip this projection because it is getting stuck with this projected. I think this will be comfortable just to carry on like this. Yeah, this is the perioperative picture where we removed the bone flap here and the dura is open here. You can see
sorry
how
to
much
interrupt you. You have another 5 minutes for the presentation, sir.
Oh yeah. Okay, now then you can see how much of pressure is there in the brain, and this is all like once we removed the clot, taking advantage of the sulcus or the Sylvian fissures, the brain is pretty relaxed here. And then this is the minimal invasive approach where a catheter is placed into the clot, and then thrombolytics can be used to evacuate the clot here. And then craniotomy, as I said, is the most common strategy and most studied approach. Even though a randomized control trial was taken up in 1961 by McKessock et al., this topic is still of hot debate, and there are a lot of controversies involved in this, in the indications and in the outcomes also. I will go into the depth of all the trials and the statistics. This is a small retrospective analysis of we did studying 12 patients with decompressive hemicraniectomy and clot evacuation. And we could see that this is a life-saving procedure, and it improves the unfavorable outcomes, particularly in a select group of young patients with right-sided hemorrhagic strokes. And then the Stitch 1 trial, which is the largest randomized controlled trial to date. And here the early hematoma evacuation or the conservative management were compared. And the surgery was done within 24 hours of randomization and within 72 hours of the ICTUS. It concluded that there was no much difference in the 6-month favorable functional outcome or mortality. But a subgroup analysis has shown that superficial lobar hemorrhagic stroke demonstrated an 8% absolute increase in the favorable functional outcome. To study this group, The same authors took up the Stitch 2 trial. I'll skip this. Yeah, in the Stitch 1 trial, as I told you, the trends, there was no statistical significance, pointing to a possible better outcomes in craniotomy group, particularly in patients with GCS 9 to 12 and the lobar hematomas, and the clot is nearer to the cortical surface. In patients with GCS 5 to 8, they tended to do better with the medical management. And Stitch 2 trial was taken up by the same group just to expand the data on the subgroup where there was some amount of benefit with the surgical intervention. They recruited around 601 patients with superficial lobar hemorrhagic stroke with a volume of 10 to 100 ml with the location very nearer to the cortical surface. Here they have shown that the functional outcome was not significantly different between the two groups, and the trend of decreased 6 months mortality was seen in the surgical group. When you look at the weak points of the Stitch trials, there is a large crossover from the conservative group to the surgical group that might have affected the overall statistical analysis. And the neurosurgeon was unsure about the clinical benefits of either surgical or the conservative line of treatment. And if the crossover from the conservative group to the surgical group has not happened, probably the statistics might have been bad in the conservative group itself. So in the Stitch 2 trial, so the strong points of the Stitch trials are like they are well powered and well designed and multicentric and multinational trials. And there was a good follow-up, and the surgical group was limited to patients who had early surgery. That was a very important criteria in the surgical intervention. When there was a meta-analysis including Stitch 2 trials and another 15 trials, there was a possible benefit of early surgery. And then this switch trial is still ongoing trial with decompressive hemicraniectomy in intracerebral hemorrhage with or without clot evacuation. And it was likely to be concluded in 2020, and results are expected in 2021. The primary outcome was like functional outcome was to be assessed, and the secondary outcomes of mortality and dependency and quality of life have to be assessed in this trial. And coming to the minimal invasive approaches, this is the first randomized control trial which was taken up in 1989. 100 cases with more than 10 ml volume operated within 48 hours. And there were higher rates of favorable outcomes in the interventional group compared to the conservative group. And the ICSC trial, this is like the same kind of trial where imagological guidance was taken up to guide the endoscope into the hematoma. And the study was not powered to assess functional outcome and the mortality, but there was not a significant higher rate of favorable outcome compared to the conservative group here. And then MISTI trials came up. This is a pilot study just to demonstrate the safety and feasibility and efficacy of the minimal invasive techniques in the hemorrhagic stroke. And that was compared with the conservative group. This is the phase 2 trial. 96 cases were taken up. 54 was assigned to surgical intervention and 42 in the conservative group. And the ultimate goal here was to achieve a clot size of less than 15 ml. Here, along with the MISTI, the Altiplase was also utilized. And that was given like 0.3 milligram or 1 milligram every 8 hours, up to maximum of 9 doses, or when the clot size has come down to less than 15 ml. And the 30-day mortality, the symptomatic bleeding, or the cerebral infections were almost the same in the two groups, but asymptomatic hemorrhage was more frequent in the interventional group. And then the phase 3 MISTI trial came up with more centers included, and the dose of alteplase was limited to 1 milligram every 8 hours to maximum of 9 doses. And 506 patients were randomized, and the protocol was the same. And in the conclusion, it was a safe procedure, but it has not shown much improvement in the long-term functional outcome with the surgical intervention. And a meta-analysis including these MISTI trials was evaluated by MRS, or the extended Glasgow outcome scale, at 180 days. But there was no significant difference in the surgical intervention in comparison with the conservatively treated cases. And these are all other ongoing minimal invasive surgical trials. The SCUBA trial, where dry field technique and wet field technique are used, where the visibility of the surgeon in evacuating the clot was better, and even to control a bleeder was also better. And then early minimally invasive removal of intracerebral hemorrhage trial, ENRICH trial, and then the INVEST trial and the MIND trial. These are all ongoing minimal invasive trials. And when you come to the different scenarios, like in intraventricular hemorrhage, the hematoma within the ventricle is a very good independent predictor of poor functional outcome, mostly in 45% of the cases. And EVD is the method of surgical option here to relieve the pressure. Particularly with intraventricular hemorrhage, there is associated hydrocephalus, or there is a large parenchymal bleed with hydrocephalus. The intention is to reduce the ICP to less than 20. In the recent guidelines, it can be less than 22, and improve the cerebral perfusion pressure to more than 60 millimeters. And then the CLEAR 3 trial came up. Here, an intraventricular dose of TPA and a placebo was compared. And here the TPA was given like 1 milligram every 8 hours for a maximum of 12 doses. And when there was a spontaneous intracerebral bleed of less than 30 ml, and an associated intraventricular hemorrhage was there, causing obstruction at the third and the fourth ventricles. There were 500 cases in 73 sites. The study was done between 2009 and 2014. Despite the association between the amount of the clot and clot removal and the improved chances of MRS less than 3, the use of intraventricular TPA did not improve a 6-month functional outcome when compared with the placebo. And when you look at the other options of the management of intraventricular hemorrhage, there are options of putting 2 catheters on either side, dual EVD insertion with or without thrombolytic therapy, or intraventricular fibrinolysis with lumbar drainage, or a neuroendoscopy combined with external ventricular drainage. So meta-analysis of 11 studies where there were 5 randomized control trials in this meta-analysis found that neuroendoscopy with EVD was superior in comparison with EVD with the thrombolytics, either in terms of mortality or evacuation of the clot, or the favorable functional outcomes, or the requirement of the ventriculoperitoneal shunt. And when we are dealing with anticoagulant associated hemorrhagic stroke, reversal of drug effect is crucial in the scenario where surgical procedures are required particularly. And platelet transfusions are not indicated in antiplatelet associated ICH unless there is a surgical procedure which is foreseen, which is going to be a must. And cerebellar bleeds, most of these decisions are based on the retrospective analysis of the data. But the current management is like controversial. There are certain indicators like if the cerebellar bleed is more than 3 centimeters, there is an indication of surgery. Even if the clot size is little smaller than 3 centimeters, but there is brainstem compression and associated hydrocephalus, surgical intervention is advisable. And in brainstem bleeds, medical treatment appears to be the best policy. For larger lesions, which is more than 1.8 centimeters, the outcome appears to be uniformly fatal, regardless of whatever option, either conservative or surgical intervention is taken. And when we discuss about early surgery, how early this surgery should be, the rebleeding is one important thing which has to be looked upon. In 40% of the patients, there was rebleeding when the surgical intervention was taken up within 4 hours of the ictus. And it was around 12% when the intervention was between 4th and the 12th hour of the onset. So the recommendation is surgery should be taken up after 6 hours or more after the ictus, unless there is like a dire emergency and the patient is rapidly deteriorating and there is acute hydrocephalus. When indicated, early surgery might have a specific role and it can be life-saving. And when you look at the intracranial pressure monitoring role with hemorrhagic stroke, there are no randomized control trials, and it remains unclear whether this is going to be useful or not in these scenarios. And there are no specific guidelines regarding the intracranial pressure monitoring in hemorrhagic stroke. So when you look at the whole scenario, there are certain thoughts like why the surgical trials in hemorrhagic strokes are failing. One is because the primary injury happens because of the hemorrhage, which can't be treated with surgery. And then the procedure will be required on an emergency basis, and it is difficult to recruit the patients so early. And an ideal candidate for the trial or optimal timing of the surgery are essential questions that are not yet determined. And many clinicians would consider hematoma drainage as a life-saving measure. In some situations, therefore, patients who are considered to benefit from surgery were enrolled into the conservative group. This changes the scenario of the statistical analysis. And a large crossover, as we discussed in Stitch 1 trial, almost like 25% of the patients, they crossed over into the surgical group. And particularly those patients had large bleeds and poor GCS. Those are all indicators of the unfavorable outcomes. So that is how the statistics of the surgical intervention groups were affected. Imagine there was no crossover from the conservative group onto the surgical intervention group. The statistics with the conservative group might have been worse than the surgical group, and that might have changed the total conclusion of the trial itself. And other problem is like study design, the sample size, and the number of excluded patients. And strict inclusion criteria is another problem where recruitment will be very slow. If you look at a population-based study in association with Stitch 2 inclusion, recruitment, there are like more than 3,000 cases which were excluded because they were not suitable for recruitment. So these are all the problems like why these surgical trials are failing with hemorrhagic stroke. And finally, when you look at the recommendations of American Heart Association or American Stroke Association and the European Stroke Organization, for the majority of patients with spontaneous hemorrhagic stroke, a benefit of surgical evacuation is not established. This has a class 2B and level A evidence. However, surgery can be life-saving for patients with GCS 9 to 12. This has a moderate quality and weak recommendation. And patients with delayed neurological deterioration, the surgical intervention is going to be useful. This has a class 2B and level C evidence. And decompressive craniectomy with or without clot evacuation will help in reducing the mortality in the basal ganglionic deep-seated bleeds with midline shift, and also in patients with refractory intracranial pressure. This has a class 2B and level C. This is the last slide. I'm finishing.
Sorry, sir.
Level C evidence. And regarding the use of minimally invasive surgical approaches, stereotactic or endoscopic aspirations with or without thrombolytics, its effectiveness remains uncertain. This has a level B and class 2B evidence. And patients with posterior fossa hemorrhages with acute hydrocephalus and brainstem compression or worsening neurological status, surgery should be performed as soon as feasible. This has a class 1 and level B evidence. So these are the current recommendations of AHA and ASA and European Stroke Organization. I think that makes it, that gives a little bit good idea about like where we are standing and how we should be planning the treatments and how we should be planning the further trials. Yeah. Thank you.
Thank you so much, sir, for such an elaborate talk. We'll take the questions at the end of the session. Sir,
Yeah.
I request you to please stop sharing, sir.
Yeah.
Now I'd like to introduce our next speaker for the session. Dr. Mohammad Shujauzzaman Bilal. He has done his MBBS from Deccan College of Medical Sciences and MD Medicine from Medicity Institute of Medical Sciences, Hyderabad. He has done DM Neurology from Deccan College of Medical Sciences, Hyderabad. He is currently the Managing Director and Neurology Consultant at SP Cardiology and Neuro Center, Vijayanagar Colony, Hyderabad. He is also the Chief Consultant at Omni Hospitals, Hyderabad. His areas of interest are stroke and epilepsy. I welcome Dr. Bilal to give a presentation.
Yeah, can you hear me?
Yes, you're clear.
Yeah, I'm sorry, I had lost the connection in between, so I'll be just sharing the presentation. Can you see my slides?
Not yet. Yeah, we can see them. Can you please have it on a slideshow mode?
Yeah, it's processing. So can you see the full screen now?
Yeah. Please go ahead.
All right. So at the outset, I would like to thank the organizers for giving me an opportunity to speak on this topic. I think it's a little bit dry topic compared to the exciting topics of treatments and recommendations and guidelines, because still it's a developing field where still research is ongoing, and and the recent article published in 2021 February, it stated that are we there yet? So that was the title of the publication in Frontiers of Neurology. So that was that kind of summarizes. We are still not completely there with a biomarker that can accurately detect an ischemic stroke from a hemorrhagic stroke differentiation, and then the time of onset, the intervention that would be ideal, the risk of hemorrhage and stuff like that. So with that introduction, I would like to start off with the presentation. So the objectives of this talk would be to discuss various categories of available biomarkers, which have been historically, since which are still there, being researched and already been researched. Mechanism of their release into the circulation, a little bit of pathophysiology, predictive value in terms of sensitivity and specificity of these markers, supportive evidence, and also in the end with certain future directions regarding the same. So what is a biomarker? Biomarker is basically in general. Of course, I'll come to the definition, but as this graphic shows, it is basically so as this graphic shows, it is basically a marker for a biological process, which can be a physiological process, pathological process, pharmacological ongoing process inside the body. So it's basically it's a marker. It is usually the blood is preferred to measure the biomarkers because it is an easily accessible fluid. Now coming to the NIH definition for biomarker, a characteristic that can be objectively measured and also quickly measured. That is another thing which I would like to add, and evaluated as an indicator of normal biological processes, pathological processes, or pharmacological responses to therapeutic intervention. Of course, so basically it's a marker for a process, marker for some question. It helps in answering a question by showing the status of a tissue in the body, sort of. So what would be an ideal biomarker? So this is just the introduction to a biomarker. An ideal biomarker would be specific, sensitive, and predictive, meaning that it should have a it should release proportionate to the extent of exposure, give indication of reversibility, and has a long half-life in tissue so that it can be measured. And it should be robust, like rapid, simple, accurate, inexpensive. All these things should be very important, because most of these stroke biomarkers, particularly as was being told by the previous speakers, that the earlier the better. So in stroke, that's the paradigm. So we have to detect something really quickly, and turnaround time should not be much. So why do we need a biomarker in stroke? One thing is it helps in it can help in first is detection of stroke, because certain centers or certain peripheral areas may not be having scanning available right away, or they may not some people may not be able to afford that. So a lesser cost and reliable marker which can be quickly measured in blood is the primary requirement. And what it can do is further indicated in this slide. It can first thing is differentiation of hemorrhagic versus ischemic stroke. That is what we desire from a biomarker. And then to prognosticate our stroke patients so that we can accordingly plan the therapeutic interventions. Like if we know that this particular patient is going to bleed once we give the thrombolytic, we would that would completely simplify the thrombolytic therapy. So we would not obviously give that particular patient who is going to bleed. We are not going to give the therapy. And then if repeated measurements can be made, of course it can. This is the other thing. It shall be able to indicate the time of onset of stroke. So it can be like we are now using the tissue biomarkers. These I would mostly be concentrating on the blood biomarkers, because tissue biomarkers have already come in the mainstream. They have already been talked in the previous presentations about how we can detect the perfusion and diffusion and mismatch and everything. So I would be mostly restricting the blood biomarkers, which shall be able to, like the desire is that they should be easily accessible, and they should be rapid and cheap. Now challenges, of course, now that we are already, as we would think that cardiologists have already got their biomarker in the form of troponin I and troponin T and such. So, but then we would think that why stroke still doesn't have a biomarker, even though strokes are equally important in terms of morbidity and mortality. So, of course, a lot of research is undergoing, but the research is not 100% positive, because there are certain limitations, there are certain hurdles. Like stroke is not a simple muscle damage. Of course, simple might offend the cardiologist, but it's not a muscle damage. It is a very heterogeneous tissue where it is also a very complicated circulation system where large arteries, small arteries, and perforators and everything are there. So that is heterogeneity of stroke. Then presence of blood-brain barrier, and then complexity of brain injury. Individual markers lack sufficient sensitivity and specificity. So of course, there are quite a few markers which are sensitive and specific, but turnaround time of the markers is high. So that one or the other things usually limits the usage in the bedside. So it is a bench to bedside sort of course, we have not really come in the bedside, I think, with the markers yet. So of course, this is a very complicated sort of a slide, but then I would like to I would like you to concentrate on the red circles where I have marked certain markers which are specifically common, which are extremely common in any of the parameters or most of the parameters that we are trying to ascertain here. Like if you want to differentiate between stroke and controls, there is a marker called S100B and neuron-specific enolase. Then S100B also helps in differentiation between ischemic stroke and bleeds. And then, so first of all, whether it is a stroke or not, then is it an ischemic stroke or not? Then what is the risk of hemorrhagic transformation? There also S100B, neuron-specific enolase, MMP9. So the basic like what I want you to get out of this slide is that there are certain markers which are extremely common, and most of them are actually the markers of neuronal or glial injury, and they are there everywhere. Like they indicate almost all the parameters. And another thing I want you to get out the out of the slide is what all we can determine. So we can differentiate between stroke and the controls. These are the potentials of a biomarker. Stroke, whether it is a stroke or not, whether it is an ischemic stroke or not, what is the risk of hemorrhage if we give RTPA, if we give thrombolysis, what is the, which patient has a hemorrhagic volume, which patient has a stroke in, severity, what will be the outcome, and like what is the duration of stroke, what is the risk of early neurological deterioration, and what is the risk of malignant edema, thereby who may require decompression, who may not require decompression. So all these things. So, and stroke etiology as well, like D-dimer, CRP, and of course we'll go through all those. Now, this is a very important pathophysiological slide, which sort of summarizes the entire stroke pathology, the things involved in stroke pathology into one slide. So these, for example, what are the things? So there is the blood vessel is there. As you can see at the bottom, this is the blood vessel which can get blocked. Then there are pericytes. Then there are astrocytes, which again, as I told you, S100B, MMP9, GFAP. These are markers released from astrocytes. Like neurons release neuron specific enolase. Oligodendrocytes also release MMP9. Microglia. So MMP9 is actually a pan glial marker sort of. So it's released by most of the glial cells like microglia, oligodendrocytes, and astrocytes. And neurons release NSC, and then blood markers. Of course, we use a lot of. We sometimes use blood markers, but none have been properly, easily available at the bedside. Like CRP, D-dimer. These are commonly available, but then CFN, that is C. So we'll come to the names. CFN has been is a significant marker in the blood. So then potential biomarkers, and again with respect to markers of specific injury, markers of neuronal or glial injury are brain type neurotrophic growth factor. But here I would like you to concentrate on a few. Like markers of neuronal injury, important ones are neuron specific enolase, and then glial fibrillary acidic protein, GFAP. So GFAP and NSE are important markers of neuronal injury. Also S100B, S100 calcium binding protein B. This is also a very important marker of neuronal injury. Now, markers of this we don't usually use, pathophysiological stress. Markers of endothelial function, sometimes we use homocysteine, but then nothing much is commonly used here. Nothing important as far as the status of trials right now is concerned. Markers of inflammation, sometimes we may be end up using CRP, ferritin, interleukins, and amyloid in leads. Now, markers of coagulation function, D-dimer and antithrombin 3, all these things we end up using in cases we suspect there to be any coagulation abnormalities. And then markers of cardiac function in embolic stroke, there has been some role of markers of cardiac function like BNP, NT-proBNP, and troponins. So coming to the individual biomarkers and their detail a little bit. S100 calcium binding protein is S100B as it is denoted as. So it is an astroglial protein that has been studied as a serum marker for cerebral injury and disruption of blood-brain barrier. So single center studies have suggested that at S100 levels measured at multiple points after stroke were predictive of malignant course and a larger infarct volume. So larger the tissue damage, larger the marker that is going to be released, and also independent factor for hemorrhagic deterioration. Stroke again. So where does S100B come? It is coming from the astrocytes. So the numbers, the sensitivity, specificity, the specific numbers regarding an S100B. So S100B in the differentiation of ischemic stroke and ICH, differentiation between ischemic and hemorrhagic stroke. As you can see, the sensitivity is pretty good, but specificity is a little less. But still, it is sort of respectable. You know, as you can see, this is also important when we can measure the marker, when it is indicative of a tissue damage. So sometimes because of the blood-brain barrier, the markers get released later into the circulation, and that has been a very major hurdle in the stroke marker trials. So other things like differentiation between stroke and mimics, risk of hemorrhagic transformation, pretty good sensitivity. It can detect a patient who would bleed, you know, after RTPA, and then risk of malignant edema. Sensitivities are good, specificities are on a little lower side because other tissues might be releasing the similar markers. Now, neuron specific enolase. So it's an enzyme released after neural damage, and has been you know, studied as a marker for multiple things like cerebral infarction, HIE, and evaluation of these and prognosis. So overall, of course, the data in terms of numbers, we'll see that later. But systematic review of 12 studies, for example, has you know, it had a pretty good N number, and it showed that even though serum levels were elevated in patients compared to controls, correlation with infarct volume and correlation with degree of neuronal deficit was all these things were there, but then still, you know, because of limitations in the time duration of measurements, in the availability, in the assays, with cost of the assays, all these things are still very significant. Bottom line in the review article was that these markers, even though they might be looking promising, the time of measurement of these markers is usually quite high. So you have to measure within 1 hour or within as soon as possible, preferably in a stroke, that whether it is a stroke or not, whether it is ischemic or not, all these things. Now coming to source of.
Sorry to interrupt you. You have just 5 minutes left for your presentation.
That's okay. That's fine.
Thank you, sir.
So coming to the neuron, NSE is released from the damaged neurons. So it has a higher sensitivity expectedly because neurons are definitely getting damaged, but the specificity is a little less. Now coming to the numbers, sensitivity in detecting a favorable outcome of RTP administration is 77%, but specificity is slightly on the lower side. And of course, within 4.5 hours of symptom onset, there is a cutoff value. So still we can use, but specificity is a little less. Now, cellular function one. So CFN, glycoprotein primarily produced by vascular endothelial cells, C fibronectin, okay, CFN. So it is it has some potential in predicting the risk of hemorrhagic transformation after IV TPA, but rapid assays are not available. So it has that limitation. Of course, as the research progresses, and of course, I think this lecture should hopefully, I hope it makes some people take up the research in terms of making these markers more accessible and also faster. So CFN, it is released from the blood cells and proteins. So CFN has very good sensitivity and relatively good specificity in predicting the risk of hemorrhagic transformation. So if the CFN is easily available, suppose it is faster, available within 3 hours of stroke onset, it is very good because sensitivity of 100% it can predict whether RTPA will cause a bleed in that patient or not. Now, risk of malignant edema also is being shown pretty well. So after that, coming to the biomarker panels. So individual biomarkers may lack sensitivity. So what about panels, multiple biomarkers? So in a systematic review, Whiteley et al. Identified 7 panels of biomarkers tested as ischemic stroke diagnostic tools. So those were considered to be eligible or useful. Main criticisms were multi-marker panels studies does not provide regression equations for stroke prediction, and then there were a variety of cutoff values and also timings for different markers might be different. So that is a limitation still. And sample collection were outside. Yeah, some of the markers, turnaround time, sample collection time, all these things were beyond 4.5 hours or 9 hours or whatever those stroke desirable times were. So, for example, like the combination of S100, BNGF, VWF, MMP9, and MCP1. If within now, I want you to take this thing out of this slide that these markers, even though they have very good or at least respectable sensitivity and specificity in detecting stroke and controls, stroke, all these things, but then they are telling that at a very delayed time, like 12 hours after symptom onset, 24 hours after symptom onset. Similarly, here 72 hours of symptom onset. So these are panel of genes again, with the faster, PCR assays and stuff. So this, for example, a panel of this 34 genes differentiating between TIA and patient with cerebrovascular disease. This was having a sensitivity of 100% and specificity also, but when is that saying? That is saying pretty delayed after symptom onset. Mean was 35 hours. So till then it might be pretty clear with other investigations what the pathology is. So still promising, but requires further research. Non-specific markers like BNP, NT-proBNP, where indicate cardioembolism, and linearly they were related with BNP and cardioembolism risk. And then CRP is a measure of inflammation. It measures in estimating future stroke risk. D-dimer levels, particularly in cerebral venous thrombosis, and so elevated D-dimer supports cerebral venous thrombosis. Specificity, sensitivity is also pretty good. Cancer hypercoagulability is also indicated with a pretty high specificity by D-dimer. Lipoprotein associated phospholipase A2, LPPLA2, is an enzyme expressed predominantly in leukocytes involved in metabolism of LDL. and diagnostic testing for LPPLA2 is available. It is clinically available, and it has been used in cardiovascular risk prediction. So this also particularly it is having some value in predicting stroke, but still we have been probably lacking behind from our cardiology colleagues in using markers. So important slide, future directions, miniaturizations of assays now make highly sensitive and selective and rapid analytics possible with mass spectrometry protocols. And this can help further, I think within a few years, we might be seeing a good marker for stroke and how many people are going to bleed and what type of stroke it is, what is the time of onset. Hopefully, we are going to see a marker. Now, even nucleic acid biomarkers with quick RT-PCRs show a lot of promise. Nanotechnology offers promise with highly multiplex biosensors, capable of rapid simultaneous analytics of large panels. So final word on this is it has to be concluded that none of the candidate biomarkers reliably and desirably predict the type of stroke and other things which we want to assess. But but that again segues into the point that we definitely require more research in this context. This is the department, this is myself, this is my senior Sandeep, this is Srikant sir, and this is madam, these are DMOs and these are the sisters. So with that, I would like to end the presentation and open it up for discussions.
Thank you so much, Dr. Bilal. I would like to make a special mention. We specially thank you for being able to put up such a beautiful presentation in such short notice. We'd specially like to thank you for that.
Thank you.
Now I'd like to invite our DM postgraduate, Dr. Rinda Rao, for her case presentation.
A very good evening, everyone. So today's topic will end with a case series about 3 interesting cases. So coming to the first case, we have a 35-year-old female patient who presented to our emergency department with complaints of headache, multiple episodes of vomitings, and giddiness since 1 day. Patient even developed 1 episode of generalized tonic-clonic seizure in the emergency room. There was no other significant present history. Her past medical history was significant for oral contraceptive pill use for irregular menstrual cycle since the past 4 months. On examination, patient was drowsy, arousable, obeying commands. Vitals were stable. CNS-wise, there were no specific neurologic deficits. Other system examination was normal. As you can see, the investigation, CBP was suggestive of mild anemia with a hemoglobin of 9.8. Rest of the blood parameters were normal. EEG was done in view of seizure, and it was suggestive of an abnormal background activity with no discharges. CT brain done in the emergency department showed a right temporoparietal subarachnoid hemorrhage. What next? In the background of vomitings, giddiness, headache, as well as a seizure episode, and with a past history of oral contraceptive pills, we were thinking more in terms of CSVT, and an MRI brain with MRV was done. As you can see over here, there are flared hyperintensities in the sulcal spaces in the right temporoparietal region, likely suggestive of subarachnoid hemorrhage, and blooming is seen on case of this SWI. The MRV was suggestive of a right transverse and sigmoid sinus thrombosis. As you can see, the right-sided transverse and sigmoid sinuses are not visible. The course in the hospital suggested patient was started on anti-epileptic drugs in view of a seizure and anticoagulation in few of her CSVT during the hospital stay, along with symptomatic treatment. Patient improved gradually and was discharged on oral anticoagulants, that was warfarin. Oral contraceptive pills were discontinued and alternative mode of contraception was suggested. The coagulation profile came out to be negative. So what is the take-home message based on this case? SAH on imaging can be an initial or sole presentation of CSVT as a seizure. Any new onset seizure can also be a presentation part of CSVT itself. We should have a high index of suspicion for CSVT in a patient who is on oral contraceptive pills presenting with symptoms and signs of raised intracranial pressure. Coming to a second case scenario, a 27-year-old woman, 19 weeks pregnant, with history of migraine headaches, developed severe occipital headache that increased in severity over the course of the 5 days, unlike her usual migraine. Her neurologic examination was normal. MRV showed acute thrombosis of the transverse and sigmoid sinuses on the left, and MRI showed adjacent left mastoiditis. As you can see over here, the T1 image on the axial section shows hyperintensities of the left sigmoid as well as the transverse sinus, suggestive of dural venous sinus thrombosis. The T2 weighted image over here, you can see the left-sided mastoid air space opacification can be seen on the left side, which is indicated by the blue arrow. And the MRV is basically suggestive. As you can see, there's non-visualization of the left transverse sigmoid as well as that of the left internal jugular vein. So the patient was treated with antibiotics and unfractionated heparin subcutaneously until delivery. And then she was switched to adjusted dose warfarin daily after delivery with a targeted INR of 2 to 3. The repeat MRI and MRV was done on follow-up 1 year later. It revealed recanalization of the left transverse and sigmoid sinuses, and the mastoiditis was resolved. Warfarin was discontinued. As you can see, there's recanalization of the left transverse sinuses. This was taken 20 months later. So what is the take-home message in this case? It basically illustrates the transient trigger of both pregnancy as well as mastoiditis in a young woman who later had complete resolution of thrombosis as well as mastoiditis. Infections definitely can increase the risk of CSVT. However, there are no clear-cut recommendations for starting anticoagulation in cases of only infective CSVT, not pertaining to this case. However, many authors propose we should start anticoagulation in such cases. Warfarin is contraindicated during pregnancy, but can be given during breastfeeding. So coming to our final case, this is of a 59-year-old woman with a history of psoriatic arthritis. She had the onset of severe occipital headaches over the course of several days, and she presented to an outside emergency department with multiple times during the week before admission. All of the CTs from these previous visits were read as normal. On the day of admission, the patient presented with worsening headache, visual disturbances, and left-sided weakness. Her neurologic examination showed a normal mental status, but she had a gaze deviation to the right, left homonymous hemianopia, left facial droop, and moderate left-sided weakness. As you can see over here, CT at presentation showed a large right temporal venous infarct with hemorrhagic conversion as well as a mass effect. The MRV corresponding to this shows a thrombosis of the right transverse as well as the sigmoid sinus. Because of the size of a hemorrhage, the extension of the venous sinus thrombosis, and the patient also had a progressive neurologic deterioration, she underwent an endovascular mechanical thrombectomy and balloon venoplasty of the right mid-sigmoid sinus, which resulted in successful recanalization and antegrade flow through the sigmoid and transverse sinuses, as well as the right internal jugular vein. As you can see over here, this is after the procedure, there's flow through the sinuses. So this procedure was followed by an unfractionated heparin drip, and she had immediate improvement of her headache. Her left-sided visual deficits and weakness gradually resolved over the next 3 weeks. So what is the take-home message in this case is basically it illustrates the progression of the cerebral venous thrombosis and the difficulty with recognition of this condition by CT scan until venous infarction with hemorrhagic conversion leads to progression of the neurologic deficits. These interventional procedures are usually useful in patients with rapid worsening of symptoms or lack of response to systemic anticoagulation. Thank you so much. So we'll be taking a few of the questions from our third and the final session. The first question is directed for Dr. Reshma ma'am. The question is why dabigatran cannot be given in valvular atrial fibrillation?
Thank you for the question, Dr. Rinda. Well, this was studied in the Realign study where they compared dabigatran with that of warfarin. So dabigatran was compared with that of warfarin. In this study, in valvular heart disease, they have given multiple explanations as to why warfarin is better than dabigatran. The most convincing one being, whenever we have a valvular heart disease, there will be some tissue injury from which the thrombus is generated. So whenever there's a tissue injury, we have the factor 7 which comes up. So this is a part of the extrinsic pathway in the anticoagulation coagulation pathway. So warfarin will act at various levels. Apart from the common pathway, it will also act at the extrinsic pathway level or the initiation of the thrombus generation. Whereas dabigatran, like we know, it's a direct thrombin inhibitor. So it will act at the level of a common final pathway. So they have proposed that warfarin and only warfarin can be given in these individuals. And one more thing is that if you want to give dabigatran, it has to be given at a very high dose. And that is not feasible practically, because if you give such a high dose of dabigatran in case of valvular heart disease, there will be very high risks of intracranial and other major bleeding. So that was the most convincing explanation from the Realign study. So there is only one clear-cut indication to give only warfarin, that is a valvular AF. Thank you for that question.
Our next question is for Dr. Shrikant Javalkar, sir. Sir, is there any recommendation or role of tracheostomy in a patient with posterior circulation stroke having a post-stroke dysphagia?
Well, there is no clear-cut indication only for dysphagia for the patient to undergo tracheostomy. Basically, it will depend on the level of consciousness of the patient. If the patient is comatose and not able to swallow, then it's possible that he may have silent aspiration leading to complications. So in such cases, intubation is necessary to prevent the aspiration. And if intubation is needed, then of course the tracheostomy would be the next step. Next, coming to a patient who has only dysphagia, but he is fully alert, then I think the indication for tracheotomy is less convincing. I would prefer that if the patient has persistent dysphagia, first we try with Rice tube and gradually increasing the oral feeds. If still the dysphagia is significant, a percutaneous gastrostomy tube will be preferable rather than tracheostomy. So I would say tracheostomy only if the patient has altered sensorium and is likely to have aspiration for tracheostomy after a period of oral tube. Does that answer your question?
Yes, sir. Thank you so much, sir.
Okay.
Third question is directed for Dr. Sinchu, sir. We'd like to know what is the role of IV tenecteplase according to the European guidelines.
Okay, can you hear me?
Yes, sir. We can hear you.
The ESO guideline 2021 says that for patients with acute ischemic stroke less than 4.5 hours with large vessel occlusion who are candidates for mechanical thrombectomy, for whom intravenous thrombolysis is considered before thrombectomy, we can give IV tenecteplase at a dose of 0.25 milligram per kg or IV thrombolysis with alteplase 0.9 milligram per kg. So they recommend tenecteplase more than alteplase in a patient with LVO and who comes within 4.5 hours to our center. But the quality of evidence is low and strength of recommendation is weak. But if the patient has no LVO and if he comes within 4.5 hours, and he is not eligible for thrombectomy, they suggest IV thrombolysis with alteplase over intravenous thrombolysis with tenecteplase. So that means they prefer alteplase rather than tenecteplase if the patient doesn't have LVO, that is large vessel occlusion, and recommend IV tenecteplase over multiplies if the patient has LVO, because the extend IA TNG study clearly proved that tenecteplase is superior to multiplies in cases of large vessel occlusion. But our AHA guideline says that it may be reasonable to choose tenecteplase single IV bolus 0.25 milligram or IV alteplase in patients without contraindications for IV fibrinolysis who are also eligible to undergo mechanical thrombectomy. So both the guidelines now recommend tenecteplase over alteplase in patients who are eligible for mechanical thrombectomy or along with this IV thrombolysis. Is it
Thank
clear?
you. Yes, sir. Thank you so much, sir. Our last and final question is directed to Dr. Amir Basha, sir. Sir, in case of CSVT with a mass effect, what is your opinion or what is your view regarding the ideal timing to go ahead with a decompressive craniectomy?
Yeah, in hemorrhagic strokes secondary to CSVT, the prognosis will be very good with surgical intervention. They make a very good recovery, and surgery should be taken up as early as possible. The moment you see some midline shift and the mass effect, earlier intervention will have very good results.
Okay, sir. Thank you so much. Now I'd like to invite Dr. Reshma ma'am for a final vote of thanks.
Hello.
I would like to thank all the speakers and delegates for making this scientific program a great success. I would like to extend my heartfelt gratitude to our senior consultants, Dr. Shrikant Javalkar sir, Dr. Subhash Kaul sir, Dr. Shravan sir, Dr. Amir Basha sir, Dr. Sapna ma'am, and Dr. Sinchu sir for accepting our invitation and being a part of our CME. And I would like to specially thank our sponsors, Mr. S. Rangarao, Regional Sales Manager for Astera Division of Intas, for putting up such a nice show. Thank you so much. And Mr. S. Rangarao, I invite you to please talk on behalf of Astera Division.
Good evening, everyone. Thank you, Sandhya madam. Thanks for giving this opportunity, and it's been very happy and great privilege to be part of this program, madam. Madam, we at INTAS always extend to offer this kind of assistance and service for the academic initiatives. Thank you very much for your support and trust towards INTAS, ma'am. Thank you. Thank you so much, ma'am.
Sandhya ma'am, please unmute yourself.
Anything, Reshma?
Oh, just I wanted
Hello?
you to Madam, I just wanted you to speak.
Tell. Anything? Hello?
We want to listen from you, ma'am.
Yeah, tell. Actually, I got a phone call. Actually, the certificates dates has been mentioned 3rd August. So actually few certificates has gone like that. Now it will be corrected and they will receive, because now again 350 we have to make it. So all are correct only. Okay, don't worry about that. Yeah, tell, listen, Dr. Revan. Anything you want to tell?
The moderators wanted to listen from you about their hard work throughout the day.
Okay. They have been a big support for me. Dr. Reshma, Dr. Chandra, Dr. Rinda, and all the delegates also, and even the speakers, and especially Subhash Kaul sir. He is continuously there, I think. And even our Shrikant sir. And all the speakers are there continuously supporting me from morning till evening for our team. Thank you very much. It was a success.
Yeah. I would like to put in a word.
Yes, sir.
Yeah, congratulations to all the organizing team. Very nice and very efficient work done. Once again, congratulations to all of you.
Thank you so much, sir.
Thank you, sir.
Welcome.
Thank you, sir.
Thank you, sir.
Same from us. Yeah. Thank you, organizing committee, and it was very well organized. And quality of speakers we need not mention. It was very high. And thank you for making me part of this forum. Thank you, Sandhya ma'am.
I
Everybody.
hope that the ER team, everyone, the senior residents will utilize this academic program.
Yeah, sure.
Okay. Okay. Bye.
Thank you so much.
Bye.
Bye, ma'am.
Bye.
See you.
Thank you.